You are live now, ma'am.
So, good morning, everyone. Welcome to the MP chapter of Women Ophthalmology Society. It's a resident competitive session. Myself, Dr. Shweta Walia, I am professor at MJ Medical College and is national coordinator for these resident sessions. This event marks a significant milestone in empowering the women in ophthalmology. It provides a unique platform for our postgraduate students to showcase their knowledge, skills, and innovative thinking. We owe a great deal to Dr. Mohita Sharma, the visionary behind this initiative, and to Dr. Meeta Joshi for her leadership in organizing MP chapter state level competition. To our residents, today is your day to shine. Your hard work and dedication have brought you here, and this competition is an opportunity to demonstrate your clinical acumen and it is testament to your commitment to excellence. Thank you to our judges, Dr. Ragini Parekh, Dr. Chauhan, and Dr. Shweta Verma for this session, and all the mentors, Dr. Preeti Rawat, Dr. Neetu Kori, Dr. Shreya Thatte Madam, Dr. Pragya, Dr. Sonam, and the organizers for your support. I wish all the participants the very best. Before we start this session, I would like to tell you about a new initiative of WOS, that is the WOS Care Project, in which we are starting a short-term training fellowships at few renowned eye institutes of India under the flagship of WOS at a very nominal registration fees. WOS shall arrange the stay and travel of the candidate. The courses that we are planning to come up with are phacoemulsification, ICL, medical retina, lasers and intravitreal injection, myopia clinic, and dry eye clinic. We shall share the details soon and the registration will start soon. So let's learn and grow together and pave the way for future success. Thank you, and let's begin the competition. Before we begin the session, we have with us Dr. Jimmy Mittal, who is taking up the project Shakti, and she is a great leader in WOS and doing great for Project Shakti. I invite Dr. Jimmy Mittal to present her talk on Project Shakti.
So good morning, everyone. Am I audible to all of you?
Yes, you're audible.
So, good morning, everyone. And I would like to thank Dr. Mohita Sharma, Dr. Shweta, and Dr. Meeta for making me a part of this program. So, as rightly said, Project Shakti is now on, and I'll be sharing a few words about it. So, let me share my screen. Just a moment. So, are you able to see my screen now?
Yes, it is visible, but you have to make full screen. Yes, it's good now.
So, good morning again. So, I'm here to talk about a very important ongoing project of WOS India, which is Project Shakti. It was identified to, see how workplace harassment or challenges are actually affecting the workplace people over there, and also how to deal about the things which are actually happening at the workplace. So, workplace harassment actually exists. It exists throughout all types of workplaces. It is a fact. From simple bullying to outright discrimination, it's important to understand workplace harassment so you can avoid a hostile work environment and have a comfortable and safety at your workplace. So how does harassment affect? They not only affect an employee's productivity at work, her comfort level at work, and safety at work, but also has some long-term effects such as physical and psychological effects, health effects, and financial effects. Not to miss that it also exposes an organization to legal liability if the organization is not able to handle any harassment case presented to it properly. So what are the types of harassment or challenges which we can face at our workplace? While the most basic ones would be verbal, psychological, or emotional trauma, there are also some serious forms such as physical and sexual abuse. So we should remember that all types of workplace harassment are illegal and should be reported ASAP. So workplace harassment can vary from psychological harassment, sexual harassment, third-party harassment, discriminatory harassment, personal level harassment, physical harassment, power harassment by your superiors or your institutional head, and even cyberbullying. So what constitutes workplace harassment? Now, according to the Equal Employment Opportunity Commission, harassment can include offensive jokes, slurs, or epithets or name calling, physical assaults or threats, intimidation, ridicule or mockery, insults or put downs by your superiors or your colleagues, offensive objects or pictures shown to you at your workplace. Anything which is actually hampering or interfering with your work performance is actually a workplace harassment. So why reporting workplace harassment is important? Now you should understand that it is important to report any form of workplace challenge or harassment which you are facing right now, because there may be a history of certain other complaints made by your colleagues previously by the similar offenses by the same person in your institution. So your complaint will not only strengthen your complaint as well as also give a boost to the previous complaints made by the same person. So many organizations have formal policies for reporting workplace harassment, and make sure when you are getting employed at an institution, make sure you check your employee handbook to see how to go about if such a situation arises at your workplace. So Gavin, who's a social activist, has rightly said that it's time to speak up, not only to speak up for yourself, but also for your colleagues. So if you know someone who is being harassed at work, you cannot just lose your job by reporting it yourself, because remember, not only you are protected by law from the person who is harassing you at work, but you're also protected from your employer failing to protect you. It's your moral obligation of the employer to protect you from any kind of workplace challenge. So what should you do if you feel harassed? First of all, you should understand workplace harassment is a serious issue with a lot of gray areas. So you should tread very carefully. If you witness a crime or experience harassment yourself in the workplace, it is your moral obligation to report it. If you're worried about losing your job in retaliation, always remember that there is no need to worry, because you're always protected by the workplace harassment laws. So there should be proactive steps to identify and prevent workplace harassment at every institution, be it a private institution or a government institution. And majority of the companies or institutions should have a person of contact who is easily approachable, so that the victims and witnesses can directly report the harassment situations to, and their anonymity and confidentiality is maintained. So how to report workplace challenges? First of all, you need to decide to speak up. You need to speak up for yourself, take up the issue with your family members, discuss it with your mentors at work, your professional seniors. And if the situation is a grave one, you can also approach a lawyer or a psychologist. Now, you have to be very firm and specific with your approach. Remember, if you are the employer and any employee comes to you and complains about an unprofessional conduct or inappropriate behavior, please ask your employee to describe the conduct more specifically in detail. Keep detailed records of each indiscretion that has happened. For example, the people who were involved in the condition which was happening, what was said or done to you, where and when the abuse had occurred. Document each incident in detail to bring it on record later on if required, the date, the time, and the place of the challenge or harassment when it happened, preferably through written applications or emails, because written evidence is of much more important in the court of law in comparison to verbal or oral communication. So you need to document each thing in written applications. Share the problem with your authorities, your HR, and the Vishaka committee. Vishaka committee is very important and mandatory to be have at every government and private institution. It actually deals with sexual harassment cases directly. And now you have WOS for all of you, who's there to help you out in any case of workplace challenge. So evaluate your workplace policies at least once in a year to ensure they're up to mark. And if anything is required, you can approach the HR for that. So I just briefed you what to do, but what to avoid when facing workplace challenges. Now, 3 important things to avoid when you are facing such a condition. The most important one is do not lose your temper and retaliate or argue with your harasser, because retaliation can escalate the issue further and will often make the matters more complicated. Maybe he's your superior or your senior and you start arguing with him, he can just blame you for indiscipline and take action against you. Instead, so escalate the issue very, very properly to the proper channel and let the HR professionals handle things from there. Secondly, do not complain to your co-workers and co-colleagues, because your colleagues are sailing in the same boat as you. And they do not have much power to change the situation at hand, because they have the same scenario of workplace, and will likely to water down your version of events if they're asked to testify against the senior or the superior. Last but not the least, the most important one is that do not keep quiet. You need to speak up for yourself and report any kind of workplace harassment, and all complaints should be thoroughly investigated. So we have for you Project Shakti. which is having a committee or to which incorporates important and expert panelists with all of us. The panel comprises of senior female ophthalmologists and male ophthalmologists, a lawyer, a human rights activist, a member of the National Women Commission, and a psychologist. Now, what does WOS do when we receive a complaint? We take every complaint very seriously. We investigate every complaint in an unbiased fashion. We share and discuss the situation at hand with our expert panelists. We maintain the confidentiality and sensitivity of the issue, and we also maintain the anonymity of the person who is making a complaint. We'll try not to make any credibility judgments based on the reputation of the person who is complaining or the person accused of harassment. It will be an unbiased inquiry at our end. We'll not assume that the person who is making the complaint is being oversensitive or over-emotional, and will not leave it to the parties involved to work it out. So what will we actually do once the complaint has been verified by our expert panelists and found to be genuine? We then take up the issue with the concerned hospital or the institutional authority through mail and requesting for a formal inquiry and required action against the harasser. We'll also decide if any psychological, legal, or professional help is required in this matter by the complainant. And if yes, we help the person connect with the one required. So WOS encourages a zero tolerance harassment policy at every workplace. Now, why harassment policy is necessary? Because anti-harassment policy will help to deter such future issues, and it will also help to outline methods of use in case such a situation arises. Thirdly, it will help to raise awareness of your intolerance towards such unwanted behavior at your workplace. It also prevents legal liability and also strengthens further such complaints made by your colleagues. So remember, all of us deserve a safe workplace. And please feel free to report any kind of workplace challenge or harassment which you are facing at your workplace at iwosindia@gmail.com. And we'll make sure that your complaint is confidential and your anonymity is maintained. So we at WOS are here for you, and together, yes, we can make a difference. Thank you so much for your patient hearing. Thank you.
Thank you, Dr. Jimmy. In fact, this is one of the things that we all females need to know, and that we have someone who is standing for us in case we have any issues at workplace. And
Yeah.
we are thankful to WOS and to you to take this initiative and leadership in working on this. Thank you so much, Dr. Jimmy.
Shweta. Thank you.
Thank you. Thank you. We have with us Dr. Mohita Sharma, who is Secretary, Women Ophthalmologist Society. She is Director at Tirupati Eye Center, Noida. And she has taken the initiative, and this resident program is the brainchild of Dr. Mohita. And I would like to now call upon Dr. Mohita to tell us where and how we have reached such heights. Dr. Mohita, can we have you on stage?
Thank you, Shweta. And good morning, everybody. So nice to see everybody here. Shweta, you yourself, Dr. Vinita, Dr. Jimmy, and many other faces that I can see. And it's an absolute pleasure. And it feels like we should have a WOS meeting every Sunday morning so that we can start the day on a good note. And the WOS is all about supporting each other. And Shweta, just before she introduced me, she said that it's my brainchild, this PG program, but she's the one who's behind it. So thank you, Shweta, for giving me a credit which I don't deserve. But yes, I think I deserve the credit that I have such a great team with me, that that this team is like amazing team. So we all know that in WOS, it's a different kind of an atmosphere. It's a different kind of an environment. And we just heard Jimmy talk. And so Jimmy says WOS is there for you. But Jimmy is a very passionate lady about this whole project Shakti. I think when she sleeps also, she thinks about how to make Project Shakti better. And that's all because she wants to make lives of all the women ophthalmologists safe and a good work environment. And I'm sure in the next 1 year, she'll be able to achieve that.
Thank you, ma'am.
Thank you, Dr. Jimmy.
Thank you,
thank you for doing this. So now coming to what WOS is doing in 2024, I'll just share a few things. Most of you now know about WOS. It has become a society which is well known all over the country, and a lot of activities are happening. I will go in brief about what is happening now and what will be happening in this year. So for those who are new to WOS, this was established in 2015. We have now almost 3,000 members. There are 22 state chapters which have been launched, and 7 annual conferences have been done. And the next annual conference is the 8th annual conference, which will be happening in Delhi in October. So initial days of WOS, a lot of questions were there on as to why at all WOS is needed. That is when men and women are equal in today's time. So we actually did a lot of surveys, and we actually went into the literature to see as to whether there was a difference existing or not. And we found that there were a lot of differences existing. And this is what this slide is about what the literature says. And literature clearly says that remunerations for women ophthalmologists are lower. If you see them in chairs and conferences and inaugurations, you find that they are much lower. If you see them as leadership in the leadership roles in societies, again you find that the percentage is very low. If you look at first and last authors, if you look at industry ties and funding, you find that all this is much less for women compared to men. In fact, all these figures were quite alarming for us and very surprising, because we never thought that the figures would be so low for women ophthalmologists. And of course, the figures are improving, but still, today where we stand, where 50% of ophthalmologists are women ophthalmologists, we are nowhere near being 50% in our professional lives. And this is what WOS aims to do. And the numbers should keep pace with the percentages also. And as we say, we are equal to men. In fact, we are better than men. So we should have a peaceful coexistence, and yet we should be doing well in our professional lives, equally well as men ophthalmologists also. You are not born to be ordinary, and you are a soul on a mission. And when you really want something, it's because that desire originated in the soul. So WOS is all about you not being mediocre and you not being ordinary, but you being extraordinary in your profession. It's also about not being part of the crowd, though WOS talks about being together so that you come out of your isolation and you start sharing whatever challenges you have with each other, and start working on those challenges. But it also says that while you do this, you should not become a part of the crowd. You should not take a herd mentality. You have to stand out in your own way. So being a part of the crowd is always easy and makes your soul suffer. But the day you decide to be different, that is the day which is written in the stars, a date with destiny. So in WOS, we want that you should be supporting each other, and simultaneously you yourself should be different and extraordinary also. So WOS is all about being different. So we found that there are universal professional challenges, and this all happens because of leaky pipeline, where we all start as residents. The phase that you are in, it is said that whatever is your surgical peak phase, where you need to learn your surgeries, where you need to upgrade yourself more professionally, that's also the phase which is your peak challenging phase as far as your personal life is concerned, because you get married, you have children, so you have some inevitable breaks. So since these two are coinciding, we have to realize that we don't have to go into inertia. We have to come out of our inertia. We have to take smaller breaks and then come out and then restart and be equal to our men colleagues, who today are very supportive to us. So all the programs of WOS are based on mentoring. You are not alone in your professional journey, and they are based on givers gain concept, which means the more you give to others, the more you get. So whenever you attend any WOS event, and whether it's a virtual event or it's a physical event or it's an annual conference, you will find that everybody is in a supporting mode. So there's a lot of givers gain, which means more you give, more you get, and everybody is more in a giving mode. In today's world, where we tend to see people we are only thinking about themselves. WOS has a different environment where everybody is thinking about each other. So this is an old need-based analysis done in the beginning, based on which we started working. And initially, we worked on visibility in conferences, surgical skill enhancement, and help in private practices, because this was the initial requirement that women ophthalmologists wanted. And then we started working on a lot of other things like mentoring, like research, like this Project Shakti, Project Archana, etc., which I'll tell you about. So this is where we started with men as well as women mentors. And these are just photographs where I will go through where we started from this breakfast session. This was the first session of WOS, which happened in Karnataka. And then the story continues with lots of sessions in conferences, individual state meetings, etc., and a lot of virtual programs too. So everywhere, the idea was that we were giving more and more speaker opportunities and more opportunities for somebody to become a mentor and somebody to become a mentee, so that there is a connection for lifelong, and we can pull up each other. So some of the all our conferences are based not just on clinical skills, but on life skills also, where you get to know a lot about life skills too. Our state chapter meetings are also on this year, and last year they have been on skill enhancement. And apart from that, also important topics like women's health, finance management, and research. And you'll find a lot that would be helpful for you. For somebody, something may be helpful, and for others, something else may be helpful. So Project Archana is another initiative of WOS, which is to do with something which is not taught in our medical curriculum, and that is new challenges of dissatisfied patients, angry patients, violent patients, or even mobs. And Dr. Anjali Mehta from Delhi is working on it. She's another passionate lady, just like Jimmy, who's working on this. And this is how you have to deal with such kind of situations and yet be cool and calm. Project Shakti, you already heard about. Our request to you is whenever you come across a situation where you find that there is a workplace challenge, as Dr. Jimmy said, do not retaliate. 3 very important points she said. Do not retaliate immediately. Do not share with your colleagues, but you have to tell somebody and get a solution. And that somebody could be somebody in your institution, and simultaneously, if you're not able to find that solution, that somebody could be Project Shakti of WOS, led by Dr. Jimmy. So if you could do that, it is not that they could give you a solution. There is a team of mentors who could give you a solution as to how you could get over that challenge and you could actually perform better. So it doesn't have to be that you have to be, women's liberation and strike, etc. You have to find a path in your life. It should always be that you have to find a path where you can get over that challenge, and that could be an example to others, maybe anonymous, where if you don't want your name to come, because challenges are common to all. Whatever you may be facing as a workplace challenge, it may be a subtle workplace challenge, or it may be a big sexual abuse. It could be anything. It is not necessary that it has to be a very big workplace challenge, but sometimes small challenges also make a huge impact on your mind, and they actually pull you down. And that is what we want, that you should not be pulled down. You should realize that there are others who have faced these challenges, and once you communicate with them, you may find a very easy solution, and you may find that your professional growth is not hampered, and yet you have kept everybody happy in your organization. We have this Women in Research or WINR group. You are always invited to join this Women in Research group. Now we are working on what is called clinician scientists, where you have to realize that it is not that you can be a clinician and yet not a researcher. In fact, it is your duty and responsibility towards your patients, towards your country, that apart from being a clinician, somewhere research has to be a part of your profession. And WOS shows you the way how being a clinician, you can be a researcher, and you can be a researcher whether you are a solo practitioner, or you're in a group practice, you're in a corporate practice, or you are in an institution which is doing research actively. So WOS has its own ethics committee. For those, it's open to all members, where ethics committee is an obstacle. It holds in between, it holds these research sessions where we teach you how to get basics of how to get started with research. It enumerates all the opportunities related to research, and this is one of those courses. It gives you an opportunity to become a part of rare eye disease group, where we are working on national registries, and it gives you an opportunity for publications in IGU and other journals like this one. This was a read IGU issue, which came out specifically on RED, and it had articles from all WOS members. So not going into the details of RED, It is basically, in brief, it is creating national registries. There are 10 diseases which have been selected. It has started data capture, but you can still be an investigator if you want. And there is WOS Care, Dr. Shweta, your own Dr. Shweta Walia herself, who's a very, very active member of WOS, and very one of the pillars of what WOS, I would say. She has worked on it, and she would be just about starting with this fellowship as well as training program. These are all short term, because we realize that women ophthalmologists many a times cannot do long-term fellowships, or even if they have done long-term fellowships, they would want short-term trainings to enhance a particular skill. So that is an opportunity you can get. Then apart from this, I want to tell you in brief about Women Ophthalmologists Worldwide, which was also started by us and it originated in India, and it has now 29 countries involved. And if you are a WOS member, you automatically become a WOW member too. So you can go to the website of WOW, Women Ophthalmologists Worldwide, and you can just register and you get a complimentary membership there. So do that today. And this is the first annual conference of WOW which happened. And by joining WOW, you become connected to several countries, and you can get an international opportunity, international mentors too. So this is about the conference that happened in India itself in 2022. So this year, 2024, we have been doing sessions in conferences. Thank you to Dr. Tityal and to Dr. Ragini, who were the first ones to give us this opportunity. In fact, now we are invited to hold sessions. So apart from our own state chapter meetings, we do these sessions also. We are doing these resident programs in all the states, which are the state chapters. And so apart from the state chapter meetings, which are happening as physical events. So WOS is an opportunity where women ophthalmologists like you and me can become extraordinary in their profession with the concept of giver's gain. So welcome to WOS, welcome to these PG programs, welcome to Project Archana, welcome to WOS Care, welcome to Project Shakti, welcome to WOW, welcome to Women in Research, welcome to Rare Eye Diseases, and welcome to Annual Conference of Women Ophthalmologists Society, which is happening in Delhi from 4th to 6th of October. It is going to be an experience for you, which you have never experienced before. Those 3 days are full of everything for just you. You will realize it's different from any other conference. There are so many networking opportunities. Normally, as I had written in the group also, you go for a conference, you may meet a few people, and then you come back, or maybe you go with your 2-3 friends and you're all huddled together, and then you come back. But WOS is a place where we make you interact with everybody. When you come back, you will find that you have actually found at least 10 mentors, at least 10 other connections, and they are all willing to help you in whatever way you want. And I have put down the topics also on the right side, because you just to tell you that apart from the clinical courses, we have so many non-clinical courses, and all of these are useful for you. So thank you, everybody, and welcome to WOS. And this is the last slide, which I always want to talk about. I alone cannot change the world, but I can cast a stone across the waters to create ripples. And this is not just for me, it is for all of you. Each of you can cast a stone, and you will realize that you can create many ripples once you're a part of WOS. And those ripples, I believe, this is something that I have added from my side, that those ripples can actually turn into a whole tsunami. And that is what actually WOS has done. So join us at WOS and be a part of the whole journey. Thank you.
Thank you, Dr. Mohita. In fact, everyone would be motivated today to get more involved in the activities that WOS is starting. And I expect all the residents, those who have joined in this session, they will definitely be an active part of all these projects that WOS is coming up with. Thank you, Dr. Mohita, once again. And now I call upon Dr. Niharika Arya and Dr. Pragya Prakash, moderators for our competitive session 1. Dr. Niharika, I would like to take you the charge for this session.
Yes, ma'am. Thank you, ma'am. So now I'll invite Dr. Ragini Parekh, ma'am, the judge, and a small introduction about her, that she is at received the more than 100 Women Achievers Award at the hands of Honorable Shri Pranab Mukherjee, Honorable past Minister, past President of India in 2016, and she worked in government for 29 years at Grant Government Medical College and Sir J.J. Hospital. Now I'll invite Dr. Shweta Verma ma'am. She did her MBBS from the NSCB Jabalpur Medical College in 2005 and PG from MGM Medical College, Indore. Now working as an associate professor in Saraswati Medical College, Lucknow, UP.
Hello, good morning, everyone.
Good morning, ma'am. Good morning.
Thank you, Dr. Niharika. Now I would like to invite Dr. R.S. Chauhan, sir. He is a professor at head in the RAO Rohtak, and he's trained in LVPI at AIMS and the Dudley Hospital, Birmingham, UK. And his area of his interest are cornea and the eye banking. And he has done more than 5,000 of surgeries to his credit. At present, he is a equine president of in Haryana and the president of ROS. So very warm welcome to you, sir. Thank you. So now we will begin our first competitive session. The presentations are of the 4 minutes for the PGs and the 4 minutes is for discussion. So the first presentation is from MGM Medical College Indore. Dr. Ritika Singhal is the presenter, and the mentors are Dr. Preeti Rawat and the Dr. Manushree Gautam. So please, Dr. Ritika Singhal, are you there?
Yeah. Am I audible, ma'am?
Yeah.
Yes.
So before you start, we are always thankful to men who join us in our program. Thank you, Dr. Rajendra Chauhan. And we always believe in peaceful coexistence. And WOS is and the men who join are actually the lucky ones, which WOS team chooses because we know that they are always supportive to us.
Before you
Thank you,
start,
madam.
Ritika,
Thank you.
1 second. This is just a point. The judges will give the points according to the heading. Anyways, the sheets are forwarded to you. The points are given under the headings of first is the way and quality of presentation is of 10 marks. Clinical oment is of 10 marks. Adherence to time is of 5 minutes or 5 marks. Originality and the uniqueness is 10 marks and discussion is of 15 marks. So total you'll get the 50 up. Yes. Now, Ritika, you can start your presentation.
Very good morning, everyone. Myself, Dr. Ritika Singhal from MGM Medical College. Today, I am presenting a case of 40 years old female with chief complaint of swelling and the pain in the upper eyelid of the left eye since 3 months. According to the patient, she was apparently all right 3 months back. Then she developed the swelling in the upper eyelid of the left eye, which was gradual in onset, progressive in nature, and painful. Patient had no history of watering, discharge, redness, pain on ocular movement, headache, diplopia, and other ocular complaint. Patient had already taken oral antibiotics for 10 days but didn't respond to that. No history of ocular trauma, joint pain, fever, cold and cough, shortness of breath, fatigue, weight loss, skin lesions. On the past history, patient had history of similar complaint in the left eye 15 years back, for which she undergone ocular surgery, that is lateral orbitotomy. Patient had previous MRI report of the brain and orbit, which was showing soft tissue intensity mass lesion in the superolateral aspect of the left orbit, involving the lacrimal gland, which was extended up to the orbital apex. Patient was advised anti-tuberculosis treatment after lateral orbitotomy, which was she took for 3 months and then stopped. Patient didn't have any history of the other chronic illness. Personal history was normal. There was no history of similar ocular complaint in the family, but there was a history of the pulmonary tuberculosis in the family of her husband. On the general examination, everything was within normal limit. There was a no palpable lymph node and the stellar right incision was present. On the ocular examination, the distant vision of the right and the left both eye was 6/12, which is improved with the pinhole up to the 6/9. Near vision is N10. But the best corrected visual acuity of the right eye was minus 0.25 ds, that is improved up to the 6/9, and the near eye is plus 1 ds, that is improved up to the N6, and the BCB of the left eye is plus 0.25 ds with plus 0.50 DC with the 20-degree angle, that is improved up to the 6/9, and near eye is plus 1 ds, that is improved up to the N6. Rest of the anterior segment examination of the right eye was within normal limit, and the ocular examination of the left eye, ocular movements were present in the all cardinal gaze. There was drooping of the eyelid present, swelling present at the upper eyelid temporally, that is 4:1 in the centimeter in size, with soft consistency and tender on palpation. Rest of the anterior segment examination of the both eye was normal, except the both eyes have grade 1 posterior subcapsular cataract. When we do the ptosis evaluation, the palpebral fissure height of the right eye was 10 mm, in the left is 3 mm. MRD1 is 4 mm in the -1 mm in the left. MRD2 is 6 mm in the right and 4 mm in the left. Marginal crease distance is 4 mm in the right and the 9 mm in the left. The Bell's phenomena was good in the both. Marcus Ganjo Wicking phenomena is absent in the both. LPS function is 15 mm in the right, 12 mm in the left. Marginal limbal distance is 9 mm in the right and the 2 mm in the left. Eye spec test was negative. Fundus examination was normal of the both eyes. So based on the history and the examination, we reached to the differential diagnosis of infectious rectoidinitis, tuberculoma, idiopathic orbital inflammatory disease, orbital lymphoma, metastatic disease, or orbital sarcoidosis. Here are the table that is showing the differentiating feature. Now we move further. For the blood investigation, all the blood investigation was within normal limit, except the patient has the raised ESR and the CRP. Chest X-ray was normal. Thyroid function test was within normal limit. USG skin of the left eye was showing the left lacrimal gland, and surrounding orbital tissue appears bulky, heterogeneous, with increased vascularity that is suggestive of infective or inflammatory etiology. We has advised the MRI brain orbit, but due to the financial problem, that couldn't be done. Then an excisional biopsy was done, and on the histopathology report, the lacrimal gland which surrounded orbital tissue was surrounded with the mixed inflammatory cell infiltrate, fibrofatty tissue, and the congested blood vessels. So on the basis of that, we reached to the final diagnosis, that is a left eye idiopathic orbital inflammatory disease with severe acquired mechanical ptosis with grade 1 posterior subcapsular cataract. So we give the medical management, that is a IV methylprednisolone 1 gram OD for 3 days, followed by tablet prednisolone 40 mg for 7 days, then taper accordingly. And we with the coverage of the antibiotics, NSAIDs, and the Acelog. Locally, we give the eye drop moxifloxacin and the carboxymethyl cellulose 0.5% QID and eye ointment tobramycin 0.3% BD. Now we can see the post-treatment picture. Now the palpebral fissure height is 7 mm, which was previously 3 mm. So we can clearly see that patient is very good improving on the systemic steroid. Thank you. Thank you.
Okay. Thank you, Ritika. Any questions from the judges? Please discussion. Case is open for the discussion.
The discussion is for 4 minutes, right, madam?
Yes, sir.
Yes, sir. Yes, sir. It is for 4 minutes, sir.
I think it is a nice presentation, and it was quite exhaustive. In fact, the investigation part was quite lengthy, and normally, clinically, when we see that it is probably idiopathic, then we don't go for further investigations. That way, the patient has improved, and it appears to be normally such kind of cases are coming. Good, Dr. Ritika.
Thank you, sir.
Okay.
You said there was no pain. The pain was not there?
No, ma'am, pain was present. It was painful swelling, but no pain on ocular movement, and ocular movements was normal.
Okay. Okay.
Okay.
That was a good presentation.
Thank you, Ritika. Now the next presenter is Dr. Arpita Singh, from the MGM Medical College, and the mentor is Dr. Shweta Walia ma'am and Dr. Neetu. Dr. Arpita Singh, are you there? Dr. Arpita? Yeah, please go ahead with your presentation. Yeah.
Good morning, everyone. Today I'm here to present a case of a 39-year-old female presented to IOPD with complaints of headache since 15 days, seen 2 images of objects, and deviation of left eye since 10 days, and diminution of vision in left eye since 2 days. As narrated
Dr.
by my
Arpita, we are
patient.
not able to see your presentation. Can you share your screen?
Yeah, doctor, not shared.
Yes.
Arpita, share your presentation.
Yes, ma'am.
Yeah, now it is visible. Yeah.
Yeah.
Yes.
Good morning, everyone. Today I am presenting case of a 39-year-old female presented to IUPD with complaints of headache since 15 days, seeing two images of objects and deviation of left eye since 10 days, and diminution of vision in left eye since 2 days. As narrated by my patient, she was apparently alright 15 days back. Then she developed complaints of headache. It was gradual, throbbing type. Initially, the location was frontal, and then it extended to occipital region and aggravates in evening. It was severe and was getting worse with time. It was not radiating to face, neck, and shoulder and not associated with any nausea or vomiting. Since 10 days, the patient is having complaint of diplopia and division of left eye. It was sudden and present throughout the day. The images formed were side by side and was worse when she looks at distance and to the sides and disappeared on closing one eye. 2 days back, the patient developed complaint of diminution of vision in left eye. It was painless, sudden, progressive in nature, and it was more for distance than for near. And since 2 days, the patient is not having complaint of diplopia. It was not associated with pain, redness, watering, photophobia, and there was no any history of similar complaint in past. Extensive negative history was taken and it was all negative. In past history, the patient is a known case of diabetes and hypertension since 4 years and was taking regular treatment for that. Rest of the history was not significant. On general and systemic examination, the respiratory system, cardiovascular system, and gastrointestinal system were all within normal limits. On CNS examination, examination of all cranial nerves were normal except for the sixth nerve. There was no any lymph nodes or temporal artery palpable, and no any menstrual tenderness was felt. On ocular examination, the position of head was normal. The Hirschberg test was performed to see corneal reflex and it revealed 15-degree esotropia in left eye. It was confirmed by a cover-uncover test. Upon evaluating the ocular movements, they were restricted in dextroversion, dextroelevation, dextrodepression, and also restricted in levoversion, levoelevation, and levodepression. Abduction in both eyes were also reduced. Post-duction test was done and it was negative, indicating the paralytical squint. Vision of the patient in right eye was 618, which was not improving with pinhole, and in left eye it was counting finger at 1 foot and PR is accurate. Near vision was N36 in both the eyes. Rest of the anterior segment examination was normal except for the pupils, which were centrocircular and sluggishly reacting to light. On fundus examination, in both the eyes, media was clear. Disc was yellowish to dirty white. Edematous with +6 disc elevation, circumferential blurring of margins, and obscuration of vessels. And in right eye, there were 3 cotton wool spots and splinter hemorrhages present on disc. And in left eye, gliosis was present. Splinter hemorrhage was seen at 12 o'clock. And in both the eyes, venous pulsations were absent. Cup is full. Veins were dilated and tortuous with reduced AV ratio. And in left eye, AV nipping was present. In both the eyes, foveal reflex was present and microaneurysms were seen in all 4 quadrants, indicating right eye grade 4 disc edema with mild NPDR and grade 1 hypertensive retinopathy, and in left eye grade 4 disc edema with mild NPDR and grade 2 hypertensive retinopathy. Coming to the clinical diagnosis of right eye lateral rectus palsy with grade 4 disc edema with mild NPDR and grade 1 hypertensive retinopathy, and in left eye lateral rectus palsy with grade 4 disc edema and mild NPDR with grade 2 hypertensive retinopathy. Then routine blood investigations were done and they were all within normal limits except for the TLC, which was raised, and HbA1c, which was raised. Neurology opinion was taken and they performed lumbar puncture in which the CSF pressure was raised and rest of the CSF composition was normal. MRI brain and orbit was done, both plain and contrast, and there was no any abnormality detected. Different causes for the bilateral lateral rectus palsy and papilledema are brain tumor, dural sinus thrombosis, hydrocephalus, any infectious or inflammatory disease, which were ruled out by normal MRI findings and normal blood counts. So my diagnosis of exclusion is idiopathic intracranial hypertension. So final diagnosis is right eye idiopathic intracranial hypertension with grade 4 papilledema and mild NPDR and grade 1 hypertensive retinopathy. And in left eye idiopathic intracranial hypertension with grade 4 papilledema and mild NPDR with grade 2 hypertensive retinopathy. The patient was managed for raised intracranial pressure with injection mannitol tablet acetazolamide along with syrup oclor, and for control of headache tablet topiramate and naproxen were given. She was continued on tablet telmisartan, metformin, and glimepiride for her systemic conditions, and neurosurgery department opinion was taken and they advised VP shunt for the patient. Thank you.
Thank you, Arpita.
Thank you, Dr. Arpita. Actually, I just wanted to know that since the TLC was very high, and
Yes.
can it be infective because it is idiopathic intracranial hypertension, and patient was managed. Other things were normal, almost normal.
Yes, sir. There may be any infective etiology, but only TNC was raised, and upon doing the MRI orbit and brain, there was no any abnormality was detected. So therefore, the made the diagnosis of idiopathic intracranial hypertension.
But apart from that, it can be due to hypertensive retinopathy, and because there is grade 4 papilledema. And in fact, what happens in microangiopathy due to diabetes and due to hypertension, it might have led to some vascular abnormality in the brain, which was not detected on MRI. But microangiopathy can actually cause at the neurological level, because it was bilateral left rectal palsy.
Yes, sir. So
So
if the neuropathy,
only idiopathic intracranial hypertension may not lead on to bilateral paralysis.
yes, sir, there are many other causes also. For example, if there is any tumor in brain or any vascular abnormality, for example, aneurysm or any infarct in brain, that can also lead to bilateral lateral rectus palsy and papilledema.
I think it was quite challenging case, and you have in fact done exhaustive workup to find out the cause. But anyway, the patient was treated well. Thank you, Dr. Arpita. Dr. Ragini may ask some questions.
Thank you.
Okay. Shweta ma'am, any question? Shweta Verma ma'am?
Yeah. No, you can proceed.
Okay. So now I'll invite the next case present PG, Dr. Himanshi. She is from Saint Arvindo Medical College, and the mentor are Dr. Pragya Prakash and Dr. Sonam Verma. Yeah, Himanshi, you can start with the presentation. Himanshi, are you there?
Himanshi?
She joined, but she is muted.
Okay.
Yeah. Start your presentation.
Start, Himanshi.
Good morning, everyone. Today I'll be presenting. I'm Dr. Himanshi, Junior Resident, Department of Ophthalmology. Today I'll be presenting a case on unveiling the uncommon duo under the guidance of Dr. Pragya Prakash ma'am, Assistant Professor at Department of Ophthalmology. So a 23-year-old female resident of Indore presented to ophthalmology OPD with complaint of left eye diminution of vision since 1 year and headache since 1 month. My patient was apparently all right 1 year back. Then she noticed diminution of vision in left eye, which was gradual in onset and progressive in nature, and headache since 1 month, which was not associated with nausea or vertigo. There was no association with redness, watering, and pain, and no complaint of floaters, foreign body sensation, colored halos, or discharge. There was no history of ocular surgery or trauma, and no history of using spectacles. The patient was on antiretroviral therapy for HIV, and there was no other drug history or long-term illness or no family history. On journal examination, the vitals were stable. The best corrected visual acuity of right eye was 6/6 part, and in left eye it was finger counting close to face. On retinoscopy, there was myopic astigmatism and scissoring reflex was seen in left eye. The NCT was 12 millimeter of mercury in right eye and 40 in left eye. The periorbital area, extraocular movements and eyelids were normal. The conjunctiva and cornea was clear. The anterior chamber depth was normal in right eye and deep in left eye. The iris was normal. Pupil was round and regular, reacting to light in right eye, but the consensual was sluggish. In left eye, there was grade 3 RAPD. There was early lens changes in left eye. On undilated fundus examination, the cup disc ratio was 0.4:1 in right eye. The neuroretinal rim was healthy and FR was present. The CDR was 0.9:1 in left eye. There was nasal shifting of vessels and advanced glaucomatous cupping, and bare knitting of vessels was also seen. The IOP by applanation tonometry was 10 in right eye and 38 millimeters of mercury in left eye. On pachymetry, the central corneal thickness was 478 in right eye and 459 in left eye. The true IOP calculated was 14.9 in right eye and 44.3 millimeter of mercury in left eye. On indirect gonioscopy, all angles were open and Sampuli's line was seen in all the quadrant in both the eyes. In the right eye perimetry, few depressed point was seen in non-edge region suggesting early lens changes. In OCT left eye, there was RNFL thinning in all the quadrant in left eye. In right eye, there was slight decrease in nasal quadrant RNFL thickness. On ASOCT, the concave iris configuration was seen. This is the op scan of left eye showing central corneal power of more than 47 diopter in first scan and difference of more than 6 diopter. And in right eye, the changes were less significant. So our provisional diagnosis were left eye pigment dispersion glaucoma with keratoconus, and right eye it was pigment dispersion syndrome. The patient was advised admission and started on systemic medication. IV mannitol 300 cc was given, followed by tablet acetazolamide and eye drop bromelain plus timolol 12 hourly in left eye. On the above medication, the IOP was 21 millimeter mercury, and then the patient was planned for left eye trabeculectomy. So left eye fornix-based trabeculectomy was done. The surgery was uneventful. On the post-op day 1, the IOP was 11 millimeter mercury. AC was well formed. Surgical PI was patent, and patient was discharged on topical steroid and antibiotics with regular follow-up to examine the progression of keratoconus. On post-op day 7, the IOP was 16. The bleb was formed. AC was formed, and PI was patent. This is the ASOCT showing bleb. So the pigment dispersion syndrome is typically more common in young myopic male. However, in our case, the patient was a young female with significant myopia. In keratoconus, the irregular corneal shape and instability of eyes refractive system may cause increased iris movement, enhancing the shedding of pigment granules from the iris, which then contribute to the clogging of trabecular mesh. The HIV is associated with various ocular conditions like keratoconjunctivitis, sicca, and dry eye, and raised IOP in some occasions, but there's no specific literature directly linking HIV to PDS. So these were the references. Thank you.
Thank you, Himanshi. Any questions, judges?
It was nice presentation. Himanshi has covered it very well, and I think she has covered it in time, 4 minutes. So and the end result was good. The only thing is that because the keratoconus was seen only in one eye,
Yes.
and other eye, that it was incidental finding or it was on routine examination it was found, because normally if the patient is having very high IOP, we usually don't do that OR scan or pentacam.
So basically, we did keratometry in keratometry there, and there was significant difference. So that's why we went for topography in the patient.
What was the age of the patient?
23-year-old, sir. Young female.
23-year-old.
Yes.
So naturally the pressure was very high, so IV mannitol was given, right?
Yes, sir, mannitol was
So
given.
can you tell me what is the dose of IV mannitol?
Sir, it is 1 milligram per kg.
Okay, next you can we can go ahead with the next presenter.
Okay. Now we invite Dr. Sakshi Mishra. She is also from Arvindo, Indore, and her mentor is Dr. Sonam Verma.
कैसे करते हैं? Yeah.
Dr. Ragini Parekh has joined.
Hello. Sir,
Dr.
actually,
Ragini Parekh has joined.
Hello. So,
I think she has not joined. Dr. Ragini, madam.
Sir, actually, her father is ill. He's admitted.
Okay.
So, Dr. Shweta Verma and you are the judge.
Okay, fine. Thank you.
Sir. Thank you.
Good morning, everyone. Today I'll be presenting a case of recurrent ptosis.
My patient, 16-year-old female resident of Indore, came to same OPD with her aunt. They complained of drooping of upper eyelid of left eye since childhood, which was insidious in onset, gradually progressive, and was present since childhood and associated with diminution of vision. She was not complaining of similar complaints in the other eye. There was no complaint of diplopia, ocular trauma. There was no history of generalized weakness or stiffness in body, and there was no history of variability. There was a history of lid surgery in the left eye 10 years back elsewhere, but documents were not available. Other birth history and immunization history was given by her aunt, which was moderately reliable. General examination and pediatric examination was all done and all systems were normal. On ptosis examination, position of head was normal. There was no head tilt, no face turn, no chin elevation, and there was no frontalis overaction. Position of the eyebrows, the left eyebrow was slightly more raised, and the position of eyelashes were normal. There was a scar mark present 10 millimeters above the eyebrows. The right eye examination was all within normal limits. In the left eye, lid lag was absent. It was full and free. Ocular movements were full and free in all gazes. There was no lag of thalamus. Bell's response was normal, and there was no Marcus-Gunn jaw winking phenomenon. The palpable fissure height was 4 mm. MRD1 was -3 millimeters. MRD2 was 5 millimeters. LPS function was 4 mm, and lid crease was reduced in the left eye. Other anterior segment findings on slit lamp revealed no abnormality, and on indirect ophthalmoscopy, fundus was normal. So we made the diagnosis of left eye recurrent severe congenital ptosis with poor levator function with good Bell's phenomenon. It was differentiated from myasthenia gravis, third nerve palsy, Marcus-Gunn jaw winking, post-traumatic ptosis, blepharophimosis, and double elevator palsy. The challenges in recurrent ptosis was there can be a remnant of old sling entangled along with fibrosis. Overexposure risk is more with severe ptosis post-operatively. Lack of thalamus is expected to be more. And so we suggested frontalis sling surgery using silicone sling, which was planned for her under general anesthesia after pediatrician and anesthesia fitness. The points to be taken care of was to not to attempt retrieving previous link, avoid marking at the site of visible fibrotic scars, ensure good lid crease formation before closing, secure main sleeve with sutures, check Bell's response post-operatively, use of high viscosity lubricants post-operatively, and counseling and chair time is important. Counseling about recurrence and second surgery. Post-operatively, this was the first post-op day where we can see lid edema, lag of thalamus, and watering. And we have to take extra care about to avoid exposure of cornea. This was 3 weeks post-op where the lid edema has reduced and the formation of crease is better appreciated. This was 2 months post-op, which was better appearance. This was 3 months post-op. When does the ptosis recur post-operatively and why the previous surgery might have failed? Incorrect points at the level of lids, superficial passage of the sling, inadequate tightening at the time of securing the end of sleeves. The slings ends were cut too short, use of friable sutures instead of silicone slings. And the rate of recurrence after frontal sling is approximately from 14.1 to 62.2%. Causes can be local diseases, loss of function of LPS, intermittent sympathetic dysfunction, and isolated paralysis of LPS and Muller muscle. Thank you.
Okay.
I think we are next. You can proceed.
Okay, sir. Now we'll
Thank you, sir.
Okay. Now we'll invite Dr. Yukta Patel, as Dr. Prajakta Bansali from the Choitra Mitrale is not, she's not well, so she's not joined this session. So now invite the Dr. Yukta Patel. She is from Choitra, and her mentor is Dr. Dipanshu Agrawal. Yes, Yukta. Please unmute yourself.
Yukta, can you share your screen? Is
Yes. Hello.
there an issue
Am
with the
I
network?
audible, sir?
You're audible. Your screen is
Am I audible?
not shared. Yeah.
Yeah, sir.
Yukta, are you still there?
Is the screen visible? Am I audible, sir?
No, your internet is not of very good
Hello.
sound quality actually.
You can switch off your video. Yukta,
Yukta,
you
can you
can
switch
switch
off
off
your
your video.
video
Your
and then see
presentation will
if
work good.
if it is working better?
Yeah, is it okay? Is it okay?
No, your screen is still not visible.
Mm,
हाँ राजेश हाँ
Niharika ma'am, can you, is it okay if the
हेलो
next
हाँ
presenter
राजेश
presents
बोलो
and then she can
हाँ
come back and join in?
Yeah, sure.
Sure, sure,
Okay,
sure.
so that we can
Certainly.
Sure,
avoid wasting of time.
Yeah, yeah.
चौकीदार गया कहीं
sure,
तो फोन कर
sure.
लो ना उसकी वाइफ तो है
Yeah. So the
हाँ तो
next,
टेलीफोन कर लो ना उसको अरे यार नंबर मैं भेज देता हूँ
Yukta, stop sharing your screen. You can present later on.
yeah, yeah. I stopped the share.
तुम सामान ले आओ
so I'm
ले आओ
inviting
सामान
the
पैसे
next presenter.
घंटे के बाद दे देंगे पैसे
Um,
सामान ले आओ मैं उसका लालचंद का नंबर दे रहा हूँ आपको
Pragya, you can continue.
yeah, thank you, ma'am. So I'm inviting the next presenter from, this is Dr. Pankaj Sana from Amaltas Institute of Medical College, and the mentor is Dr. Purvi Garg. So, Dr. Pankaj, are you there?
Yes, ma'am. Good morning, ma'am.
Yeah. Good morning. Please share your screen and start the presentation.
Hold on, ma'am.
Dr. Pankaj, start your presentation. Yeah.
Yes, ma'am. The screen is visible, ma'am.
Yeah, it is visible. Make it full screen if it is possible.
Yes, sir.
Okay,
Good morning,
start.
everyone. Um, Good morning, everyone. I am Dr. Pankaj Hanap, our first year resident from Medical Sciences.
Hmm.
Uh, a 30-year-old female resident of Indore, Madhya Pradesh, came homemaker by occupation, came with a chief complaint submission of vision in right eye since 15 days. She was apparently all right 15 days ago, and then she started complaining of diminution of vision in right eye, which was sudden onset and moderately progressive. She had a previous history of LASIK surgery in right eye 10 years ago and three intravitreal ranibizumab administration in right eye 2 years ago. She had no history of type 2 diabetes mellitus, hypertension, bronchial asthma, or TB. Her diet and appetite were normal. Bladder habits were also normal. Sleep was adequate, and addiction, there were no history of addiction. Uh, Family history was not relevant, and her general and systemic examination well. Uh, Ocular examination, her head posture was straight, and ocular alignment were orthotropic. Facial, face was bilaterally symmetrical, and ocular movements were free, full and free in all of cardinal gaze. Ocular examination, vision of her right eye was 6 by 12, which was not improving on whole, and that of left eye was 6 by 9, which was not also improving whole. Her eyebrows were normal, and eyelids and all the associated appendages were normal. But on slit lamp examination, her conjunctiva was normal. Cornea was the size and shape of the cornea was normal. Surface was smooth in both eyes. Her cornea was clear and sheen was bright shine both eyes. Anterior chamber depth was normal in both eyes, and his color pattern was normal in both eyes. Pupil was central and reacting to light in both eyes. Lens was normal in eyes, and her intraocular pressure was 10 millimeters of mercury in right eye, and that of left eye was 12 millimeters of mercury. On dilated fundus examination, was clear in both eyes. Optic disc examination, the size and shape of the optic disc was normal. Margins were well defined, and a color swing. A cup disc ratio was 0.3:1 in both the eyes. In right eye, there was a scar that was 1 disc diameter temporally to the macula with a single fluid pocket present, and that of left eye macula was normal. Retinal blood vessels, the AV ratio was 2:3 in both the eyes, and background was tessellated. These are fundus examination view. We can see scar present to the temporal to the macula here. And this was an OCT image before admission of anti-VEGF on 18th of January 2024. We can scar in the near the crux membrane. So my provisional diagnosis both eye pathological myopia with right eye myopic choroidal neovascular membrane. The differential diagnoses are age-related macular degeneration, pathologic choroidal neovascular membrane, polypoidal choroidal vascular inflammatory choroidal neovascular membrane, and trauma-related choroidal neovascular membrane. Management was intravitreal anti-vascular endothelial growth factor ranibizumab 0.03 ml. This was our OCT image after 2 months of administration. 2 months after the administration, we can significantly see the scar exist in this image. This was our image on the last OCT image of the last follow-up. Here we can see significant reduction in the scar on the OCT.
Thank you. Thank you, Pankaj.
Yes,
Over to the judges. Rajen sir, if you have any questions, please. Shweta ma'am.
How do you differentiate myopic CNVM from ARMD CNVM on FFA? Or
Yes.
Ma'am,
one eye was having this problem, not the other eye, right?
yes, sir.
So, and it was pathological myopia in both eyes.
Yes, sir.
So, this anti-VEGF injection was given after how many days, or what was the period between the 2 injections, and how many injections were given?
Sir, anti-VEGF injections were given 6 months apart.
Ranibizumab.
Yes.
So the after the first injection, the second injection was given after 6 months.
Yes, sir.
And what was the criteria? So on follow-up, what tests were done?
The OCT image, fundus examination and OCT were done.
OCT were done. Good.
Yes, sir.
So what was the visual improvement?
Sir, our visual improvement is 6/6 in the right eye after 6 months of administration.
So when you
The second
decide
dose.
not when you decide not to give injections, after how many injections, or what is the doses of injection? Like how many injections should be given?
So,
Okay, thank you, Pankaj.
thank you, sir.
There was one question which I asked if you can answer.
Yes, ma'am. Ma'am, in ARMD is generally age-related. We can see the fact in older patients. Here, my patient was 30-year-old female, and along with pathological in ARMD, drugs are seen, and
Is there any difference between the leakage in myopes and ARMD, CLD?
um,
Okay.
Okay, we can proceed with the next
Okay,
presenter.
we can proceed. Yeah. Yes, sir.
Okay, ma'am. Okay, sir. Thank you. So the next presenter is Dr. Kriti Jain from Amaltas Institute, and the mentor is Dr. Soumya Sharma. Dr. Kriti, are you there? Dr. Kriti? Yes, Dr. Kriti. Dr. Kriti? Yes, Kriti. Dr. Kriti, please present your case and please share your slides. Unmute yourself. Dr. Kriti? Dr. Kriti, you're not audible. Um, Please unmute yourself. Okay. Dr. Kriti, okay, can we take the presentation from Chwetram then? Dr. Dipanshu, can we take the
Yeah, Dr.
presentation
Yukta,
from
are you there?
Are you ready? Okay,
Yeah,
Yukta, you present your, please share your screen.
Yeah, ma'am. So is the screen visible, ma'am?
Yes,
Not yet. Uh,
showing started screen sharing.
yeah,
In
yeah,
case
yeah.
your
It is
screen sharing it does not work, ma'am, is it okay if I share screen on her behalf and she can speak on
sure.
that?
Yeah. It can be done.
Because
Is it
Yeah,
okay?
not yet. Yeah, it's visible
yeah,
now.
it is visible, Yukta now. Just can
Make it
start.
on slideshow. Yeah.
So, good morning, everyone. My name is Yukta Patel. I will be presenting an interesting case series on an anterior segment inflammation. So, my first case is of a 37-year-old female who came with a complaint of pain and redness in the right eye since 6 months. She had a multiple prior ophthalmic consultation for the same,
Yukta, your presentation
and
is
for
not
which
moving.
she was given. Yeah,
Have you put it on
sir,
slideshow?
please can you? Yeah, sir, can you please share your screen presentation because mine is, I guess, not good.
Yeah, stop sharing screen now.
Yeah.
Is it visible?
Yes, now it is visible.
visible. Good morning, everyone. Myself, Dr. Rita Patel. I will be presenting a case for anterior segment inflammation. So my first case is of a 37-year-old female who came with right eye pain and redness in 6 months. She had multiple prior ophthalmic consultation for the same recurrent episode on and off since past, for which she was treated with the topical and oral steroid medication. Her present best corrected visual acuity in both the eyes is 6/6, and anterior segment findings are within normal limit, except there is a congestion present in the superior nasal aspect of the right eye. The fundus finding were within normal limit. So we had a provisional diagnosis of right eye anterior scleritis with us in a mind. So we ran down various investigation, amongst which Montux and Tigra came out to be positive. So we had a final diagnosis of right eye anterior scleritis, secondary to presumed ocular TB in our mind. So we started our patient on right eye drop fluoromethanin 6 times daily and tablet indomethacin 75 milligram BD for 3 weeks and tablet pantoprazole 40 milligram OD for 3 weeks. We also started our patient on ATT regimen after the pulmonologist consultation. So our patient on first visit, there was no much improvement in the patient's condition. So we continued our treatment. At the 3-week follow-up, there was slight reduction in the congestion seen. So we decided to taper off the topical medication and continue with the same oral medication. At 5-week follow-up, the condition was much better and the congestion seemed to be resolving. So we did taper our topical medication and started and transferred our BD oral medication dosing to the OD dosing. At next visit or follow-up, the congestion seemed to be settled very well. So we decided to taper off the topical medication and continue with the same OD dosing of the oral medication. At the final 12-week follow-up, the congestion was absolutely cleared off. So we decided to taper off the topical medication and stop the oral medication and continue with the ATT regimen as prescribed by the pulmonologist. So this is a pictorial representation of the patient's eye at the various follow-up visits, showing the improvement, showing the effectiveness of the treatment. My second case is of a 56-year-old female who came with a complaint of right eye pain and redness since 15 days. It was the first episode of such illness. The best corrected visual acuity in both the eyes was 6/6, and anterior segments finding were within normal limit, except that there was congestion seen. Now it was along with the nodularity on the superior nasal aspect of the right eye. Rest fundus findings were within normal limits. So we had a probable diagnosis of right eye anterior nodular scleritis in our mind. So we ran down with the investigation and all came out to be negative. So our final diagnosis was right eye anterior nodular scleritis. So we started our patient on 1% prednisolone acetate eye drop 8 times daily and tablet indomethacin 75 milligram BD for 3 weeks and tablet pantoprazole 40 milligram OD for 3 weeks. So on the first follow-up visit, the condition was same. So we continued our treatment protocol and tapering of the topical medication. At 10-day follow-up, there was slight reduction in the congestion seen. So we continued the tapering. At the next follow-up visit, we can see slight improvement with the medical treatment. So we continued the tapering of the steroids. At the 8-week follow-up, we could see the congestion was clearing off, but the nodularity was still persisting. So we decided to add on the oral steroid medication and continue tapering of the topical steroid medication. At next follow-up visit at 10-week, at 12-week, we could see complete resolution of congestion and nodularity as well due to the oral steroid medication started. So this is the pictorial representation of the patient eye at various follow-up visits showing the effectiveness of the treatment. Based on the above discussion, we can conclude that anterior scleritis can be a first-time diagnosis, but the recurrence is much more commoner with it. Extensive workup is essential to get down to the root systemic cause and treat it. And patients at most essential, as seen in both our cases, it took almost 1 month to resolve the condition. So patients is at most essential for treating disease. Thank you. Thank you.
Okay. Thank you, Yukta. Over to Jajal, sir. Any questions? Rajan, sir.
Yes, Dr. Kranti, in both the cases, can you hear me?
Dr. Yukta
Yes,
is there,
yes,
sir.
yes. I can hear you, sir.
She's Dr. Kranti then, right?
Sir, Dr. Yukta is there, sir.
Yukta
Dr.
Patel, sir.
Kranti. Yeah.
Yukta Patel. Okay. She
Yes.
came back. Okay, fine.
Yes.
So, Dr. Yukta, your presentation was very good. In fact, both the cases were really managed very well. I was thinking that why you decided to take fluoromethalone and not dexamethasone or prednisone acetate, because we have to vigorously treat these patients when we are giving systemic steroids. Why we have to take the weaker topical steroids?
Yes, sir. Seeing the condition of the patient, there was no nodularity or no bogginess in it. It was just congestion. And it seemed to be improving with our low-dose steroid. We gave a trial of low-dose steroid and it seemed to be improving with the low-dose steroid. So we continued with our low-dose steroid
No,
medication.
because
Since
we
she
were
was
giving the
responding
systemic
to it.
steroid as well. We had given the systemic steroid as well. So when we are giving systemic steroids, why we resort to the weaker topical steroid? Because the topical steroid has got a very accurate effect on the local area, and in fact, I personally feel that if you want to really treat something, once you make a correct diagnosis, then you have to go all out. Then
Yeah.
you can use a better steroid. Prednisone acetate has got better penetration, and even some other steroids like dexamethasone also is equally good, though we are not using. But FMLA,
Yeah.
I basically keep them reserved for the allergic type of situation, and this is inflammatory. So the patient was treated well. There is not much difference because the end result is fine, but probably the end result may be because of systemic steroid and not because of the topical steroid. Probably we could use the topical steroid more aggressively, and because the systemic steroid has got. What about the blood sugar? Did you check the blood sugar also?
Yeah. We did check the blood sugar, sir.
Because before giving systemic steroid, we have to check for diabetic status and or steroid responder also. But anyway,
Yeah,
your
she was
presentation
in.
was good.
Yeah, thank you, sir. Thank you, sir. Thank you, sir.
Okay, Dr. Yukta. From my side, it is okay. Dr. Setawalia may ask some questions.
You can proceed.
Okay.
Last one, there is one more.
Yes.
Okay. Thank you. Shweta ma'am, any questions? No, it's okay.
Dr. Pragya, anybody is keeping a watch on the clock, because we do not see any clock here, so we do not
Yes, sir.
know how much time was
Yes, sir.
taken.
Yes, sir. We are. Now, Dr. Krati Jain is our next presenter from Amaltas Institute of Medical College, and the mentor is Dr. Soumya Sharma. So, Krati, are you there? Dr. Krati? Dr. Krati? Dr. Krati, please unmute yourself and please start your presentation. You are not audible. Just unmute yourself.
Dr. Pragya, I can't see Dr. Krati. I
It
can't
will
see
come.
Dr. Kriti. Now she's there. Okay.
Yeah, she's there. But she's like not unmute herself, I feel. Dr. Prati, are you you're not audible. Mm.
Dr. Sonam, can you call Dr. Kriti?
Yeah, Dr. Sonam, can you call just Dr. Krati and
अपनी कर लो ना ये अंदर लोगों ने लगाई
Dr.
हुई है
Krati?
Yes, ma'am. Ma'am, this is audible now.
Yeah, now
देखा
you are
नहीं
audible. Yeah. Okay, just share your presentation. Just share your presentation full screen.
Yes, ma'am.
बहुत भीड़ है हैं? वो तो मंदिर के आना जब इतना परेशान रहता है शरीर तो
Okay, just do it full screen, Dr. Kriti.
Yes, ma'am. Good morning, ma'am. Good morning, sir, and everyone. I'm Dr. Kriti Jain, RSC second year. My guide is Dr. Purvi Karanai. A 42-year-old female was
Just make it full
admitted
screen,
in
Kriti.
ICU, referred from medicine
Kriti,
department.
just make it full screen. Okay, you start now.
Good morning, everyone. I'm Dr. Kriti Jain, RSC second year, and my guide is Dr. Purvi Karanai. A 42-year-old female was admitted in ICU, referred from medicine department for fundus examination. On general and systemic examination on central nervous system, patient was not conscious and not oriented to time, place, and person. Cardiovascular system was normal. Respiratory system
Kriti,
with
we are
mild
not
abdomen,
able to
chest
see your
pains.
screens properly. Just make it full screen. That is not, your presentation is not moving. It is showing the one screen only, the same screen. It's hanged, I see. Just make it full screen. Yeah, just change the slide so that we can see at least. Yeah,
Okay, okay.
make it full screen if it is possible.
make it slideshow.
Make it slideshow.
And it's already a slideshow.
Oh, it is not showing here
No,
as
it
a
is
slide.
not.
Okay. Okay, you start then.
A 42-year-old female was admitted in ICU, referred from medicine department for fundus on systemic examination and
Change your slides, Kriti.
central
You're only
nervous system, not oriented to.
we are not able to see your slides properly, Kriti. You just scroll down the one slide after the other so that we can also read them. Please do that. Yes. Uh, start.
A 42-year-old female was admitted in ICU and referred from medicine department for fundus examination.
Hmm.
On general and systemic examination, central nervous system patient was conscious but not oriented to time, place, and person. In cardiovascular system was S1 and S2 heart, respiratory system bilateral chest where patient was of febrile, and at the time of presentation, blood pressure was 165, 108 millimeter of mercury, and pulse was 82 beat per minute, and SpO2 was 99%. There is a pallor, teres, hidden edema, plugging, cyanosis, and limb peritopathy. On ocular examination, her head posture was straight, and examination of facial symmetry and forehead bilateral symmetrical, and ocular movement was not elicited due to patient was not well oriented, and anterior segment was normal except pupil were dilated pharmacologically. On ocular examination, result not possible due to no patient was not oriented. Color vision can be performed. Their anterior segment was
all normal. Ocular movement can't be performed. Uh, Anterior segments are all normals and pupil were dilated. On dilated fundus examination, media was clear. In optic, its size was normal in the both eye. In right eye, shape was circular, 360-degree well-defined margins, color margins, 360-degree well-defined margins, and color was white pale. CD ratio was not commentable, and macula was dull. Blood vessel was sclerosed vessel still near this. Background was multiple yellowish lesion were present in periphery of the retina, and oval well demarcated cystic lesion was present in along superior vessels in posterior pole. In left eye, media was clear and size was optic. This size was normal, shape was can't define, and margin there is a 360-degree blood disc margin. Disc edema was there, and color was mark hyperemic. CD ratio was obliteration of the curve, and multiple macula multiple yellowish lesion in parafoveal region corresponding to the hard exudate. There was macular edema present, and in blood vessel there is a tortuosity of blood vessels. In the background periphery of the retina, multiple yellowish lesions were present in the periphery and with flame-shaped hemorrhages in inferior to the disc along with vessels, and choroidopathy was there. This is the fundus photograph of the right eye and the left eye. Uh, we done OCT of the patient. There is a in the right eye there is a thinning of the retina, and in OCT there was a fluid-filled space in the right eye. CBC was CBC was normal. CT brain subacute infarct involving right external capsule and frontoparietal regions. In USG abdomen, bilateral renal parenchymal disease with left renal corticomedullary cyst and mild ascites. Drop I was negative and viral marker was negative. On the basis of fundus examination and CT brain report, my provisional diagnosis was pseudo-Foster-Kennedy syndrome. After a day, patient history asked from her son, and he gave a history of right eye sudden painful loss of vision 3-year back, diminution of vision in the left eye since 6 months, which is gradually progressive and painless in nature, and history of generalized headache was there. He gave a history of previous 3-year back. She had diagnosed with COVID, and then she completed treatment and recovered from COVID. Then after a month, she had a pain in her tooth associated with swelling of right side of the face and eye, and complaint of pus discharge from right eye. Then pus drained from tooth side done, and bandaging the right eye. Culture was done and diagnosed with mucormycosis. Vein opening of the right eye. She had complained of complete loss of vision in right eye, which was sudden and painful. They went for eye checkup and advised for she had a history of seizure and cerebrovascular accident, thrombocytopenia, anemia, 10-month back. It is on medication. There was no history of any ocular surgery, head trauma, no history of spectacles, spheres, and there is no significant family history and drug allergic history. On the basis of this, my provisional diagnosis is right eye secondary optic atrophy and the left eye hypertensive retinopathy grade 4 with hypertensive choroidopathy. Advice MRI report is awaited. And the disease was Foster-Kennedy syndrome, pseudo-Foster-Kennedy syndrome, ischemic optic neuropathy, compressive or infiltrative optic neuropathy.
Okay, thank you, Prati. So now back to judges, sir. Any question, Rajan, sir, from your side? I think
Yes, Pragya, sorry, I think I had muted myself. C has presented, and actually it appeared to be little difficult case. The
yeah,
slides
it's a
were,
long, not very
uh,
clearly visible, sir. Yeah,
yes. Okay,
it's a
thank you.
long slide. Okay. Thank you, sir. So these are the presenters for the competitive section 1. And I thanks for our judges, Dr. Chauhan sir and Dr. Shweta Verma sir, to give the valuable their valuable time and for the session, for the WOS session. And this is the end of the session 1. Thanks for all the candidates. Thank you.
Okay, thank you, Dr. Pragya.
Thank you, sir.
Thank you
Thanks
so
a
much.
lot for giving your valuable time to us, sir.
I wanted to make some comments because I was thinking and closely watching and observing that we should have a dry run also for the residents, because they should check their videos, they should check their audios, they should check their presentations. Not too much material to be put in the slides,
Yeah.
and they should be able to check whether they are able to present properly or not. Where they are sitting, they should have quiet environment and good internet connections, because it is not only the content of the presentation, it is also very important to know how they are going to present properly. They are able to make effective communication with the audience, effective communication, the audio quality, the sound, the pitch and the loudness, clear and loud. I mean, the clarity, clear and loud should be the word. Like when they speak, they should be confident whatever they speak, and they should be clear and they should be loud. Number one. Number two, the too much content in one slide may not give a good idea, because they have to basically give the idea. They are not going to teach the theory. They want to have the stress only on the positive findings, not on the findings which are already negative. They can easily skip those, so that, because the presentation is for 4 minutes.
Yeah, and most of the candidates run beyond the 4 minutes, sir. Yeah.
Exactly. So they should rehearse. Before that, they should be able to do a presentation in 5 minutes for 4 minutes presentation, so that if they rehearse and they do 10 minutes presentation, then they cannot. They will be too much crowding of the words, vocabulary, and presentations. So the idea is not to give the whole chapter. The idea is in 4 minutes presentation, we should be specific to that, particularly that area only, that whatever we want to present.
Yeah.
So although, because probably some of the students were first year and they were not given good opportunity in their classes, so they have that opportunity in the webinar. That is a good idea, but I think they should present in the classes also before they put in the presentation in the webinar. So that is a better idea for the mentor, and every mentor should be encouraged to join also, so that the student will have confidence that my mentor is there, so he can advise me accordingly, because everybody is new. So this is a competitive session, and I think one more point I was thinking, that you can have the competitive session for first year, competitive session for second year, and competitive session for third year, because a first year resident cannot compete with the final year. And the sorry, I wanted to clear one point, that because my laptop video was not working, so I had joined with my mobile also. So the sound you are listening from my laptop, and video you are looking at my mobile. So that is what the presentation, effective presentation is, when your audio, your video, and your presentations, all three things are important. Then the content of the presentation, the point in focus. So only one point is to be focused, because if you see in classes, we are dealing with case presentation, it takes almost half an hour. So how they can present in 4 minutes? So we should train them to present in 4 minutes, not to go into too much detail, right? The students were very good. Some of the students very good. So I feel that probably they were senior students. So, and one more thing, because there was no stop clock here, so I couldn't see whether they have exceeded the time.
Yes, sir. Yeah. So thank you for your suggestions, and we are definitely try to adhere on that. And that dry run idea is really good, sir. We should next time we will try to incorporate into our sessions. So it will help the residents as well, and they will be more confident in presenting after that, I feel.
See,
So,
our idea is not to discourage, but our idea is to encourage them for the presentations. So it is not that who wins and who loses. It doesn't matter actually. Everybody
yes,
has presented, that matters much. So
yeah.
instead of having toppers, you can have a graded, means like 10 position of the 10 residents, so they can compare their presentation with the other presentation, that why I was first and or why I was the last. So if they
Sure.
have to listen to everybody's presentation, then they can still improve. And one more thing, that that sheet you had provided did not
Yeah.
have that session 1, session 2, and session 3.
So they
So
have the candidate's name in there, so incorporated. I'll give you the details of the session one. So I'll send you.
I had 29 students, so I was thinking that all 29 has to present in one session.
No, sir. Now we are running shortly. We're starting our competitive session too. So, sir, I will send you the list of the students which are in the competitive session one, so that it will be like more clear for you
No,
to.
I have already given the marks. That is not a problem. I wanted to know that am I in the second session also, or it is okay with the first session only? Now, who are the judges in second session?
We have different set of
Just
judges for the second session, sir.
Okay, madam. That is fine. So I will send the result to Dr. Pragya Prakash.
yes, sir. Yes, sir. Yes, sir. Sure, sir. Sure.
Pragya,
So
can we
kindly
start
send.
with the second session,
Yes,
Pragya?
sir. Yes,
Yeah,
yes,
ma'am.
ma'am. Sir,
Thank
you
you,
can
sir.
send.
Thank you.
So you can send the result in that group also, sir. WhatsApp group.
Okay, thank you, madam. Thank
It
you.
is for the first session. Yes, sir.
Yeah.
Thank you, sir.
So before starting a session, second session, can we have Project Archana, or we will start the session 2 first? Competitive session second, we will start. Dr. Sonam?
We can start with the session 2.
Dr. Sonam, before you start, can you please ensure that music is off? We can't hear anything. There is somebody playing music.
Okay, we will check it, ma'am.
I request everyone else to mute their computers. Those who are not presenting, please mute.
Yeah. Okay, it stopped. I don't know. There was some that humming. Okay.
So we'll start with the second session.
Actually, there is a one project Archana is there with the Dr. Anjali Mehta ma'am. So can we have a 5 minutes like project Archana, or we will after that we can start our competitive session?
Sure, ma'am. Sure.
Good morning, everybody. Am I audible?
Yes, ma'am, you are.
So greetings to everybody. I'll just give you a short overview. Dr. Mohita had invited me to just acquaint you all with this project. It's called Project Archana. And it is another powerful idea from Dr. Mohita and the rest of the board. And I'll take a few minutes just to tell you three things. One, what is the project? How did it come about? And some advice to residents. And I won't be more than 5 minutes because I understand you all are running very late. So Project Archana is actually designed to help you in a holistic manner when you face any medical legal crisis or any work crisis. So it is, part of the ethos of the WOS that apart from your mentoring in studies and all, you should have mentoring in a holistic way. That is the ethos of WOS. How did it come about? That is the first part. In 2022, there was a gynecologist who committed suicide, Dr. Archana. The project bears her name. It is a kind of commemoration to her memory. She was a fabulous doctor with experience. She was doing a lot of social work. She was loved by the community. She took on a high-risk case. the patient died. This happens with other specialties. You have life and death happening every day. So why did she commit suicide? It was because of circumstances. So what happened? Actually, the patients and their family loved her, but the local politician sensed an opportunity to exploit the case. So he did two things. He told the family कि ये dead body को आप mortuary में मत ले जाओ. You sit outside her office and I'll help you get 15 lakhs from the doctor. We'll extort her. He also told the police to file a murder case against her. That was wrong. You can never file a murder case against a doctor because the victim, so-called victim, comes to you for advice and you are doing it in good faith. So a doctor can only be charged with negligence, never murder. Why Dr. Archana committed suicide was for 2-3 reasons. She was a very simple, very nice, technical sort of person. She didn't realize that all these people are trying to exploit her. She was unfamiliar with the law. She thought I'm going to be in jail for murder. She didn't know that there's a long process before that can happen, right? So of course, it led to a national debate, and Dr. Mohita and others realized that, this can happen to anybody in ophthalmology also. You can be stuck someday. So how do we provide support? And I want to point out to all the residents that you may be brilliant in your work, you may have the best machines, everything going for you, but you are not in control of circumstance. So the second part of my short talk is that what exactly is Project Archana? So in Project Archana, we have these sessions. We have webinars, maybe once or twice a year. And at every conference, we have a session where we holistically guide you that when, God forbid, if you're ever stuck in a crisis, how do you take help? So there are 4 or 5 aspects. How to help the person, how to calm your own mind, because when you have a crisis, you're very stressed mentally, physically, aapke haath paun neele thande ho jate hain. How to calm yourself. So there's actually practical advice that this is what you can do to calm yourself. Second, how do you take help from the people around you? How do you train your staff to help you? How do you get help from friends around you? See, big hospitals, they have their own medical legal cells. They have their full system. You just press a button and code violet, code blue, all these things to help. Private practitioners don't have all these resources. So this guides you. The third part of the session, we normally have lawyers and coming and telling us about our medical legal rights. You cannot be charged with murder. Even if you're charged with negligence, there are a lot of checks and balances, Naturally, a patient who loses a relative, meaning if a patient is lost, the relatives get very angry, but it's not your fault. You're not God. You can't save everybody, right? And in spite of so, it tells you what are your legal options. It also guides you how to take help. If you're stuck, where do you seek lawyers from? How do you get insurance? You can either sign on for insurance indemnity, get lawyers from there. You can hire your own lawyers. So we have these sessions at every conference, and I invite you to come and attend these sessions, increase your awareness of your own rights, because see, all of us are working happily. We are doing cataracts every day. When things are going well, we don't have a problem. Problem comes only when you have a rent or something. So it's in your vulnerable moments that you need protection, and this tells you how to be secure when you're vulnerable. And then lastly, I would just like to give 2 words of advice to our young residents who are with us today, that there are 2 main safeguards you don't get stuck in all this. One is to be very good at what you do. If you're, you pursue excellence, you have good mentoring, then you're bound to be above average in your work and you're less likely to make mistakes, but everybody does. I've had a long career for 25 years. Believe me, I have made some mistakes. Luckily, very few. All of us make mistakes. We can be in a crisis. So remember that. Have the humility to remember that and acquaint yourself. Become aware of these things. Don't wait for it to happen and then. And most importantly, and lastly, don't judge your friends, help your friends. So if you see that some case has gone wrong or something like that, don't judge them because you don't know. They're brilliant people. They may not have the resources when they set up their private practice. They may not be able to afford an OCT. They may not be able to afford something, but their mind is brilliant. So you cannot judge the other doctor. You don't know if the patient coughed in the middle of the surgery. You don't know why that thing happened, that complication. Tomorrow you could be in a spot where you've done 100 good cases, but 101, the relatives are very violent type of people, not your fault. Relatives' nature is like that. They can come and surround you. You want your friends to help or not, right? So never judge each other. Be each other's friends. You are the biggest support for each other. So I wish you a wonderful second session. Good luck. And I hope to see you in Project Archana in the conference.
Thank you, Anjali ma'am. I just want to introduce that Anjali ma'am is ex-army eye surgeon and presently practicing in Dwarka and Vasundhara Eye Center. And she had an Indian patent of biodegradable PPE and a certification in global medicines. Thank you, ma'am, for giving your valuable time and just make it aware as for Project Archana. And thank you, ma'am. And now we are
very welcome.
So now, Dr. Sonam, I just want to continue for the competitive session 2. Thank you.
Thank you. Thank you, Dr. Pragya. This is Dr. Anshu Khare.
Thank you, ma'am.
And so me and Dr. Sonam will be moderating this second session, and I welcome all the judges and all the participants. And I hope all the participants are present here, and all the mentees and mentors both are present. So to start with the session, not wasting much time, I would invite Dr. Sonam to introduce our judges, Dr. Tajinder Singh Aluwalia, Dr. Nilima Mehrotra, and Dr. Rashmi Jain. Sonam, please continue with the session.
So we have Dr. Major General Tajinder Singh Aluwalia sir with us. He's professor and HOD at National Institute of Medical Sciences and Research at Jaipur. He's been alumni of AFMC Pune and Arvind. He's also UG and PG examiner in various universities, so you may come across him. And he's been referee with AIOS and Medical Journal of Armed Forces of India and awarded twice as best for the same. He's won IRSI gold medal, Sushrut Samman from 40. He's been awarded with the Army Commander's Northern Command Commendation and Chief of Army Commendation. We welcome you, sir. In this session, we are joined with Dr. Nilima Mehrotra, madam. She's professor and HOD from SRMS Medical College, Bareilly. She's the one who's brought up the department there, and she's alumni of GSVM and LVPI. Winner of AIOS Platinum Award for the Cosmic Study in 2022 regarding mucormycosis, a multi-center study, and an executive committee member in the Eye Bank Association of India between 2010 and 2013. Recently in Varanasi, the WOS Annual Committee, she was the state organizing secretary behind it. And finally, I'll be introducing Dr. Rashmi Jain, professor from Yenepoya Medical College, Mangalore, alumni of our own MGM Indore and NSCB Jabalpur. She's done her PG diploma in biomedical ethics. And regarding the curriculum committee, she's a recent convener in it and in the medical education unit. She's been awarded with Good Teacher Award in 2019 and also the Iron Lady amongst us. Authored chapter on simulation in medical education. In the recent talk we had about Project Archana, it would be really good, ma'am. Just a humble suggestion if we could inculcate into the curriculum of the recent PGs and UGs. So kind word from my side.
Good suggestion.
Here
In
we start
fact, we had a session at Project Archana last time in Varanasi. So I was also one of the speakers. It was a pleasure listening and nice to have you. So thank you for welcoming, and we can start off the session. Thank you.
So first we have the Sham Shah Medical College, Rewa. And among them, we have Dr. Tanisha Mittal, mentored by Dr. Pankaj Chaudhary, going to present traumatic complete SOS syndrome. Dr. Tanisha Mittal, are you here?
Yes, ma'am. Yes, ma'am.
Please share your screen. If you have any problem, please let me know.
Yes. Full screen.
Just one moment. We have way and quality of presentation being marked by with 10 points, clinical acumen with 10 points, adherence to time 5, originality and uniqueness of the presentation 10, discussion 15. To the others, there's a humble request that please mute yourself and pause your video so that we have better quality of presentations. Dr. Tanisha, please start. You have 4 minutes.
Ji, ma'am. Good afternoon, everyone. I will be presenting a case
My mentor is Dr. Professor Pankaj Chaudhary, sir. Particulars of the patient. Patient name is Rita Kushwaha, 42 years old female, housewife by occupation, Hindu by religion, residence of Bodhabag district, Rewa. Chief complaints, pain, swelling and bleeding from lower lid tier right eye since 1 day. As narrated by the patient, she was apparently well 1 day back, then she sustained trauma to right eye due to hit by cow's horn, leading to pain, swelling, bleeding from lower lid tier right eye. Past history, not significant. Personal history, patient was vegetarian by diet, normal bowel and bladder habit, normal sleep-wake cycle, no history of anticoagulant drug intake, no history of loss of consciousness, epistaxis, rhinorrhea, and vomiting. Family history, not significant. General examination was within normal limit. Systemic examination was also within normal limit. On ocular examination, best corrected visual acuity in right eye was 6.9 partial, in left eye was 6.6 partial. IOP was within normal limit in both eye. Face and orbit. On inspection, right eye shows mild swelling on right half of the face, periorbital edema with ecchymosis, lid edema with lid tear, and severe ptosis was present. Axial proptosis was measured with Ludy's exophthalmometer. In right eye was 23 millimeter and in left eye was 18 mm. Left eye was normal on inspection. Movements were restricted in all the cardinal gaze in right eye, suggestive of involvement of third, fourth, and sixth cranial nerves. Left eye movements were normal. On palpation, right eye, tenderness was present, margins can't be assessed, no thrill and increased proptosis with Valsalva, anesthesia of the frontal region, upper eyelid and inferior periorbital area was present, suggestive of involvement of frontal nerve. Corneal sensations were absent, suggestive of involvement of nasociliary nerve. Left eye was normal on palpation. All auscultation, no bruit sound audible. Anterior segment examination, right eye shows conjunctival congestion, chemosis, subconjunctival hemorrhage. Pupil was dilated and non-reactive to light. Grade 1 nuclear sclerosis of the lenticular opacity was present, rest normal. Anterior segment examination, left eye shows grade 1 nuclear sclerosis, rest normal. Optic nerve function test, both eye was normal. Shermer's test in right eye was 10 mm, suggestive of involvement of lacrimal nerve. Left eye was 15 mm. Fundus examination of both eye was within normal limit. So my differential diagnoses are traumatic superior orbital fissure syndrome, orbital compartment syndrome, expanded orbit syndrome, cavernous sinus thrombosis. On investigations, WBC count was raised. Medicine reference was done for the raised WBC count. Rest investigations was normal. NCCT orbit, in this coronal section, we can see there is break in the continuity of the medial wall and the floor of the orbit, showing the medial wall and the orbital floor fracture, as well as herniation of the tissue is seen, showing the teardrop sign. Left eye is normal. In this axial scan, right eye proptosis is noted. Displaced fracture of the medial wall along with fracture of the lamina papricia is present. Retroorbital hemorrhage is noted. Left eye is normal. In this axial scan, fracture walls of the right maxillary sinus with blood in the maxillary sinus, that is hemosinus, is noted. Left maxillary sinus is normal. So my final diagnosis is right eye traumatic complete superior orbital fissure syndrome with Leaford 2 fracture along with blowout fracture, retrobulbar hemorrhage and hemosinus with immature cataract. Left eye immature cataract. Treatment given IV steroid and IV antibiotics. On discharge, patient was complaining of watering and doubling of vision. Deep orbital sulcus was present, mild ptosis was present, sensations reduced, severe inophthalmos was present, slight hypoglobus was noted. On discharge, movement shows improvement. Force suction test was negative. Shermer's test shows improvement in right eye from 10 mm to 14 mm. In proptosis measurement, on admission, right eye was 23 mm and on discharge, it was 11 mm, showing the inophthalmos was present. Thank you.
The case is open for discussion. May I request the judges to please ask questions?
Okay, Dr. Tanisha, thank you for
Yes,
the
sir.
nice presentation.
Thank you.
What was the condition you said, that condition at discharge? The ocular movements were back to normal?
So at admission, it was restricted, or there was no movement, but on discharge, it was little bit improved, not completely, but improved than in the comparison of on admission, sir.
Okay, and what was the dose of steroids given?
We gave injection dexamethasone 8 mg IV BD. As the patient's WBC count was raised, so we can't give the dose of the methylprednisolone as described in the few articles that is available. But not the standard treatment is available for the SOF syndrome because the few cases are reported of this disease.
Okay, and in the blowout fracture, there was no involvement of the inferior rectus.
No,
Entrapment
sir.
was not there. Okay.
No, sir, there was no entrapment in CT scan. Also, there was no kinking of the inferior rectus muscle, or as well on force ejection test, it was also negative, sir.
Okay. Okay.
Yes, sir. Thank you, sir.
Okay, Dr. Tanisha.
जी मैम. Good afternoon, ma'am.
Hello.
जी मैम जी.
Yeah, Dr. Tanisha.
Hello. Yes.
In the lower lid.
Sorry, ma'am. सुनाई नहीं दिया, ma'am.
Canaliculus while repairing it?
No, ma'am. Canaliculus was not damaged, ma'am.
But it was a full thickness tear, right? You have not mentioned any treatment in your surgical treatment in this case.
Ma'am, tear was 2 mm away from the lower lid margin, ma'am. Not
Okay,
involving
okay.
the lid margin. जी,
Not
ma'am.
not involving the lid.
जी, जी.
All right. So the patient is still under follow-up?
No, ma'am. The treatment which we did, we prescribed that treatment, and we manage conservatively only, ma'am. For further treatment, that is surgical intervention is required. For that, we don't have facility in our institute for that, ma'am. For surgical intervention.
All right.
जी.
All right. Very well presented. And I'm
Thank
sure
you.
you must have done something for the hemosinus as well.
Ma'am, we were observing the patient for the retrobulbar hemorrhage only, and we went for the ENT reference also for that patient. Then they also, the ENT department also decided to refer the patient at higher center, further higher center, ma'am.
All right.
Where,
All right. Thank you.
जी ma'am.
Thank
Thank you,
you
ma'am.
very much.
जी ma'am.
Is there any role for surgical management here? What are the indications for surgical management in such a case?
Yes, ma'am. There is role of surgical intervention also, ma'am. Firstly, in a case of traumatic SOF syndrome, ma'am, we will go for the conservative management only. If in case of SOF syndrome is there, there is a sphenoidal fracture, depressing sphenoidal fracture, then we will go for the surgical decompression. And if there is associated facial fracture, ma'am, then we will go for open reduction. And we also have to rule out the vascular causes also, ma'am. If they are present, then we will go for the angiography, and then we will do embolization.
Okay, one last question. Any role of minimally invasive surgery? You mentioned open reduction, right?
जी ma'am.
Any role of minimal invasive?
Sorry, ma'am. Minimal
Okay, okay, no problem. Thank you. Well presented. Okay.
Thank you, ma'am.
Over to you, Dr. Sonam. Yeah.
Thank you.
Great presentation, Dr. Tanisha,
Thank you,
and
ma'am.
congratulations to both of you. Your mentor also prepared you very nicely, very
Thank you.
systematic approach.
Thank you, ma'am.
Pankaj sir, thank you so much. Next, I would like to invite
Thank you.
Dr. Anjali Sharma. She is mentored by Dr. Shashi Jain ma'am, again from Shamsha Medical College, Riva. She's going to be presenting on Stargardt's disease. Am I right? Dr.
Ma'am,
Anjali? Are you?
good afternoon, ma'am.
Yeah, please start sharing your screen. Your presentation is still not up. Yeah. Can you put it to full screen, please?
Good afternoon, ma'am.
Sure.
Good afternoon, everyone. Myself, Dr. Anjali Sharma. My mentor is Dr. Shashi Jain. Sorry, ma'am, it is not working. Screen is not moving.
If on minimizing it is working.
Yeah. Working in this.
Yes, you may present with this. If the judges allow, is it okay?
Ma'am, it is working now.
Okay.
Good afternoon, everyone. Myself, Dr. Anjali Sharma. My mentor is Dr. Shashi Jain. नहीं हो रहा ना
Don't worry. You can minimize and present if the slides are okay. It's moving, I guess.
Yes, ma'am. Good afternoon, everyone. My patient is Ayush Dwivedi, 12-year-old male student, resident of Riva. He presented with the chief complaints of diminution of vision both eyes since 2 years. History of present illness, as narrated by patient's attendant, he was apparently well 2 years back, then developed diminution of vision both eye, which was gradual in onset, progressive in nature, not associated with any pain, redness, fever. Patient did not complain of any photophobia or night blindness. In past history, there is no history of using of any spectacles, ocular trauma. There is no history of any systemic disease. There is no history of any chronic drug intake. Family history, he has a younger sister with a similar complaint of diminution of vision both eye. There is no history of visual complaint by any other family members. There is no history of consanguineous marriage in the family. Birth history, it was a full-term normal vaginal delivery. Birth weight was not known. No history of any pre-peri or postnatal infections. No history of any NICU stay. General examination was within normal limit. Systemic examination was within normal limit. Ocular examination, visual acuity of the both eye was 260 with pinhole, no improvement. Retinoscopy under homotrobin done with 1 meter working distance gave a result of +2 diopter in both meridians, but it was not improved. Near vision was N12 at 25 meters centimeter, and other findings of anterior segment was within normal limit. सॉरी मैम, ये हैंग हो गया फिर से.
You can minimize and continue, please.
Fundus examination, both eye fundus examination, both eye disc, the right eye disc was normal in size and shape. Temporal pallar was present. Left eye was slight tilted with the temporal pallar. CDR was 0.5 and NRR was healthy. Macula, in both fundus, the macula saw central macular hyperpigmented lesion with a beaten bronch atrophy with a pair of macular yellowish round flex specifiform around the macular region and all around the fundus area. This is the fundus diagram. Color vision was defective by the Ishihara chart. Visual field was normal with the confrontation test. In the pedigree analysis, both the offsprings are affected, but the parents was not affected. My differential diagnosis was Stargardt disease, bone dystrophy, chloroquine, and hydroxychloroquine maculopathy. This is the siblings fundus photograph showing hyperpigmented lesion in the macular region of the both eye. This is the fundus autofluorescence of the patient, showing hypoautofluorescence in the macular region suggestive of atrophy, along with hyperautofluorescence flecks seen in all over the fundus suggestive of lipofuscin-laden RPE cells. This is the osseity. This is the osseity of the right eye and the left eye, HD raster osseity, showing the foveal thinning with ellipsoid layer loss. The electroretinogram also done. Full field ERG shows reduced both photopic and the scotopic responses. Multifocal ERG also done, shows foveal, perifoveal, and parafoveal decreased responses. Both eye Stargardt disease is my probable diagnosis. There is no current treatment is available for this. Clinical trials are available. Amexostat hydroxychloride, which inhibit the RPE65, reduces the production of the byproducts like A2E, which are toxic for the photoreceptors. ALK001, which reduce the production of A2E and lipofuscin formation, can also be used, and with the help of the adenovirus associated virus, we can introduce the healthy ABCA4 gene into the RPE cells, which act as an active transporter. With the help of gene therapy, we can help in the regenerating of the RB cells. Although all these trials are under trials right now. These are my references. Thank you.
Dr. Anjali, you are exceeding time a bit, but I can understand with the technical glitches. Your case is open for discussion with the judges. May I please ask you to question her regarding the case of Stargardt disease?
Okay, Anjali, it's a nice presentation and most of the points have been covered. Regarding the treatment part, actually,
Yes,
right, there's no treatment available right now, but I think we have high hopes with the genetic treatment in the future. But I don't have any questions for you.
Thank
The
you, sir.
other
Dr. Nilima, Dr. Rashmi Jan, ma'am, if you have any questions regarding the case, please.
Yeah, I'll just ask a question. Did you have any differentials when you were diagnosing as Stargardt's, what were your differentials?
Ma'am, we can have the cone photoreceptor cell cone dystrophy. We have cone rod dystrophy. This could be our and other findings of bullseye maculopathy like hydrochloroquine or hydroxychloroquine toxicity fundus findings. This could be included in our differential diagnosis.
ARMD can be a differential?
Ma'am, yeah, ma'am, it may be because the age of presentation, it is a younger age. He's a 12-year-old female, and mostly it is in older age group.
All right. Okay. Thank you. Well presented.
Thank you, ma'am.
Okay, Anjali, would you suggest any low vision aids for the child?
Yes, ma'am. We can advise. Yes, ma'am. Yes, ma'am. We can advise. As the vision of the patient is 260 in the both eye, we can advise the high magnifier glasses to the patient and also we can change the environment, like we can provide the brighter, big and the big
Yes, correct. Yes, you're right, but you didn't mention them, did you, in your presentation? I missed it up probably. If you, I think you have mentioned, right? So you
yes,
should
ma'am.
always think of improving your patient's vision in whatever small or big way that you can. It's not only about making diagnosis, but it is also about doing the best for restoring your patient to as normal as possible. So the child is 12 or 14 years old and
Yes, ma'am.
has another sibling who's affected also. So you should think of advising whatever low vision aids which can work for the children. These people generally have better peripheral vision, but central
Yes, ma'am.
normal. The retinoscopy you mentioned was quite normal, so I don't think he will need any spectacles or they will make any difference.
Yes, ma'am.
All right, thank you, Anjali.
Incidentally, Anjali, just one thing. Your patient you said had vision in the right eye of 2/60, and then you've noted there BCVA of 1/60. The BCVA cannot be less than the uncorrected vision, right?
Yes, sir. It was सर वो लिखने में थोड़ी मिस्टेक हो गई सर.
Okay.
हाँ जी सर.
With very good positive notes from the judges, we now move on to Bundelkhand Medical College, Sagar. We have Dr. Isha Garg with us. Congratulations to Anjali and Dr. Shashi Jain ma'am for the great presentation on Stargardt's. So, Dr. Isha Garg, are you with us?
Yes. Can
And
you hear
your
me?
mentor, Dr. Sarika Chauhan. Yes, we can hear you. Dr. Sarika Chauhan, madam. You'll be presenting on peripheral ulcerative keratitis, I believe.
Yes.
Okay. Please share your screen.
Yes, I'm sharing.
Your time has started, please. You have 4 minutes.
Okay. Myself, Dr. Isha Garg, first year ophthalmology resident from BMC Sagar. My guide is Dr. Sarika Chauhan, ma'am. The patient, 74 years male, resident of Sagar, presented with the chief complaint of pain in left eye since 20 days, whitening over the black part of eye since 20 days. The patient was apparently all right 20 days back when he noticed pain in left eye, which was sudden in onset, moderate in severity, persistent throughout the day, associated with redness and watering. It was non-radiating and no aggravating or relieving factors. He also noticed whitening with the black part of eye since 20 days. It was associated with gradual and progressive diminution of vision and discomfort in bright light and foreign body sensation. No history of ocular trauma as per the patient. He was admitted in ophthalmology ward on 3rd July 2024. There was no similar complaints in past, no significant medical or surgical or family history, no significant allergic or personal history. General and physical systemic examination was within normal limit. There was no history of joint pains. On examination, right and the left eye, the eyebrows orbit and size of the eyeball was grossly within normal limit. The eyeballs were deep-seated, uniocular and binocular movements were present in all gazes. In right eye, the visual acuity, best corrected visual acuity was 6/12. Lids, eyelashes, lacrimal gland were within normal limit. The white out spots were noted temporarily in conjunctiva. Cornea, sclera, iris, pupil lens, and fundus was grossly within the normal limit. Now the left eye. The best and uncorrected visual acuity of left eye was 1/60. Lids were edematous. Lid crease was present 10 mm away from the upper lid margin. The eyelashes, lacrimal gland, lacrimal sac was normal. There was circumciliary congestion and bitoid spot noted in conjunctiva. The cornea was 10 into 11 in size, anteriorly convex, irregular surface from 5 to 8 o'clock. There was a defect of size 4 into 2 in periphery, extending 4 into 2 in periphery, extending to paracentral area at 5 to 8 o'clock, along with thinning of about 2/3 of stroma. The stroma infiltration and increased stromal thickness of about 2 superior and inferior to the defect, and about 4 at 5 and 8 o'clock position. 2 broad grayish white nebulomacular opacity seen along the limbus. Rest of the cornea was transparent. Prominent superficial corneal vessel is seen at 8 o'clock, extending up to 2 on cornea. The sensations were absent in the areas of thinning and present in other quadrants. There was a whitish gray colored corneal ulcer, oval in shape, located in periphery, extending up to the paracentral area with rough edges, irregular margin. Base was filled with necrotic material. No vascularization is seen over the ulcer, and the walls were sloping. Anterior chamber, iris, and pupil and lens were grossly within normal limit. The differential diagnosis of bacterial keratitis, fungal keratitis, viral keratitis, peripheral ulcerative keratitis, Murren's ulcer, and keratomalacia was made. Blood investigations was within normal limit. RA factor was negative, and on physician's examination, there was no systemic illness was found. We sent a conjunctival swab and corneal scrape, but no fungal or bacterial growth was found. After clinical and ocular examination, BCL was placed after 2 days of admission and further planned for amniotic membrane graft. We made the final diagnosis of left eye Murren's ulcer. The systemic and topical treatment was given as follows. After 6 days of medical management, patient was symptomatically better, but the corneal thinning was progressive. So we planned for surgical management. We placed the amniotic membrane graft in multi-layered over thinned out corneal surface by inlay technique and over the entire cornea by onlay technique and secured using sutures. BCL was placed over the cornea. On post-op first day, vision was counting finger 2 feet. Patient was symptomatically better. Patient was discharged with after 5 days of surgery with vision 1/60. After 15 days follow-up, the vision was 4/60. Amniotic membrane was absorbed. Patient was symptomatically better. Opacity developed over the area of ulcer along with vascularization inferiorly. Thank you.
Well managed in time. We may take your questions for the presentation. May I request the
It's a
judges to
nice presentation, but what was the rationale for diagnosing it as Murren's ulcer?
Actually, the Murren's ulcer is a diagnosis of exclusion. So for that, first we took the history for any systemic illness, which was not there. There was no history of joint pain and any other systemic illness. Secondly, we sent the sample for corneal scrape and conjunctival swab, which also came out to be negative. And the presentation was like that. So we, after excluding all the conditions, we made the diagnosis of Murren's ulcer. And the blood investigations were also negative.
You've mentioned there's bitoid spots in both eyes, and yet in your diagnosis there is no mention of that. Did you give vitamin A supplements?
Yeah. No, I mentioned vitamin A therapy in treatment.
Okay.
Gave vitamin A therapy.
Okay, thank you.
Any questions from Nilima ma'am and Rashmi ma'am?
Yeah, am I audible?
Yes, ma'am.
Yes, ma'am.
Hello?
Yes,
All
Yes,
right.
ma'am. You're audible.
What was the source? Dr. Isha?
Yes, ma'am.
What was the source of the amniotic membrane which you took for grafting?
We extracted the amniotic membrane from mother after processing it with the antibiotics, and then we placed over the cornea. We extracted
Okay, but generally cryopreserved.
No, we preserved it empty media, and
All
then
right, but generally cryopreserved membranes are used now.
Okay.
That is more readily available from the same patient itself. It's very Hello.
Yes, ma'am.
Do you have any knowledge about Tenon patch preference?
You're not audible.
Ma'am is asking if you have idea about cryopreserved membranes.
No, ma'am.
Actually, ma'am is
I don't
calling for
have
the
any idea about
verification.
cryopreserved one. In our institute, we extract it fresh from the mother and we process it and then we apply it.
All right, all right. But cryopreserves are used, and also Tenon patch can be used as a graft for such cases.
Yes, ma'am.
All right. Thank you.
Okay, so to continue with the management, any difference in the management of Murans and peripheral ulcerative keratitis? The focus of management, what's the major difference between the two?
Ma'am, if the ulcer is progressing, if there is a thinning, then we can manage it with the graft, keratoplasty, and we can also do the conjunctival resection. And we can give the topical and systemic steroids.
Okay, thank you. Well presented. Over to you.
Great presentation, Dr. Isha, and congratulations, Dr. Sarika, for mentoring her. Next, we have Dr. Ayushi Mahajan presenting congenital ptosis, mentored by Dr. Anjali from Bundelkhand Medical College, Sagar. Can you please share your screen?
Good evening, everyone. Myself, Dr. Aishi Mahajan, first year ophthalmology resident, BMC Saga. My mentor is Dr. Anjali Virani, ma'am. I am presenting a case of 21-year-old male resident of Saga, presented with chief complaint of incomplete opening of left eye since birth. History of presenting illness, as per patient's parents, they notice incomplete opening of left eye since birth. The incomplete opening was non-progressive in nature. During the course, he adapted a particular position to see objects, that's head tilt to right along with elevation of chin sometimes. A negative history of diminution of vision, seeing double objects, abnormal ocular movements, diurnal variation, abnormal movements of eye during feeding or use of any ocular eye drops or similar complaint is described. No similar complaint is found in younger brother and sister. Past eye history, he has a similar complaint in right eye for which he went frontalis sling surgery under local anesthesia on 2nd May 2023 at BMC Sagar. After that, he adapted a head posture of elevation of chin and head tilt to right side sometimes. No history of any ocular trauma or wearing glasses. Past medical history, born full term with uncomplicated pregnancy and delivery. No history of birth trauma. No significant family history, social history or drug allergy. On general examination and systemic examinations were within normal limits. Ocular examination, head posture is erect, occasionally tilt to right is seen. On forehead, multiple small wrinkles are noted along with frontalis crease line, and left eye covers the pupillary area. On elevating the lid, axis is central. On examination, the eyebrows of both eye are elevated with at equal level with black color adequate density. Orbit and eyeball are normal. Ocular movements are recorded. Uniocular and binocular movements are present in all cases. Right eye visual acuity best corrected is 6/6. Biconvex lid creases present 3 mm above the lid margin and upper lid covers 2 mm of the cornea. Eyelashes, lacrimal gland are normal. A vertical aperture of 8 mm is noted. Lacrimal sac area, conjunctiva, cornea, sclera, anterior chamber, iris, pupil, lens are normal. Visual acuity of left eye best corrected is 6/6. Lid shape is biconvex with absent lid crease and upper lid covers 6 mm of cornea. The eyelid movement is opening is restricted. Lacrimal gland and eyelashes are normal. A vertical aperture of 4 mm is noted. Lacrimal sac area is normal. Ocular movements in all the gazes are recorded. Since lid crease is absent, lid fold distance and lid crane distance cannot be calculated. Marginal limbal distance of 4 mm, MRD1 minus 1 mm, MRD2 5 mm, MRD3 minus 2 mm. Fissure height in primary gaze 4 mm, LP's exclusion 4 mm, lid lag and leg ophthalmosis noted. Bell's phenomena is present, Marcus jaw winking phenomena absent, extraocular movements muscle is noted. Corneal sensation, tear film, shimmer stress, ocular surface, pupil refractions are within normal limit. Conjunctiva, cornea, sclera, anterior chamber, iris, pupil, lens are normal. A differential diagnosis of congenital simple ptosis, congenital complicated ptosis, pseudoptosis, and myasthenia gravis is made. Blood investigations are within normal limit. On clinical examination, intercanthal distance is 28 mm, interpupillary distance is 60 mm, eye spec test, fatigability test, coagulate with sign negative, and pyridostigmine test is found to be negative. A final diagnosis of severe simple congenital ptosis with leg ophthalmos is made in left eye. A management of left eye with frontalis link surgery is planned and patient was operated on 6 July 2023. Post-operative stay was uneventful and he was treated with systemic and local antibiotics and discharged on second post-operative day with lid full of 2 mm, lid crease of 3 mm, MRD with 3 mm, MRD to 6 mm, fissure height of 8 mm and leg ophthalmos is present. On post-operative day 2, extraocular movements are recorded in all the cases. On follow-up post-operative day 7, extraocular movements are recorded in all the cases. Thank you.
The case is open for discussion. I request judges to please question her.
Okay, so what are the indications of surgery in congenital ptosis?
Dr. Ayushi, are you with me?
Am I audible, Ayushi?
Hello, Dr. Ayushi?
Yeah, hello.
Yeah.
Ma'am, am I audible?
Yes, now you're audible.
So what are the indications for surgery? You've gone for a frontalis thing, right? What was the indication for surgery in this particular case?
Sorry, ma'am.
Indications for surgery in this particular case.
Ma'am, it is a severe simple congenital ptosis. We have made a diagnosis. The pupillary margin is covered with the lid. The patient is having difficulty in seeing. That's why he's changing his head posture to see the object. So we have done a surgery so that he can have a central pupillary area to see the objects and can keep his head posture erect.
Okay, so abnormal head posture was the indication. All right. Okay. Thank you.
Thank you, ma'am.
Yeah, over to
Dr. Ayushi, why is this not blepharophimosis syndrome? It was bilateral, correct?
Blepharophimosis ptosis epicondyle inversus syndrome. It is an autosomal dominant disorder in which, along with severe ptosis, we have epicanthus inversus and telecanthasis. On examination, we have not found any epicanthus inversus, and the telecanthasis distance is also within normal limit.
Okay. Did you mention that distance when you presented the case?
Yes, ma'am. On examination, intertelecanthal distance, telecanthal distance has been mentioned to be 30 mm. Interorbital distance.
All right. Thank you.
Ayushi, what was the vision of the patient?
So the patient's vision is best corrected as 6/6 in both eyes.
In spite of that severe ptosis, there was no amblyopia in either.
Say low amblyopia as patients have vision, bilateral ptosis is present, so the difficulty of amblyopia is not present here. Presence of amblyopia is not.
Bilateral ptosis, if it is covering the pupillary area, doesn't mean that if it is bilateral, it won't be amblyopia. Okay, amblyopia, if there is vision deprivation, even if it is bilateral amblyopia can develop.
Okay, sir.
Okay, the other thing is, what are the different materials used for sling surgery?
Sir, to frontalis link surgery, it is done in our simple severe ptosis and markers with jaw winking phenomena and with poor LPS function.
No, I said, what are the materials used? Can you just tell me what are the different materials which can be used?
Sir, we can use from the same patient, we can use fascia lata, which is extracted from the thighs, or we can use artificial materials such as nylon thread, silicone threads.
Okay, fine. Thank you. I think you can move on to the next speaker now.
Yes, sir. I invite Dr. Anshu Khare ma'am to moderate session ahead.
Yeah, thank you. Thank you, Sonam. Now I would invite Dr. Anubha Chaube from GRMC Gwalior, and her mentor is Dr. D.K. Shakya. She is going to present her case on LASIK unseen thread, corneal thinning and glaucoma. Dr. Anubha?
Yes, ma'am.
You can share your screen.
Yes, ma'am.
Anubha, are you there?
Yes, ma'am.
Just share your screen.
Ma'am, actually, there's some issue in share.
Are you able to? Okay.
Ma'am, is it available? Is it
Yeah,
visible now?
we can see. Yes, we can see your screen. Enlarge it.
Yes,
Okay. Okay, now you can present. Yes.
Yes, ma'am. Thank you, ma'am. Good afternoon, everyone. This is Dr. Anubha Chaubey from Department of Ophthalmology.
Your voice is not audible, Anubha.
Hello.
Anubha, you have to speak loudly. Keep your mouth close to the mic.
Ma'am, is it now audible?
Very faintly, little more. Anubha?
Yes, ma'am.
Hello.
Now it is audible.
Good afternoon, everyone. This is Dr. Anubha Chaubey from GRMC Gwalior with my mentor, Dr. D.K. Sharkya, sir. I'm going to present a case of LASIK's unseen thread keratosis, glaucoma. My 33-year-old female resident of Gwalior, teacher by occupation, presented with a diminution of vision in both eyes since 2 years. The patient was apparently all right 2 years ago. Then she developed a diminution of vision in her left eye and a progressive decline in vision in left eye. This was followed by a similar and gradual progressive loss of vision in the right eye, which began 6 months ago. It is associated with difficulties in driving due to reduced peripheral field of vision and in near work. It is also associated with ocular discomfort, frequent headaches, halos around light, and frequent changes of glasses. The patient denies any pain or floaters. There was a history of LASIK surgery in both eyes in 2020 in Delhi. Her pre-LASIK refractive status in right eye was -5 diopter spherical, -1.25 diopter cylindrical 180-degree axis, with her best corrected vision was 6.6, and in left eye it was -5.25 diopter spherical, -1 diopter cylindrical 45-degree axis 6.6. There was also prolonged use of topical steroids post-LASIK, and there was no any other significant past or personal history. Her general physical examination was all normal. Her vitals were all good. On an ophthalmic examination, her best corrected vision was 618 in right eye and 618 part in left eye. Her near vision was N8, N10, and her NCT was 19 and 16. She was prescribed the glasses of -2 diopter spherical, -2.50 diopter cylindrical with 35-degree axis. And in left eye, it was -1.5 diopter spherical, -2 diopter cylindrical, 140-degree axis with 618 partial vision. On NCT, it was 19 and 16, and 80 was 18 and 12 in right and left eye. When CCT was done using ultrasound pachymetry, it came out to be 356 micrometer in right eye, and in left eye, it was 363 micrometer. After which the corrected IOP was calculated, which came out to be 29.7 in right eye and 26.2 in left eye. For fundus examination in right eye, it was 0.5 cupping with inferior thinning, and in left eye, there was a significant cupping of 0.8 with inferior and superior thinning with inferior notching, and there was nasal shifting of blood vessels. On indirect gonioscopy by 2-mirror gonio lens, it was open angles in both eyes. Visual field analysis was done by perimetry in right eye. It has shown a significant moderate glaucoma. And in left eye, there was generalized depression with macular involvement, suggesting of advanced glaucoma. When corneal topography was done by pentacam in right eye, it was a post-LASIK ectasia to be noted here, with an average progression index noted to be 2.74. And there in left eye, the similar ectasia was seen in the left eye also, with pachymetric thinness is around 367, and her average progression index was 2.59. This was her pre-operative corneal topography showing the central corneal thickness of 488 in right eye and 487 in left eye. On comparing her pre-operative findings with post-operative and the findings on the day of presentation, her vision was 360 pre-operatively, which got corrected to 6.9 and 6.12 after the LASIK surgery. And now she presented with 6.36 and 6.60 vision in her both eyes. She was given a spectacle correction of this particular thing. And her CCT, which was 488 and 487 pre-operatively, came down to 356 and 363. Her true IOP was 29.7, 26.2, and there was advanced glaucomatous changes in her fundus finding.
That came out to be a final diagnosis of post-LASIK keratosis with secondary steroid-induced open-angle glaucoma in both eyes. She was given the treatment of travoprost, brinzolamide, brimonidine, and timolol. The intraocular pressure was stabilized at 15 mmHg by 4-drug therapy. The regular follow-up and adherence to treatment were emphasized to prevent the future complication, and patient was advised for the filtration surgery, but the patient refused. The presented case highlights the critical role of comprehensive preoperative with borderline corneal thickness undergoing the LASIK surgery. Post-surgery requires consistent monitoring to detect early signs of complications such as corneal ectasia or glaucoma, which have significant impact on the vision if left untreated. Hence, the accurate measurement of intraocular pressure, that is the corneal thickness corrected IOP, is vital for diagnosing these conditions promptly, and a comprehensive approach involving careful patient selection, advanced diagnostic technology, and timely intervention is essential to detect and manage the potential complications effectively to preserve the optimal vision for patients undergoing LASIK. Thank you.
Dr. Anupa, what was the indication for prolonged postoperative use of steroids in this patient?
Actually, so she was using it impromptu. Whenever she has ocular discomfort or something, she uses her prior drops, which consisted of prednisolone and moxidexa. So there was a long use of steroids.
Okay.
Dr. Rashmi, any question?
No, let sir continue. After that, sir, you please continue.
Sir, please.
No, ma'am, please carry on. I'm done.
If a patient comes to us post LASIK surgery, what would be the good way to record intraocular pressure?
The best way is to record the CCT first, and after which the corrected IOP, because mainly after LASIK surgery, her corneal thickness falls depending upon the residual thickness. And so
Goldman applanation, you are saying Goldman applanation, CCT corrected Goldman applanation. Is that what you're mentioning?
Using pachymetry or using an ultrasound pachymetry. Then when we use a formula, mainly the Ehler's formula, to calculate the corrected IOP.
No, you haven't understood the question. What ma'am is asking is, which is the best method? Is it applanation? Is it indentation? Or is it some other method?
No, ma'am, it can't be.
When the correction can be done, fine. You can do the correction depending on the corneal thickness. But what is the best way to measure in a post-LASIK patient?
So indentation can't be the best method because it depends upon the corneal thickness. So an alternate method should be there to measure the IOP.
You're still beating around the bush. You've not answered the question. Which would be the best method? Is it NCT? Is it 80? What?
So it can then be 80.
Okay, you are aware of different ways of measuring, right? Please do read up about it, because when you present LASIK, care of a patient post LASIK is different from how you would normally do care of other patient. Okay, so do read that up. Well presented. All right.
And one more, sorry, one more thing. Please get out of this habit of writing NCT 15 and 16 millimeters. It is the IOP, not the NCT. Okay. You're supposed to write the intraocular pressure is 15, 16, and in bracket you say the method by which you have measured it, whether it is 80 or NCT or sure, whatever.
Thank you, sir.
Ma'am.
Any questions for the judges?
I think is slightly unusual because with the residual bed of 350, 360 microns, I think it is probably because she developed secondary glaucoma that again the cornea has become ectatic. Otherwise, normally with the residual bed of around 350, 360, generally they tend to be stable.
Yes, an additional factor was there of glaucoma due to raised IOP.
Yeah.
She developed
That's probably what caused the ectasia again. And what was the vision corrected BCVA now?
So it is 618 in both eyes.
Not improving beyond that.
No, sir.
All right, I have no questions.
Thank you, ma'am.
So can we proceed to next case?
Yes, please do.
Okay, thank you, Dr. Anubha. Now I would invite Dr. Anushila Trivedi. She is also from GRMC Gwalior, and her mentor is Dr. Rashmi Kujur, and she is going to present on ocular tuberculosis, impact and manifestations. Dr. Anushila.
Good afternoon, ma'am. Good afternoon, ma'am. Am I audible?
Yes, you are very well audible.
Yes,
Just
ma'am. I'll share the screen. Yes. Yes, ma'am. Is my screen visible?
No.
Now, ma'am?
Still not visible.
Okay, just a second. Is it visible now, ma'am?
No, beta, it's not.
Not. Okay.
If you have someone around to help, you can ask.
Yeah, sure, ma'am.
Dr. Anuba, who just presented, is she around you?
Yeah, ma'am. She's around me.
Okay.
Okay, you can ask for her help.
Yes.
I would also, the next presenter will be Dr. Pooja. So I would request her to keep herself
Ma'am, it's
ready.
coming now?
Yeah.
Yeah. Okay. Okay,
Yeah,
ma'am. I'll just start my presentation.
Okay.
Good afternoon, respected ma'am. Myself and sir, myself Dr. Anushila Trivedi, and I'm presenting a case presentation on the topic ocular tuberculosis, impact and manifestations. A 20-year-old female student by occupation, resident of Gwalior.
Just a minute, Anushila, can you please switch over to slideshow?
Slideshow. Yes, yes, sir. It's on slideshow only.
Make it full screen.
No, full screen.
Okay,
Make
so
it
just
full
a
screen,
second.
yes.
Click on the slideshow logo.
Acha. क्यों नहीं आ रहा?
See where home is written on the fifth
Yes.
bar, fifth place. You have slideshow written.
Move your cursor
See
to
your
the
home.
right. Move your cursor to the right. Slideshow.
Yes, ma'am. Actually,
where it's written slideshow, go there.
है ना, यहाँ पे आ नहीं रहा. There's no option for slideshow.
Option is shown, beta.
Insert, design.
Ma'am, is it? Beg your pardon, ma'am?
Not yet.
At the top, home, there is written home. Next to it is insert, then design, animation, and then slideshow. Topmost. Yeah.
Top. Next to animation. On the top tabs.
Top, yeah.
Yeah, you can see a slideshow word. Next to your home tab. Yeah.
Actually, ma'am, in my laptop, it's not showing the option. It's
Okay,
getting
no
hidden
problem.
by
You
the
continue.
other.
It's
Okay,
okay.
I think then you continue.
You continue, no problem.
If you're not able to, then continue, please.
Yeah, ma'am.
But please move the slides along so we can see the slides.
Yeah, sure, ma'am.
Okay.
Sure. Now I'll start, ma'am. Now I guess it should come. Is it coming? No, ma'am?
No.
Okay.
I think you should just continue now.
Just continue, it's okay.
Okay, ma'am. Okay. Chief complaints. A 20-year-old female student by occupation, resident of Gwalior, presented with complaints of diminution of vision in right eye since 2 months. Patient was apparently asymptomatic 2 months back. Then she developed diminution of vision in right eye, which was insidious in onset and gradually progressive in nature, associated with repetitive episodes of redness and floaters in right eye since 1 year. It is associated with pain, which is intermittent in nature and relieved on medication. It is associated with anorexia, low-grade fever, night sweats, fatigue, and 6 kg weight loss since 1 year. Not associated with any watering and discharge. No history of ocular trauma and ocular surgery, family history and person history, nothing significant. On the examination, patient was moderately built and nourished, oriented to time, place, person, vitals were normal, systemic examination was within normal limits. On slit lamp examination, on ocular examination, the visual acuity in right eye was counting finger 3 feet, and on pinhole it improved to 6/18. Best corrected visual acuity by -2.0 diopter spherical correction was
Please change your
6/18.
slide. You're showing the previous slide and you're, I think, reading up from the next slide.
So there's a lot of internet issue over here. I'll just check, sir. Is it changing now, sir?
No.
Sir, just give me a few minutes. I'll shift to Dr. Anubha Chaube's laptop and I'll be back, sir. Hello.
So look at profit to you. Look
Can we instead take Dr. Pooja Narvaria?
Ma'am, I'll be back with Anubha Chaube's laptop. Can you give me 2 minutes?
Can we take the next presenter by that time?
Yes,
Yes, let's
ma'am,
take
please.
the next.
If she's ready,
Yes,
let us
ma'am. Yes, ma'am, I'm ready.
Dr. Pooja, please start sharing your screen.
Am I audible?
Is it Dr. Pooja?
Yes, ma'am. Yes, ma'am.
Okay, so Pooja will be
Please come in.
presenting. She's from Index Medical College, Indore, and her mentor is Dr. Sonali Mittal. She's going to present a case on retinoblastoma. Pooja, you're ready?
Yes, ma'am. Am I?
Yes, you are audible. Now you just share your screen. Okay, make it full screen.
Is it good, ma'am?
Go to slideshow.
I've started slideshow. If that's not working, I'll try again. Is it visible, ma'am?
Yeah, but you're not in slideshow.
Sir, I have done. I guess it's not working yet.
On your computer, there'll be another window which
Yes.
might have opened.
You can go down, extreme down to your
That is
right.
better.
There must be one icon for full slide.
Yeah, where
That is the better
64%
option.
is written, right?
You go and switch on, click on that.
Yeah, next to the next to that
Extreme right.
Yes, next to
Yeah, this one, that's right.
Correct. Click on it.
Okay. Good morning, ma'am. Good morning, everyone. I'm Dr. Pooja.
The slide?
No. You're on the slide sorter view.
Your slide
Next to
sorter
that,
view.
yeah.
Go to
Next to that,
slideshow.
there is the slideshow.
Actually, all of you should have presented many
Driving.
times. You should have experience in presenting and setting up your slideshow.
Icon will be similar to like the from beginning and from current slide. It will be similar to like this. Just click on that.
Now it is
Pooja?
fine. I think now it is fine.
Okay.
So please continue then.
Okay. Good morning, everyone. I'm Dr. Pooja Narvaria from Index Medical College, and my mentor is Dr. Sonali Mittal. I'm here to present a case of a 5-year-old female child was brought by parents resident of Satwasganj, Indore, with chief complaints of huge orbital mass protruding from right eye since 4 years, pain around right eye since 4 years, and loss of vision in right eye since 3 years. History of presenting illness, as narrated by parents, is noticed white reflex in right eye.
Sorry, your slides are not moving. Pooja, sorry. The slide is not moving.
Sir, can I just read it out from this?
Yeah, now it is fine.
It's moving now. Continue.
Okay. As narrated by parents, they noticed white reflex in right eye of the child few months after birth. They noticed 4 years back she developed forward bulging of right eye associated with pain, which was progressive in nature, redness, watering, and loss of vision. Then they noticed a mass protruding gradually from eyeball, which increased progressively. It was associated with malaise and lethargic behavior. Since 3 years, they noticed that it has developed into fungating mass, which was progressive in nature. It has increased to huge orbital mass suspending from right orbit, measuring 10 into 10 into 15 centimeter. The parents had shown to some general practitioner who advised them to come, but no regular follow-up. Left eye showed no perception of light and showed signs of phthisis bulbi. The patient was highly irritable. This was the picture of the patient when came to our OPD, showing fungating mass protruding from eyeball, measuring 10 into 10 into 15 centimeter. Past history, on detailed history, it is a case of normal vaginal delivery with no history of maternal infection during pregnancy. Child had history of birth asphyxia at time of birth, history of hospitalization in ICU after birth for 15 days. The child had history of repeated falls and irritable behavior. No history of any similar illness in any family member, no family predisposition to develop cancers in body, and no major surgeries in past. No history of TB and bronchial asthma. Family history, no history of consanguinity, no history of similar illness in siblings. Patient had one sibling and who was 1 year old. No history of eye loss in other family members. Personal history, the diet was mixed in nature, appetite decreased. Bladder bowel was altered, sleep was irregular, and no history of addiction. Immunization history, well immunized till date. Status of BCG vaccination was uncertain. Milestones were delayed and verbal of motor both were normal.
General examination, patient had an average build, conscious and highly irritable. The general condition was malnourished. Rest all the possibilities were not, no abnormality were detected. Ocular examination, the patient was highly incooperative and irritable. The head posture was normal, face was asymmetrical. Eyeballs in the right eye, the protruding fungating mass was suspended from right orbit, showing 10 into 10 into 15 centimeter. Left eye showed signs of phthisis bulbi. On palpation, right eye that was not reducible, formed to hard consistency. Ocular movements were not recordable. Uncorrected visual acuity was no PL in both the eyes. Eyebrows were present at the same level. Lids were edematous, covered under mass in the right eye, and left eye was normal. Lashes were not visible. Lacrimal area was not recordable. This is the picture. Ocular examination of conjunctiva and sclera in the right eye, they was not visible. Left eye was not recordable. Sclera was thickened and stuffed in the left eye. Cornea was stiff and cloudy. Rest all details were not recordable. Investigations and routine metrological investigation, hemoglobin level was 9.4. Rest all the investigations were normal for this patient. We did the USG-B scan, which shows variable calcified mass-like lesion involving entire globe with intralesion hyperreflectivity. Lens echoes were not noted. CT orbit was done. CT finding revealed evidence of large lobulated pedunculated soft tissue mass lesion, which emanated from the right orbit with a large exophytic component. The mass lesion extends in the periorbital spaces, stretching and displacing the intraocular contents. No intersinus intracranial extension seen. The left globe was distorted morphology showed and small and contracted, tiny calcific foci seen in intraocular compartment. MRI imaging was done, showed evidence of well delineated multilobulated isotense soft tissue lesion near completely occupying the vitreous chamber of right globe, measuring 10 into 10 into 15 centimeter. Areas of calcification also seen within it. The optic nerve appears uninvolved. By this, my definitive diagnosis was group E, extensive retinoblastoma in right eye and phthisis bulbi in the left eye. Differential diagnoses were orbital cellulitis, congenital cataract, port disease, ocular textocariasis, and PHPV. The treatment, the child was referred to the higher center as our institution didn't have the facility for it. But the treatment protocol includes the multimodal therapy, chemotherapy for that standard dose and the high dose regimen, the carboplatin, including carboplatin, vincristine, etoposide. Focal therapy, including cryotherapy, laser photocoagulation, thermotherapy, plaque radiotherapy, and external beam radiotherapy. We can do enucleation, palliative therapy. Recent advances include local chemotherapy administration, ophthalmic artery chemosurgery, intravitreal injections, intracameral therapy, periocular intrathecal chemotherapy, gangliosides, and other targeted immunotherapy, gene therapy, and oncolytic virus treatment. Thank you.
Over to the judges.
So this patient apparently has had bilateral retinoblastoma, right? So did you actually examine the siblings? Did you examine the parents and the siblings? Because almost about 20% cases where the retinoblastoma is bilateral tends to be sort of hereditary.
Parents for the examination, we had their CT scan. The 1-year-old child they had, मतलब उनके पास उसकी भी reports थी sir. So that child was totally normal and parents had no gene detection for the same.
And the other thing is they detected, as per your this thing, the sort of growth was detected in the eye just soon after birth, or maybe 4 months after birth, and yet they came to you after 4 years.
Yes, sir.
Okay, the other thing is when you're making a differential diagnosis, your differential diagnosis is supposed to be based on your clinical findings, right?
Yes,
when you
sir.
have a match like this, where there is a fungating growth, your congenital cataract and the other DDs of leukocoria will not come into the picture. It is only if the patient is presenting to you as leukocoria, then you have that DD. In a growth like this, you can take other malignancies or any other growth which looks similar. That will come in the DD, right? Not the DD of leukocoria.
Okay, sir. I'll note that.
Okay, fine. Okay, ma'am, please.
So, Dr. Pooja, you said that the optic nerve seemed to be free of the disease.
Ma'am, on CT it was free of the disease, but on the MRI it was shown that optic nerve was also involved in the.
So, how do you think the patient had bilateral retinoblastoma? Did it spread from one eye to the other or something else?
Ma'am, usually it is binocular, it is bilateral tumors in the most of the cases.
So bilateral because of spread or something else?
Ma'am, it is because of spread. Because of the evidence showing by MRI.
No, it is not always because of spread. It could be the two tumors arising in each eye. Tell me, what is trilateral retinoblastoma?
Ma'am, it's retinoblastoma plus pinealoblastoma.
Sorry?
Pinealoblastoma, ma'am. It's retinoblastoma plus pinealoblastoma.
Yes. So, it can be arising from multiple foci.
Yes, ma'am.
And as sir said, your differential diagnosis was absolutely out of sync with your case.
Yes,
which is not the way to go about a case presentation. Okay, thank you.
So you mentioned about Group E. Which classification are you referring to when you say Group E? And
Ma'am,
what
it's
is the basis of
International
this classification?
Classification of Retinoblastoma. International Classification of Retinoblastoma, ICRB.
What is the basis of this classification?
Ma'am, it's depend on the prognosis and the location of the tumor.
No, what is the basis? It helps in prognosis.
Yes,
what is the basis of this classification?
Ma'am, like if it's only involving less than 3 millimeters from the retina, so Group A just needs chemotherapy.
Okay, so what are the three factors which determine these categorization? What you're telling me is the details. So what is it on basis of which we classify in this?
Ma'am, vitreous, phobia, optic nerve, and the vitreous seeding.
Okay, any other classifications you know?
Ma'am, Rees-Ellsworth classification.
What is the basis of that classification?
It also depends on the. Sorry, ma'am.
Okay. So, case like retinoblastoma, right? Please do read about the classifications, the stagings. All right?
Yes.
Okay. All right. Okay. Thank you very much.
Can we go for the other case, the last case? Dr. Anushila?
Good afternoon, ma'am. Am I audible?
Yes, you're audible. You're ready?
Yes, ma'am, I'm ready. I'll
Okay,
just...
Okay, Dr. Pooja, please switch off your screen. And Dr. Anushila, now you share your screen.
Okay, ma'am. Good afternoon, ma'am. Respected sir and ma'am, myself Dr. Anushila Trivedi, and I'm presenting my topic on ocular tuberculosis impact and manifestation.
Yes, Anushila, continue.
Yeah, chief complaints, a 20-year-old female, student by occupation, resident of Gwalior, presented with complaints of diminution of vision in right eye since 2 months. History of presenting illness, the patient was apparently asymptomatic 2 months back. Then she developed diminution of vision in right eye, which was insidious in onset and gradually progressive in nature, associated with repetitive episodes of redness and floaters in right eye since 1 year, associated with pain, which is intermittent in nature and relieved on medication. It is associated with anorexia, low-grade fever, night sweats, fatigue, and 6 kg weight loss since 1 year, not associated with watering and discharge. No history of ocular trauma and surgery, family history and personal history, nothing significant. On examination, the patient is moderately built and nourished and oriented to time-place person. Vitals were normal. Systemic examination was normal. On examination, visual acuity in right eye was counting finger 3 feet. On pinhole, it improved to 6/18. Best corrected visual acuity with -2.0 diopter spherical lens was 6/18. Near vision, color vision normal. Cornea had mutton fat KPs present in R's triangle along with fine KPs. Aqueous cells grade 2 and vitreous cells grade 2 were seen in AC. Pupil was semi-dilated and fixed under drug. Iris multiple adhesions were present over 1, 3, 6, 11, and 12 o'clock. And iris pigment over anterior lens capsule was seen. And IOP was normal. Rest of the anterior segment examination was normal. In left eye, the visual acuity was 6/60. On pinhole, it improved to 6/18. Best corrected visual acuity was -2.0 diopter spherical and improved to 6/18. Near vision, color vision was normal. Rest of the anterior segment examination was within normal limit. Cornea had old, healed, fine KPs in R's triangle. On fundus examination via indirect ophthalmoscopy, red glow was seen. Media was hazy due to vitritis and vitreous obesity. Disc size shape was normal. Margin was blurred with disc edema and disc pallor was present. General fundus was tessellated with multiple discrete yellow lesions seen in the posterior polar fundus of approximately 1 to 2 mm in size, present temporal to the macula, suggestive of choroiditis. Blood vessel was normal. FR was present. Left eye, the examination was normal. Only the color of the disc was temporarily pale. Investigations, HRCT lungs were suggestive of small calcified mediastinal lymph node with right-sided pleural thickening and small calcification, which is sequelae of infective etiology, likely pulmonary tuberculosis. ESR was raised. Hemoglobin was low. EGRA was positive. Blood picture was suggestive of microcytic hypochromic anemia. ANA was non-reactive. HIV status was non-reactive. TBHA was non-reactive. ACE was within normal limits. RA factor was non-reactive. A diagnosis of right eye granulomatous uveitis with post-neuritic optic atrophy secondary to pulmonary tuberculosis was made. Patient was started on ATT drugs after consultation with a TB chest physician. Eye drop prednisolone was given for 6 times a day. Eye drop homatropine 3 times a day with vitamin C. After 2 weeks, the patient was called on follow-up and was advised posterior subtene and triamcinolone injection under guarded visual prognosis, which she refused and thus was started on PAP prednisolone 50 mg OD for 15 days along with Pantop. Discussion. Ocular tuberculosis is an uncommon extrapulmonary presentation of Mycobacterium tuberculosis infection, typically manifesting through hematogenous spread from pulmonary sources to the uveal tract. Its clinical presentation often mimics other ocular conditions such as sarcoidosis, syphilis, toxoplasmosis, toxocariasis, and fungal infections, particularly presenting as panuveitis, necessitating a vigilant approach for accurate diagnosis. This review focuses on key fundoscopic indicators associated with ocular tuberculosis and outlines the optimal management strategies for these lesions. Conclusion, therefore, a comprehensive approach involving an interdisciplinary team is crucial for diagnosing ocular tuberculosis accurately. By conducting thorough investigations and considering a wide range of differential diagnoses, clinicians can effectively uncover the underlying systemic pathology associated with this challenging disease. These are the references. Thank you.
So can I take up the first? Over here,
Please,
I'd
ma'am.
like to say, thank you, sir, thank you. I'd like to say, Dr. Anushila, your presentation and many other residents also, you don't make very good presentations, you make very long ones. There's a rule of 6 for every slide, you know, no, not more than 6 lines on one slide and not more than 6 words in one line. All right, so don't write paragraphs, don't make very amateurish slides, don't make it a textbook which you're just reading out.
Yes, ma'am.
Paired with your case, this is not the way of presenting that you are writing whole textbooks and just reading out of that.
Ma'am, just 1 second. Can she stop sharing? Can you please stop sharing?
Yes, ma'am.
Yeah, thank you. Yeah, ma'am, please. Thank you.
That is what I wanted to say about her presentation, because you know this is something very basic they should learn.
Okay, Anushila, I think you were also either you have not gone through your presentation, you were contradicting yourself in the conclusion. You said that clinicians should go through a wide range of differential diagnosis, investigate. You have not given any differential diagnosis. Straight away, you've gone to HRCT and said this is a case of tuberculosis. When you're presenting a case, you must have a differential diagnosis. Then you follow up with investigations depending on what you are suspecting, all relevant investigations, and then you come out to a final diagnosis.
Yes, sir. Yes, sir.
Any other questions from the judges?
You like to give us a differential diagnosis of only this case, not the textbook picture of the case which you saw.
Yeah, yes, ma'am. Actually, a patient presented to us with the diminution of vision, and she came along with the HRCT report, ma'am, which was suggestive of pulmonary tuberculosis, and she did not take treatment anywhere, ma'am. And thus, and on fundus examination and on
differential. See,
differential.
do not tell
Yes,
us the
ma'am.
display. Please tell us the differential.
Yes, ma'am. It could be syphilis, ma'am, or sarcoidosis, and it could be toxoplasmosis, toxocariasis, and Yes, ma'am. These are the differential diagnosis.
Okay, thank you very much. Thank you.
Yes.
Back to sir.
Okay. So, thanks all the PG students for interesting cases, and I hope everyone has noted what the judges have to tell you. And I think in next presentation you will take care of all those points. So, coming to a very interesting topic away from the clinicals, I have with us my beloved friend and alumni of MGM Medical College, Dr. Neelam Pawar. She's currently a research scholar at University of Michigan, USA, and she's also pursuing PhD at the University of Maastricht, Netherlands, on artificial intelligence in myopia in pediatric and adolescents. She's senior consultant and pediatric ophthalmologist and strabismologist at Arvind Eye Hospital, Tirunelveli, Tamil Nadu. And she is been from 23 to 24. She's been micromaster in public health, and she has done short-term observership in pediatric ophthalmology and strabismus at Julestein Eye Institute from Baltimore, USA, from Wilmer Eye Institute and UCLA Los Angeles. So, and she has not many publications. I have a whole list of publications to her name. So I would invite Dr. Neelam Pawar to present on a very interesting topic, My Journey, Triumph and Trials of Women in Ophthalmology. Dr. Neelam, over to you.
Ma'am, with your permission, can I just take a minute?
Yes, sir.
Okay, firstly, I would like to congratulate all the speakers and their mentors for a wonderful job done. Even the first years have done. It is very creditable to make a presentation online in front of, different judges and all that. So they've done a good job, including, and the mentors have sort of guided them well. Second is, I think, what I find is all the presenters were women. So I think next time probably a time is coming when ultimately we will have to see men and ophthalmology separately. The ophthalmology is going to be taken over by women. And last but not the least, I would like to thank Dr. Anshu, Dr. Sonam, and Dr. Shweta for having us involved in this wonderful program. Thank you so much.
Thank you so much, sir, for joining.
Thank you for your valuable time, Dr. Aluwalia sir, Dr. Lima ma'am, and Dr. Rashmi ma'am. We invite Dr. Neelam Pawar ma'am to please share her experiences.
Yeah. Good afternoon, everybody, and thank you, Anshu, Dr. Anshu, for kind introduction of my short journey. I would also like to thank the WSO team, Dr. Mohita, Dr. Shweta, Dr. Anshu, and Dr. Sonam to bring me into this podium after so many years graduating from Indore Medical College. And I would like to share in short about my journey of trims and trails of women in ophthalmology. So I have finished research fellowship at Kellogg Eye Hospital just back, and I have resumed my original position as a consultant in pediatric ophthalmology and strabismus at Arvind Eye Hospital, Tirunelveli, Tamil Nadu, India. So a career for a woman in ophthalmology is always challenging, and we have to always make a balance between our career and life. And if you do get a chance to read this book, it is worth to read this book, though so many of things, they are from Western countries, but still it is always better to go into books like this specifically for women. And during my career of my ophthalmology career, right now, somehow I have motivated and more attracted towards philosophy. So I keep on reading books and listen to audiobooks in my free time. And I always tell everybody and to juniors that always try to transform yourself, identify the short, small-term and large, long-term goals in your life. And for an ophthalmologist, surgery is our main life, and we know that there's a steep learning curve, which is not easier, smoother, and quicker. And during our initial period of our residency or fellowship, the aim of our life has to be totally concentrated only on surgery, because this is the time during which you can acquire good surgical skill, which will always help in your future life. Once they've acquired good surgical skill, then you can think about changing. You can learn so many other things, because change is the sign of growth and progression, and better to open to new ideas and innovations. For me, it was a very difficult journey to leave foodie city of Indore and the vibrant culture of Indore, and to get shifted to a small city down in south, which was having a very conservative nature, new people, new language, new surroundings. But with time, I got adjusted, and this conservative approach made me my journey traveling from benzos to falafel or gyros, and having a worldwide international travel and interacting with international people and doing work with them. So long back in 2006, I finished my MS under guidance of Dr. Pushpa Verma, Dr. Ulka Srivastav, Bhai Sare sir, and we had a lovely team of our department, including Dr. Shweta, Dr. Shruti is also here. We were really blessed to have wonderful seniors and colleagues like Anshu. So it was a good family. And I always believe when you work with good people in your life, you approach and God makes you to go into a good place. So in 2006-07, I traveled from Indore to Madurai, but unfortunately in Madurai, that time fellowship was not available. So I joined in Arvind Eye Hospital, Tirunelveli, which is near to Kanyakumari. And currently we are having 7 tertiary care centers of Arvind Eye system, and which caters around 1,000 to 2,000 patients daily. So the Arvind culture somehow incorporated me to become a high volume surgeon and clinician, along with the value, along with reaching the people, and with a financial sustainability. So in 2007, I traveled a long journey from train from Indore to Madurai, and that was the longest journey which I have ever done in my life in train, and which made me to travel around the world. So I always believe in the sine wave philosophy. After 2006, when I joined fellowship, there was a sudden deterioration in the earnings, and there was more about learning. So for any resident, you should always be prepared that these sine wave will definitely come into your surgical and into your career. There is nothing like only an uptrend. There will be always a downtrend, and again you can rise. So after doing my fellowship in 2009, I joined as a consultant in pediatric and strabismus department. And in 2019 and 2020, I moved to Indore with a corporate group, but somehow I was not finding a complete balanced life, and I again shifted back to Arvind Eye Hospital. So during my fellowship, I not only learned surgery. That time I had hardly done 1,200 SICs, but I trained national and international trainees. I was trainer for SICs and DNB, and my 2 years, I was only in OR starting from morning 6:30 to 5 o'clock. I used to be only in OR. I have not seen the outside world much. And unfortunately, because of this, I got vitamin D deficiency. So you should not do so much surgeries also. You should always take care of your health also. And I was never interested in publishing and presenting. So during this 2 years, I presented only one paper. And later on, I shifted to pediatric and strabismus department, thinking that I will reduce my surgery, but reverse thing happened. I became a high volume surgeon, and I used to operate a daily 50 to 55 SICs, and sometime near 2 century also. But same with the phaco and strabismus surgery also. But as I shifted into a new department, again there was a learning curve. I have to read more about pediatric ophthalmology and neuro-ophthalmology, and I spend more time in reading after my surgical hours. And during this tenure, I even trained many national and international fellows. So I had my first presentation on my specific area of research of topic on OCT in pediatric population. So that was my first international presentation, and later on almost every year I presented across WOC, APCRS on different topics on pediatric and phaco. So during that time, I had 3 or 4 publications. Those were in IGU and mainly about OCT in pediatric population. My another career was like it was an updrift in my career when I went to Jules Eye Institute in University of California, Los Angeles, which totally changed my perspective of pediatric ophthalmology and strabismus. And even I was fortunate to observe Dr. David Guyton, and Dr. David Guyton is son of Dr. Arthur Guyton. And you might be knowing that Dr. Arthur Guyton was the author of our physiology book in MBBS. So it was very good to always observe him about the physiology. He always used to talk about the physiology of the strabismus and was the person who will always think in a different manner. So in AAO in 2016, I had my first presentation in American Academy of Ophthalmology, and in Refractive and Subspecialty Day, I presented on femto laser cataract surgery, which were again published in journals. And after coming from USA, I got opportunity to be CyberSight Live faculty consultant, which is academic-based organization based in New York, and almost for every year I'm giving lectures for them, and it has again helped me to build international community and to talk to people around the world. And among my other publications, I have almost more than 60 publications, but this is worth to mention because this case report was highlighted, and it made the cover photo in Journal of American Association for Pediatric Ophthalmology and Strabismus, and it was about OCT documentation of optic atrophy in non-syndromic craniosteosis and lacunar skull. And then later I had other couple of case reports in JAPOS, and what PubMed says, it shows about 43 of my papers which are in indexed, and rest around 15 to 20 are in non-indexed journals. I don't always aim for awards, but somehow in 2022, I got a gold medal from Tamil Nadu Ophthalmic Association for maximum publication, and I got AIUS Best Poster Podium Presentation in 2023. And this year, though I was not here, but my husband received this Best of IGO certificate of 2023, in which I published about refractive profile of children who were treated with intravitreal Avastin in ROP babies. And I got one award this year on name of Dr. Merlin Miller Lecturer 2024 by Nigerian Pediatric Ophthalmology and Strabismus Society. So these are some of the activities which I am involved with the AIUS, and I'm like routine thesis, free paper, and IC evaluator. And because of all these academic activities, I got to be an academic editor in a +1, which is a very reputed journal. And I'm reviewer in Journal of Glaucoma, and usually I review papers on pediatric OCT and BMJ, BMC Ophthalmology and Ocular Therapeutics, and there are other journals in which I am reviewer and I am in editorial panel. And being a reviewer, though we don't get any financial benefit, but it always helps in communicating with people, academic people and clinician scientists around the world. It enhances the knowledge, and it gives a moral responsibility that before deciding any paper to get published, like we have a lot of responsibility what comes into reader's hand. And last year, it was a major breakthrough in my career that I was selected by Arvind Eye Hospital and University of Michigan to be a research scholar at Kellogg Eye Hospital, which is located in Ann Arbor, University of Michigan. And for public health, it is top 5 in US to get to do study in public health and biostats. So it is a candid moment that first day my daughter came with me to drop me in college for summer session in epidemiology. And during this time, I attended so many courses and classes of biostat, which were like a part of MicroMasters in public health. So even though this journey was very difficult, like studying after almost a period of 15 years and to compete with the American students, it was really difficult. But after 2 or 3 months, I was adjusted. Only problem was the 3 months snowing, which will disrupt my daily traveling to hospital and college. So this is the photo of our class in which 140 students, almost half of my age were with me, but I enjoyed being as a student for 1 year. And I did artificial intelligence work in research lab. This is my mentor, Dr. Nambi Nallaswamy. He's from Harvard. And first time in my life, I came across with so many people graduated from Harvard and from MIT. And really, they made me so much influence. And right now, my way of thinking has completely changed. And I'm also doing currently a PhD program by University of Maastricht, Netherlands, mainly on artificial intelligence in pediatric myopia and adolescent. These are my guide and co-guide. And almost every month, they will have a meeting with me. And I really like the inspiration of those teachers, though they are from other country and they treat me as a student. And they are always behind me that you should refine right now, whatever I have written, like in a very polite manner. And it is really very good to learn from people from other country that they are teaching us and they want us to improve. So really, I'm blessed that I am having all those good people with me. And because of my publication, last year I got to be interviewed another PhD scientist from Boston, Massachusetts, and he interviewed me. And in one paragraph, he mentioned about the myopia boom, and it was published in Nature Journal. And really, it is very tough. Nature is the journal which is having one of the highest impact factor among all scientific journals. And during last year, I traveled a lot besides my college and presented in various conferences, including American Academy of Ophthalmology, ARVO, and APOS, on various topics on sibling refractive screening, on myopia, and on strabismus. And in this 1 year, besides my biostat and epidemiology class, I took extra classes in engineering school and in artificial intelligence department to upgrade. And really it took me at last 10 months, I was able to know what is artificial intelligence. And again, I am grateful to all the mentors who have taught me. This was the D43 team who have already selected us and taught us, and still they are with us, like every day inspiring that you have to, beside being a surgeon, you have to be a clinician scientist. So all these slides were not to show that what I have done. It is just to show that at any point in career, you can build new skills and new career opportunities, because world is changing very fast. So you have to upgrade your skill always. And helping working women should find a balance for family. And behind every successful woman, definitely there is a man. I always thanks God that I'm blessed with my husband, who is a constant source of inspiration for me. Even my daughter, my parents, and even my homemaid and nanny, who always make me like supportive and make me to do all these things in my career. And for the women specifically, I would like to suggest that beside your surgical and academic career, please start do investing in stock market, buy gold, whether in the form of physical or bond, and have, I think the male ophthalmologist will not like this idea, but I would preferably tell each and every female, you should have a financial portfolio of your own, not combined with your husband. And always along with all these things, always give time your body for a physical and mental health. So again, back to sine wave philosophy, be prepared that life is not rosy. You will always have some downfalls, so always be prepared for it. And girls, the movement power should be like always, there should be a desire to fly. Thank you. Thank you very much for listening me. I hope I have not taken much time.
Thank you, Dr. Neelam. It is your journey is quite inspiring, and for the PGs, I think hearing all this, they must be really inspired, and we are also inspired, by you. And actually, we are very, very proud of you, and being your friend, and also the alumni of the same college. All of us are really proud of you. So thank you, Dr. Neelam. And for this session, I thank all the judges, Dr. Neelima, Dr. Aluwalia, Dr. Rashmi Jain, to take out their valuable time and teach the residents and tell them how they have to present. And I hope this session would be very, very useful for everyone. So not wasting much time, we'll move to the next session, next competitive session. The moderators for the next session are Dr. Kamla Lalwani and Dr. Manushri Gautam. So over to them. Dr. Kamla Lalwani, are you there?
Can you hear me? Yes, I'm here. Hello. Am I audible?
Your voice
We
is
would
coming very
request
feebly.
the session 2 judges to please share their mark sheets with us. Either Dr. Anshu ma'am or myself.
Yeah, session 2 judges, please share the mark sheets to Dr. Sonam.
So I would request for the moderators of the third session that please request the judges and the participants to stick to the time for the discussion and for the presentation, as we are running 1 hour late.
Hello, Dr. Shweta, am I audible?
You are audible. You can proceed, Dr. Kamla.
Hi everyone, I'm Dr. Kamla Lalwani along with my colleague Dr. Manushree Gautam. I welcome you for this session. This is a competitive session 3 and judges for this session are Dr. Deepak Mishra sir, Dr. Reema Rawal madam and Dr. Subneshwari Ganeshan ma'am. So firstly I'll introduce our respected judges. There is Dr. Deepak Mishra sir with us. He is a professor and PG teaching in charge at IMS Regional Institute of Ophthalmology, BHU. He's also holding a post of Honorary Secretary at ISM, SICS and WOS. He's Chairman ARC UPSOS and also Chairman PG Activity Acquired. He has authored almost 21 books and chapters, received 55 awards, including 15 gold medals and AIS Achievement Awards. He has published more than 120 peer-reviewed index articles. So I welcome Dr. Deepak Mishra, sir. Sir, are you here?
Yes, ma'am. Yes.
Okay.
Hello. Thank you, ma'am. Thank you for kindly.
Second is Dr. Subneshwari Ganeshan ma'am. Ma'am is senior consultant at Department of Ophthalmology, Shankar Netralaya. She's a head of vitreoretinal and oncology services. She's also project director of Lions Skill Transfer Training Program, and she has got principal interest in diabetic retinopathy, oncology, intraocular infections, and pediatric retinal diseases. She has published almost 59 articles in peer-reviewed journals and 4 textbook chapters related to retinal disease like ROP, retinoblastoma, VR, and ophthalmitis, etc. She's also been as a co-investigator in many international and national clinical trials and delivered many invited talks at national and international forums. So I welcome you, Dr. Subneshwari Ganeshan ma'am.
Yeah, good afternoon, everybody, and it's a honor and privilege to be here among friends and the junior friends who are joining this fraternity. Thank you.
Same here, ma'am. We are really honored that you are here with us. The third judge is Dr. Reema Rawal, ma'am. She's a professor of National Municipal Medical College, head of unit. She's got teaching experience of more than 19 years. She has authored many national and international publications too, including 2 chapters in glaucoma book of MSO by Dr. Surana. So I welcome you, Reema, ma'am.
Thank you.
Okay.
Thank you.
Okay. So can we start the session?
Yes, yes.
Okay.
Yes.
Our first presenter is from RKDF Medical College Hospital, Bhopal, Dr. Nikita Tomar. Dr. Nikita, are you here? Dr. Nikita?
Yes, ma'am. Yes, ma'am.
Okay. Her mentor is Dr. Vasudha Ramle, ma'am, and her presentation is eyes are windows to the systemic disease. It's a case of myasthenia gravis. So over to you. You can start.
Yes, ma'am. Am I visible, ma'am?
Yeah, you're visible and you're audible too. You can start.
Yes. My case is eyes are windows to systemic diseases. My patient, 50-year-old female patient residing at Bhopal. She's a housemaker by occupation. Her chief complaints are drooping of eyelids since 1 year and double vision on and off since 1 year. History of presenting illness. As per patient, she was apparently asymptomatic, performing her daily activities 1 year back. Then she initially noticed drooping of left eyelid initially while she is seeing herself, which was insidious in onset and progressive in nature. After 10 days, she noticed drooping of right eyelid, which was less than left eyelid, in a manner such that the patient noticed drooping worsen in evening, for which she went to the general physician and couldn't find any improvement, then referred to the ophthalmologist. Patient also noticed seeing 2 objects next to each other. Nikita, sorry to interrupt. Your slides are not moving. Okay. Wait, ma'am. Is it visible, ma'am? It's visible, but I don't see it to be moving.
We are still at the first slide. Yeah, now
Yes,
it is.
yes, now
Yeah.
it is, yeah.
Yes.
Okay. Can I start, ma'am?
Yes, please.
Yes, yes.
Now, her second complaint was patient also noticed seeing two objects next to each other occasionally, which was insidious in onset, began at the time when she noticed drooping of lids, which improved on closing her eyes after washing face with cold water. It was episodic in nature and worsened on reading, such that the patient longer ought to read. However, she didn't notice any difficulty in identifying the words, colors, and contrast. She has no history of nausea, vomiting, reduced hunger or satiety. There is no history of pain, redness, swelling, or trauma. There is no history of abnormal behavior, loss of consciousness, involuntary movements. There is no history of drooling saliva, deviation of angle of mouth, reduced hearing or nasal twang, or change in voice. There is no history of sensory system involvement. There is no motor involvement. There is no history of fever, weight loss, night sweats, chills. There is no history of breathlessness, chest pain, palpitation, and no history of abdominal pain, loose stools, vomiting, and altered bowel habits. She has no history of hospitalization, and there is no history of diabetes, hypertension, and asthma. She has no similar history in family. Her personal diet history consumes mixed diet, sleep adequate, and appetite was normal. Systemic examination is within normal limits. Head to toe examination was normal. Now she has vision, both eyes 6/6, near vision N/10, both eyes. In lid, the eyelids are ptotic. Right eye, it is mild, and in left eye it is severe. Lid crease was 1 mm in right eye and 12 in left eye. MRD1 was present in both the eyes. MRD1 was 2 mm and minus 5 mm. MRD2 was 5 mm in both the eyes, and levator function was good in right eye and poor in left eye. Rest anterior and posterior segments within normal limits. We have done some special tests like fatigability test. It was positive. Worsening of ptosis on sustained upgauge. Eye spec test was positive. Cogan tooth sign is positive. There is no meiosis, anhidrosis, or anophthalmos. There is no generalized weakness. Her gait was normal. We have done the acetylcholine receptor binding antibodies titers, which was high, more than 8 millismol per liter. Her blood investigation within normal limits. We have done NCCT thorax, which shows no evidence of thymoma. We have performed the eye spec test. Before eye spec test, the eyelid was this, and it improved after the eye spec test. So a provisional diagnosis was bilateral ocular myasthenia gravis, which was more in left eye than right eye. We have treated the patient with acetylcholinesterase inhibitor, pyridostigmine, 60 mg QID, and with oral steroids. So we have seen the improvement of palpable fissure height from 1 to 8 mm. And patient is on regular follow-up. Post-treatment, this was the picture. So my take-home message is a large number of patients have ocular features like diplopia and ptosis as per the primary presentation. Thus, careful systemic examination is required on the part of clinician. And as the patient is referred to us by a physician, as many systemic diseases can be diagnosed by proper ocular examination, and there's also need for prompt cross-referral amongst the neurologist, physician, rheumatologist, ophthalmologist for the holistic management of myasthenia gravis. Thank you.
Thank you for the nice presentation. Over to the judges.
So that's an excellent presentation, Dr. Nikita, like how the previous speakers are alluded to. I would also request that the busy slides to be avoided so it becomes easy for us to grasp what you would like to say, because it's a very interesting case.
Because of my screen is not fully coming, so videos are not able to play.
Yeah, that's okay. But keep it less in, the words have to be really less. So now moving on into the first question. What do you think your stage of myasthenia was in your patient? Or rather,
in left eye.
Yeah. Go ahead, please.
Yes, ma'am. Actually, right now, it is only the ocular involvement is seen. And in right eye, it was a severe ptosis, as we have noticed. It is covering full length of the cornea. And in right eye, it is initially started, like it is covering half of the cornea.
Now, what I exactly wanted to know was myasthenia gravis is a systemic disease. So what are the stages of myasthenia gravis? Do you know that there are multiple stages in myasthenia gravis? Or
Yes,
you're not aware about it? If you're not aware, just say no, it's okay, you can read it. Not a problem.
yes, ma'am. Right now, I can't remember. Sorry.
No problem. So was there, what was the, I mean, posterior segment findings? Do they have any posterior segment findings in
No more.
myasthenia?
No. Yes, ma'am.
Do a myasthenia gravis patient have any retinal findings also or not?
Ma'am, as in this patient, we didn't find anything. Fundus was normal, and disc and NNR thinning, everything is within a normal range.
Okay. Okay, fine. I'll request the other judges to kindly ask questions.
Am I audible?
Yes, ma'am.
Yeah. What are the options you will give for treatment of diplopia in a patient of myasthenia gravis?
Ma'am, we can give the occlusion device treatment, occlusive treatment, occlusion of one eye to.
That is, you're buying some time. Yeah, you're buying the time. Then next.
Yes, ma'am.
What is the role of prisms in myasthenia gravis induced diplopia? What stage you will give prism? Will you give prism or not?
In bilateral diplopia, we can give the prism.
What do you mean by bilateral diplopia? Myasthenia will always be bilateral diplopia.
Yes, yes, ma'am.
Unilateral is, yeah, that, okay. How will you follow up this patient? What all things will you look for in the follow-up?
Ma'am, we'll see the, as we're giving the pyridostigmine, we'll see the improvement. If it is improving, we'll continue with the treatment. And if it is not, we'll add on the steroids, oral steroids. And in severe cases, we can go for.
Go for what?
Ma'am, if it is not, the ptosis is not improving, we can go for surgery like a sling.
Okay. Yeah. One thing I would like to add, whenever in exam also you're talking about steroids, always make sure to add a line, I'll give steroids if not contraindicated. If not contraindicated. Form that a habit. Okay? Yeah. Over to the next slide.
Yes, ma'am.
What is the definite investigation for it?
Yes, sir.
Which test or investigation tells you as a confirmatory or highly specific for myasthenia?
So we can do ISPEC test, we can do neostigmine test. We can give.
I'm asking which is having high specificity or the definite test for to diagnose it. ISPEC test is not the definite test to diagnose that it is because of the myasthenia.
So we can do receptor binding, acetylcholine receptor binding antibody receptor test.
Okay. Next speaker, please. We can move to the. Thank you, Dr. Nitika, but follow the instruction of the ma'am. Make it the slide which is not to contain too much lines or the things. You have to make it PowerPoint in such a way that it hardly contains 5 or 6 to 8 lines only. Okay. Well presented.
Thank you.
Thank you, Dr. Nikita, and thank you to all the judges for their valuable opinions. Second is Dr. Mehika Dubey. Her mentor is Dr. Rajat Singh Yadav from the same college, RKD of Medical Department. Dr. Mehika, are you there?
Ma'am, actually participant is Dr. Rajat. That's me. My mentor is Dr. Mehika, ma'am. It was mistakenly written in the brochure actually.
It's okay. It's okay. You start.
Thank you so much.
Rajat, start sharing your.
Yes, ma'am, I'm doing that. Ma'am, is it visible?
Yes, it is visible and you're
yes.
Okay, you can start. Your time is 4 minutes. Again, I'll remind all the participants, it's 4 minutes for the presentation and 3 to 4 minutes for the discussion.
And all participants keep in mind that there is marking on the time also. So you have to finish it on the time. Okay.
So your time starts now.
Ma'am, is my slide visible on full screen?
Yes, it's full
Yes,
screen.
yes. Start, Rajat.
Thank you. Thank you. Good afternoon, everyone. Thanks to WOS for providing me this opportunity. I am Dr. Raj Singh Yadav, and my mentor is Dr. Mika Dubey, Assistant Professor from RKDF. I am presenting a case of viral endothelitis. My patient is a 60 years male construction worker from Bhopal, presented with diminution of vision in left eye since 4 months. As per the patient, he was apparently all right 4 months back when he started developing decrease in vision in left eye, which was insidious in onset, progressive in nature, and associated with redness, watering, and mild pain and photophobia. It was not associated with end discharges. He took treatment and was being treated on the line of suspected chemical injury, being a construction worker, but patient denies any history. Following treatment, pain and redness decreased, but vision loss is still progressive. There was no history of fever, ocular trauma, or chemical injuries. The past history was not significant. There was no any history of long-term medication also. Family history was also not significant, and personal history was not significant for this case. The patient was average build and conscious and well-oriented to time-paced person. Vitals were stable. On gross systemic examination, all are within normal limits. On ocular examination of right eye, the best corrective visual acuity was 6/9. There was nuclear sclerosis grade 2, and rest anterior and posterior segment were within normal limit. On ocular examination of left eye, the head posture, facial symmetry, ocular movements, lid, lacrimal apparatus, conjunctiva, all were within normal limits. Best corrective visual acuity was 6/24, and the cornea was rough and irregular, lusterless. The sensation was absent in all the 4 quadrants. There is a vascularization at 9 o'clock, which approaching from limbus to mid-periphery. Corneal stain was negative. The stroma was thickened and sectoral edema present, sparing the superior quadrant. Endothelium has fine diffuse KPs with Desmond membrane fold. There is a mild AC reactions. The iris was normal. The pupil was pharmacologically dilated. The lens shows senile immature cataract with nuclear sclerosis grade 2, and the IOP was 30 mm Hg by NCT, and digital tension was normal. So on fundus examination, right eye was within normal limit, and on left eye there is we see the red glow. The media was hazy, so details were not seen. On the investigation part, we have done the routine blood investigations, which were within the normal limits, and the patient refuses for anterior segment OCT due to financial constraint. So my provisional diagnosis is right eye nuclear sclerosis grade 2 cataract, and the left eye viral endothelitis with senile immature cataract with nuclear sclerosis grade 2. On the treatment part, we have given oral antivirals, and locally we have given cycloplegic corticosteroids, antibiotics, and anti-glaucoma drugs. The patient is stable after one week of treatment. So on the last part, discussion and take-home message. There are various etiology of endothelitis, such as infective, procedural, various systemic, and topical drugs. Thus, thorough history and clinical examination required for precise diagnosis and management. The topical steroids, it remains the mainstay of the treatment. The anterior segment OCT can be used to diagnose as well as to evaluate progression of endothelitis, but clinical diagnosis remains the first choice. And in this case, especially loss of corneal sensation in all quadrants and sectoral corneal edema played a key role in resolving the diagnostic dilemma. Thank you.
Thank you so much. Over to the judges.
So, Dr. Rajat, what was the etiology of your case?
Ma'am, it seems viral.
Okay, so what virus do you think would have caused it? Or is there a way to get to the diagnosis of the virus?
Yes, ma'am. Actually, the KPs were disciform, and it usually manifested with HSV, the herpes simplex virus. So my probable diagnosis is viral etiology with HSV.
So you said that your patient had a nuclear sclerosis of grade 2.
Yes, ma'am.
In future, when your patient goes for a cataract surgery, what
Yes, ma'am.
are the precautions that you would want to take on this patient or advise this patient even at this point in time?
Ma'am, for cataract surgery, first of all, we will resolve any AC reactions or any inflammatory conditions in anterior segment or posterior segment. After that, only we will do the cataract surgery. And for precaution to be taken by the patient, we can educate him or inform if there is any redness or any pain. If he's facing, he should come to the OPD or any emergency services.
Not exactly that way. See, once you must remember that once you made a diagnosis of a virus on a patient, and you should always remember that these viruses stay latent. They can always come back. So any trauma, iatrogenic, for instance, any surgical procedure can stimulate a very virulent reactions in these patients.
Yes,
so prepare your patient for the cataract surgery with antiviral. So there is something called as therapeutic range of treatment, prophylactic range of treatment. So this has to be followed. So prepare your patient with prophylactic. Then once the surgery is done, therapeutic, then again go back to the prophylactic regime, which actually goes on for months together. So that is what I was trying to find out from you. Thank you. So we can move on to the next judge, please.
Okay, ma'am.
Yeah. What do you mean by 4 quadrants sensation technique? You said you did in 4 quadrants technique.
So, ma'am, divided cornea in the four quadrant. So, superior, inferior, temporal, and medial. So the whole there was no sensation in any part of the cornea. Nothing is sparing.
Okay, and one more thing, anti-segment OCT. Does it have a role other than prognosis? Because this diagnosis is very clinical.
Yes,
so
ma'am.
do you give a lot of importance to be given to anti-segment OCT for diagnosis of such kinds of endophthalmitis?
Ma'am, the ASOCT can be beneficial as we can monitor the endothelial by ASOCT itself, and we can.
There are various ways to analyze. A good slit lamp examination can also do your job. Why do you want these such higher end instruments for such a clinical diagnosis? You need to validate that?
Ma'am, the mainstay of the diagnosis is clinical itself, but when we coming to the modalities, then ASOCT would be a help for us, definitely.
Okay, yeah. That over to the next judge.
Deepak sir, if you have any questions. Dr. Deepak sir, if you have any questions. So, okay, we'll move to the next presenter. Can we?
Thank you, ma'am.
Okay, thank you. Thank you, Dr. Rajat Singh.
Thank you so much.
What is the difference between the dendrites and pseudodendrites?
Dr. Rajat?
I'm audible, Dr. Rajat?
Yes, sir. Yes, sir.
Yeah.
What is difference between dendrite and pseudodendrites?
So dendrites have a bulb at a terminal, and it's usually septate.
Okay, there is one difference. Any other difference? Which one stain better? Means since you have to stain all the cases of viral ulcers, and you have to also eliminate or find out a differential diagnosis of the etiology, means it is herpes or the varicella. So
Yes,
in which case you will get the pseudodendrites, and in which infection you will get the true dendrites?
Sir, in HSV we will get true dendrites.
Oh, very true. In HSV you will get true dendrites, and in varicella you will get the pseudodendrites. Apart from the central terminal bleb, you will find out lesser number of corneal ulceration or central ulceration in the cases of pseudodendrites.
Yes,
and
sir.
also pseudodendrites doesn't stain well as compared to dendrites.
Dendrites, true
Thank
dendrites.
you. Thank you.
Sir. Thank you so much, sir.
Next speaker.
Yes, go to next speaker, Dr. Sukriti Srivastava. Her mentor is Dr. Shubhangi. Are you there, Dr. Sukriti?
Yes, ma'am. Just 1 minute.
Start sharing your screen.
Yes, ma'am.
Again, time is 4 minutes for your presentation. Yes, your slides are visible.
Is it visible, ma'am?
Yes, it's visible and you're audible. You start. Yeah.
Good afternoon, everyone. I am Dr. Sukriti Srivastava, presenting a case on bacterial corneal ulcer under the guidance of Dr. Shubhangi. The patient is a 67-year-old male who is a resident of Bethel district, basket weaver by occupation, who presented to Chirayu Medical College and Hospital with the chief complaint of pain in left eye since 2 days and diminution of vision in left eye since 2 days. As narrated by the patient, he was apparently all right 2 days back when he experienced pain in left eye, which was sudden in onset and rapid in progression. Patient also complained of diminution of vision in left eye, which was sudden in onset, rapid in progression, present for both far and near distance, and aggravated in bright light. There is association with watering and photophobia, and no association with discharge, use of contact lens, trauma, chronic topical medication, joint pain, or any diurnal variation. The patient had cataract surgery in both eye 8 years back. There is no history of similar complaint in the past. The patient is not a known case of diabetes, hypertension, asthma, tuberculosis, or any connective tissue disorder. The patient is vegetarian by diet with normal bowel and bladder habit and normal pattern and duration of sleep with not any known allergy to drug. He has a history of infrequent smoking and tobacco chewing since 5 years, also alcohol consumption since 20 years. There's no similar family history. On the general examination was normal. The patient was well oriented to time, place, and person with no systemic illness. On local examination, the head posture was normal with no facial asymmetry or any forehead abnormality. Starting with the ocular examination, the visual acuity in right eye was 618, which was best corrected to 69 with normal lid, and extraocular movement were full and free in all gazes. Conjunctiva was normal, the cornea was clear and transparent, and sensation was present in all 4 quadrant and centrally. The sclera was normal, the lacrimal apparatus regurgitation test was negative. The anterior chamber was normal in depth and content, and iris was normal in color and pattern. The pupil was central, circular, and reacting to light. The patient was pseudophakic. IOP was 9 mm Hg, and the fundus was normal. On examination, left eye, the best corrected visual acuity was PL and PR positive with edematous lid. The extraocular movement was full and free in all gazes. Circumcorneal congestion was present. In cornea, epithelial defect was present, which was 5 to 3 mm, 5 mm in width and 3 mm in length, centered in position, oval in shape with well-defined margin. Surrounding infiltrate was of 2 by 2 mm in width, involving more than 50% of the cornea. Corneal thinning with anterior protrusion of Descemet membrane was present, which was 3 mm in width and 2 mm in height. 2 DM folds were present peripherally. Superficial vascularization was present from 4 to 7 o'clock position. The corneal sensation were present in only in upper quadrant. The sclera was normal and the regurgitation test was negative. The anterior chamber depth was normal with hypopion present, which was 1 mm in height and mobile. The iris was normal in color and pattern. The pupil was not able to be, we were not able to assess the pupil. The lens was pseudophakic. The IOP was 2 mm Hg and fundus was clear. Presenting a case summary, the patient of 67-year-old male, basket weaver by occupation, presented with the chief complaint of pain watering and diminution of eye since 2 days, with finding of corneal epithelial defect 5 by 3 mm, with surrounding infiltrate of 2 by 2 mm. And the epithelial defect was central position, oval in shape, and with well-defined margin, along with anterior protrusion of Descemet membrane and hypopion in anterior chamber. Microbiological investigation was done. Corneal scraping was sent for gram staining and KOH mountain culture, which was negative. And routine investigation was done of CBC, ESR. And so provisional diagnosis of bacterial corneal ulcer was made, for which management was given with fortified cefazolin, eye drop natamycin, and adjuvant therapy of eye drop timolol, eye drop atropine with the lubricant, and systemically tablet doxycycline was given with Pantop, and lowering IOP lowering drug Diamox was given with Portclo. Thank you.
Dr. Sukriti, that's a good presentation. Can you stop sharing, please?
Yes, ma'am.
Yeah. So now tell me, why are you calling this ulcer as a bacterial ulcer, but you have also given fungal treatment for this patient?
Ma'am, startingly, we started with the conservative treatment, and on sending off when the culture and uh, scraping was sent, the reports came out to be negative. So, starting on on the clinical picture, we started with the management of we started with the conservative management of both bacterial and fungal.
Okay, can you enumerate the clinical picture of bacterial versus a fungal ulcer?
Yes, ma'am. Starting with the bacterial corneal ulcer, we have a well-defined margin as compared to fungal ulcer, where we have ill-defined feathery margin. Second, with the hypopion, the in bacterial corneal ulcer, the hypopion is mobile as compared to fungal corneal ulcer, where there is immobile hypopion. Secondly, ma'am, also the signs and the symptoms are much more aggravated in bacterial corneal ulcer, which consist of a rapid onset of pain and swelling, as compared to fungal corneal ulcer, where the signs are much more, and as compared to uh, symptoms, there's gradual onset and slow progression.
Thank you. So may I request the next judge to please ask?
Yeah, see, these are very basic UG level differences which you have described, which Madam very rightly asked the differentiation. And you said scraping was negative. What other test did we carry out to find the bacteria, whether we are dealing with gram positive, negative, and then focus our treatment to be more, towards this.
Firstly, to differentiate between the gram staining, like gram positive or gram negative bacteria.
Yeah. So what was the result there?
Ma'am,
what was the result of your gram staining?
Ma'am, the gram stain was found to be negative for any growth.
Was the patient already on treatment when he came to us?
No, ma'am. The patient was only instilling lubricant eye drop. There was no.
Then what is the commonest reason for such negative reports? If the patient was not on any treatment? And? An inappropriate test, right? The
Yes,
sample was
ma'am.
not taken adequately.
Properly.
See, these
Yes,
are common clinical things we come day to day in our teaching institute, right? Okay.
Yes, ma'am.
Secondly, one more thing, you have measured the defect so precisely, 5 mm, 3 mm with 2 mm of stromal involvement. So
Yes,
what did
ma'am.
you use to make these measurements?
Ma'am, for this measurement, we did it on slit lamp. We measured it with the slit, the measurement of slit.
Okay. Because usually they are in a range and not very specific. So if you want to go very safe in the exam,
yes,
don't be very crisp with the numbers. You can you can be little approximate and all.
Yes,
there's no harm in it is being But otherwise, okay, yeah. Next, go to the next judge.
Thank you, Dr. Sukriti, for the lovely presentation. One thing I like in your presentation is the handmade diagram made by you. I request or suggest all the residents who are going to present at least make a handmade diagram of yourself
I agree.
in your
Yes, sir. Yes, sir.
exam and every places. And second
Yes,
thing,
sir.
I would just like to know how you scrape. Means what is the procedure of scraping of any corneal ulcer?
Sir, firstly, we'll install a topical anesthesia, and after that, we can do scraping by BP15 blade, or a Chimera spatula can also be used. The scraping is usually the scraping should be.
मैंने भी नहीं खाया खाना.
So the scraping would be taken from periphery, and from the is usually taken peripherally, and then it is installed if in a C pattern. We'll
Your voice is cracking, I think. I'm audible?
Yes, sir. So should I start from starting?
No. How many slides you prepared?
Sir, one slide was prepared for staining. One was for Keogh's mount, one was for culture of the bacteria, and one was sent for the gram staining.
Okay. Okay. Thank you.
Thanks.
Kindly invite the next.
Next, we have Dr. Kriti Tiwari from Chirayu Medical College, and her mentor is Dr. Syed Mohammad Bilal. Dr. Kriti.
Yes, ma'am. I will share my screen. Is my
Yes, you're visible, Kriti. Go ahead.
Yes, your presentation is seen.
Yes, it is visible, Dr. Kriti. You can go on. Yeah.
1 minute. If the other two judges agree, can the candidate just speak the positive findings in the examination so that we have more time for questions and we have the exact picture? We can just spare the normal things. If
Yeah,
the other
sure.
two judges agree,
Yeah, I'm okay with it.
Deepak sir, can we do that?
Yes, ma'am. Yes, ma'am.
Thank you so much. Yeah, please just speak the in examination part, come speak the positive finding. That is how many times you are asked to present in your exam also. Okay.
Okay. Okay.
Yeah.
Or you can tell us one or two positive history if you think.
Yes, sir.
One, two
Yes.
important points
Yes, sir.
suggestive of
Yes, sir.
your diagnosis in history and then examination.
Yes, sir. Yes, sir.
Okay. So I would like to, good afternoon, everyone. I would like to start my case presentation. Myself, Dr. Kriti Tiwari, and my mentor is Dr. S.M. Bilal sir. We are from Chirayu Medical College and Hospital. So my patient, who's 60-year-old male patient, presented in the OPD with the chief complaint of sudden diminution of vision in the right eye since 4 days. And the patient, he was apparently all right 4 days back when he developed diminution of vision in the right eye, which was sudden in onset, non-progressive, and not associated with pain. He had no similar complaint in other eye or floaters and flashes, cutting coming down on the visual field, ocular trauma, headache, pain and while chewing, and weakness in the limbs, and pain on ocular movements. There is no significant past history, but there is a history of hypertension since 2 years, for which patient is taking clonidipine tablet 10 milligrams once per day, but he is not compliant with the treatment. And there is no other systemic ailment like type 2 diabetes mellitus, cardiac illness, benign posterior hypertrophy, or pulmonary hypertension, or any other medication. His other personal history is unremarkable. There is no significant family history. On general physical examination, he is moderately built, well-oriented to time, place, and person. His vitals are unremarkable except for the blood pressure, which is 178 by 98 millimeters of mercury. On ocular examination, he has normal head posture and facial symmetry was maintained. His uncorrected vision in the right eye is 6 by 36, and there was no correction. In the left eye, he has uncorrected vision of 6 by 36 with the best corrected vision of 6 by 12 with a -1 spherical correction. And his near vision in the right eye is N by 12 with plus 2.75 correction, and N by 6 in the left eye with +1 correction. His extraocular movements are full and free in all the cases, and all the anterior segment examination is normal except for the pupillary examination. The right eye pupil is central circular, 3 millimeters in size with grade 2 RAPD. And the left eye pupil is central circular, 3 millimeters in size with normal reaction to light, and there was no RAPD. Both eyes have a grade 2 nuclear sclerosis of lenticular opacity. The patient's IOP is 12 millimeters of mercury in both the eyes on Goldman sublimation tonometry. He has impaired color vision in the right eye, impaired red and green color vision, while color vision is normal in the left eye. On indirect ophthalmoscopy, the fundus examination was done. The right eye, on right eye, red reflex was seen. Media was hazy due to lenticular opacity.
Disc appeared to be swollen and cupping was not appreciated. It was pale in color with blood disc margins. Blood vessels arising from the center of disc was appreciated with an AV ratio of 1:3. Sphincter hemorrhage was appreciated at 7 o'clock position adjacent to the disc, and fundus reflex was dull. On left eye fundus examination, red reflex was seen, media was hazy. Disc was circular in shape and normal in size, pink in color with distinct margin. Cup disc ratio was of 0.3:1. Neuroretinal rim appears to be healthy. Blood vessels arising from the center of disc was appreciated with the AV ratio of 1:3, and FR was dull. On perimetry, right eye inferior altitudinal defect was seen, while left eye it was normal. On OCT, the right eye disc appears to be swollen, and no optic disc drusen was appreciated. All the blood investigations were unremarkable except for the lipid profile, which showed deranged cholesterol and serum triglyceride levels. MRI brain plus orbit impression was the width of optic nerve within normal range without any perineural edema or enhancement. Age-related cerebral atrophy with chronic ischemic changes in bilateral periventricular white matter and brain stem region was seen. So my differential diagnosis is non-arthritic anterior ischemic optic neuropathy, or anterior arthritic anterior ischemic optic neuropathy, and optic neuritis. As the patient has sudden painless diminution of vision with a history of hypertension since 2 years, with grade 2 of RAPD in the right eye, with nuclear sclerosis grade 2, with pale swollen disc with the blood margins and sphincter hemorrhage adjacent to the disc on fundus examination of right eye, and altitudinal field effect in the perimetry of right eye. My final diagnosis is right eye non-arthritic anterior ischemic optic neuropathy with grade 2 nuclear sclerosis in both the eyes. And the patient was advised for strict hypertension control. And thank you.
Yeah, so that was a good presentation. So kindly stop sharing your screen. What is that one single factor to tell you that you are probably not dealing with the arthritic AION?
Ma'am, first of all, I got on history taking. I asked for the patient whether he has any pain while combing or pain while chewing, which excludes the signs of temporal arteritis. Then on blood investigation, there was no sign of raised ESR or CRP. So from these, I excluded arthritic anterior ischemic optic neuropathy.
Yeah, that's very good. So yet another thing, you have a disc that is pale. What should that suggest you? Is it an acute event or is it a chronic event? Or it is a repetitive event?
Ma'am, it might be a chronic event, or patient might had a papilledema previously, then followed by then on long term it turned the optic disc turned pale.
So if I say this patient has got a sequelae of malignant hypertension, how would you defend that?
Ma'am, he would have had a bilateral finding if he had a malignant hypertension, but we are having all the findings unilaterally.
No, you have the other eye also disc is pale, isn't it? So, but what are the points that to say that this patient cannot have malignant hypertension? What is the age of your patient?
Ma'am, 60-year-old.
So that itself squares it out, isn't it? Malignant hypertension cannot occur in a yeah. Okay. Thank you. So move on to the next judges, please.
Thank you.
Yeah, just one question. What is your most Vaishnavi, 3 common clinical conditions, differential diagnosis of this condition based on your clinical experience of residency?
Ma'am, since the patient is Since the patient is presenting with a complaint of sudden painless diminution of vision, my differential diagnosis are retinal detachment. Hello.
Yeah, please.
Ma'am, retinal
Once-
detachment. Are you saying something?
No, please go ahead.
Okay. So my differential diagnosis are retinal detachment or ischemic optic neuropathy or diabetic retinopathy or retinal artery occlusion, retinal vein occlusion.
Okay, yeah, but good presentation. Over to the next judge.
Thank you.
Thank you, Kriti, for the wonderful presentation. One thing, how will you follow up? Each follow-up of another eye is important, or
Yes,
the
sir.
examination of another. So,
Yes,
in
sir.
which case, either arthritic or non-arthritic, what
Sir,
is the chance of involvement of another eye?
Sir, in the arthritic cases, arthritic anterior ischemic optic neuropathy, 1/3 of the patients have other eye involvement.
Okay. And would you like to do any blood investigation for this patient?
Yes,
Very
sir.
simple investigation,
Sir,
which
yes, sir.
help you in differentiating between both arthritic and non-arthritic.
Yes, sir. Sir, I'll measure the blood ESR level, CRP level, and serum homocysteine levels.
Okay, so in which case you will find out raised ESR?
Sir, in the arthritic cases, we'll have deranged ESR and CRP levels.
Okay, thank you.
Yes, sir. Thank you, sir.
Next presenter.
Next, we have Dr. Vaishnavi from LN Medical College, Bhopal, and her mentor is Dr. Nupur Sharma. Dr. Vaishnavi.
Dr. Aditi, are you there? Dr. Aditi, Dr. Vaishnavi, any one of you?
She is out of network. We can call someone else.
We can call Dr. Aditi. Dr. Aditi
Aditi.
is from LN Medical College and her mentor is Dr. Smita Patel. Dr. Aditi, please join.
Is there? Can you call next presenter? Dr. Purva Lal is there? Dr. Purva Lal?
Yes, ma'am.
Start sharing your screen. Time is 4 minutes.
Yes, ma'am.
The mentor is Dr. Harpal Singh. She is from People's Medical College, Bhopal.
Dr. Purva.
Yes, ma'am.
Yes, you can start.
Ma'am, are my slides visible?
Yes, doctor.
No, your slides.
Yes, your slides.
Yes, your slides are visible.
Good afternoon, sir. Good afternoon, ma'am. Today I have a case presentation of a 9-year-old female of Vidisha district came to her OPD with chief complaint of protrusion of eyeball since 6 months, protrusion of right eyeball. History of presenting illness. As per patient's parents, she was apparently all right 6 months back. Then they noticed protrusion of right eye, which was insidious in onset, gradually progressive in nature. There was no variation of protrusion of eyeball with postural variation or strange, no known aggravating or relieving factors. It was not associated with pain, vision loss, double vision, redness, or photophobia. There is no history of trauma. There is history of dull aching abdominal pain since 3 days. There is no significant past medical or surgical history. No significant family history. Personal history, there is history of weight loss was present. General physical examination, patient was lean built and irritable. Rest physical examination was within normal limit. Systemic examination, on GI examination, splenomegaly was present. Rest CVS, respiratory and CNS examination was within normal limit. On ocular examination, head posture was normal. Facial symmetry was distorted due to protrusion of right eye. On inspection, protrusion of right eye was seen, which was non-axial, down and out. No visible pulsation were present.
No change with Valsalva maneuver, cuff, or change in posture. Lid position was normal. Lid fullness was present. Skin discoloration was present over upper lid, both eyes. On palpation, temperature, no local rise of temperature. Tenderness was absent. Pulsation were absent. Mass over the lid, there was diffuse mass over right eye upper lid, approximately 3 by 1 centimeter, with ill-defined margins, hard in consistency, non-tender, non-compressible, not able to insinuate a finger between mass and bony orbit. On auscultation, bruit was absent. On examination, right eye and left eye, her best corrected visual acuity was 6/9 of both eyes. Color vision was normal. Eyebrow was normal in position. Eyelids, hyperpigmentation was present over upper lids of both eyes. Lag of thalamus was present in right eye and absent in left eye. Eyelid sensation was present in both eyes. Bell's phenomena was poor in right eye and fair in left eye. On proptosis axial measurement of right eye was 20 mm with vertical dystopia of 4 mm, horizontal dystopia of 4 mm, palpebral aperture of 14 mm. Extraocular movement were restricted in all gaze, more in up gaze position. In left eye, axial measurement was 15 mm, palpebral aperture was 10 mm, extraocular movement were free in all gazes. Lacrimal apparatus regurgitation test was negative. Conjunctiva was normal in both eyes. Cornea was normal. Sclera, anterior chamber iris were normal of both eyes. Pupil was central circular, reacting to both direct and consensual light reflex. Lens was transparent. Intraocular pressure was, while measured with short stonometer, was 14.6 mmHg in right eye and 12.2 mmHg in left eye. Vitreous was normal. Fundus was grossly normal. Based on this clinical examination, differential diagnosis was orbital cellulitis, hemangioma, lymphangioma, optic glioma, leukemia, rhabdomyosarcoma, or neuroblastoma. On further investigation, blood investigation, hemoglobin was reduced, RBC count were reduced, total WBC count were raised, platelet count was reduced. In differential count, lymphocyte was slightly raised, whereas ESR was within normal limit. On CCT scan, a relatively well-defined heterogeneous enhancing soft tissue attenuation lesion was seen in extraconal space along roof, lateral wall, or right orbit, causing mass effect with compression. There was medial displacement of superior and lateral recti muscle, anterior displacement of lacrimal gland, and mild right eye proptosis. There was no extension of lesion in intraconal plane, and no bony erosion was seen. On B scan, bilateral moderate to highly vascular paraglobular masses were seen. Right side proptosis with bilateral mild preseptal edema was seen. In peripheral smear, it shows normocytic normochromic anemia. On further examination, blast cells were seen with prominent nucleoli, basophilic cytoplasm, and or rods. Impression according to peripheral smear was suggestive of acute myeloid leukemia. Provisional diagnosis as per clinical history, blood investigations, and a CECT. Diagnosis was right eye proptosis with acute myeloid leukemia. Thank you, ma'am. Thank you, sir.
It's a very well presented case, actually. My question to you would be, Dr. Vaishnavi, is like, see, your patient had presented with a lesion in the orbit. So do you think CT scan of the orbit is the preferred modality, or would you prefer doing an MRI? Or how do you think which one would be the best modality if you have to choose between one?
Ma'am, we can prefer CCT. CCT was done to rule out any bony involvement was present or not. For soft tissue involvement, MRI is preferred investigation.
So now in a leukemic patient, what are all the manifestations that you can have apart from what you had?
Yes, ma'am. Apart from proptosis, there are systemic manifestation like splenomegaly and ocular
only ocular manifestations.
Yes, ma'am. Conjunctival involvement, ma'am, it could cause chemosis. There are leukemic deposit in uveal tissue also, which could cause raise in IOP. And ma'am, sometimes these deposits are also in extraocular muscles, which cause restriction of movement.
So whenever somebody is asking you a question on leukemia,
yes,
you should kind of stratify your disease, like stratify in the sense, in leukemia, basically what do you have? The viscosity increases, okay? So you stratify it as the related to the disease per se and related to the treatment per se. So hematological cause, infective causes and suppressive causes. So if you put that, you will be able to very easily differentiate the manifestations and very easily to follow these patients also. Otherwise, good presentation. So the next judge, please.
Thank you, ma'am.
Yeah, good presentation. No questions. Madam has already asked what I was planning to ask. Good presentation.
Thank you, ma'am.
Just one question, Dr. Purva.
Yes.
What are the reason for the proptosis in the leukemic patient?
Sir, there are two main reasons. First, it could be direct or indirect. Indirect, there are leukemic deposits occur, and secondary reasons are there because of blood dysynthesis, anemia, and thrombocytopenia. It can lead to proptosis.
Okay. Okay. Thank you. Next presenter.
Just a gentle reminder, the presentation done was for Dr. Purva. So the judges, please mark Dr. Purva for this case. Next, we have Dr. Pragyal Chaturvedi from People's College, Bhopal, and his mentor is Dr. Satyendra Singh. Dr. Pragyal, please join.
Dr. Vaishnavi or Dr. Aditi from NN Medical College, any one of you are there?
Ma'am, Vaishnavi and Dr. Aditi, I cannot see in the participants. They have not joined yet. Dr. Pragyal is there.
Pragyal? Yes, he's there.
Dr. Pragyal, please join.
You are, I think, unmute.
Hello, good afternoon, ma'am. Am I audible?
Yes, you're audible. Pragyal, start presentation.
Yes, ma'am. Just a moment, ma'am. I'm trying to share my screen.
We can see your first screen. Just try to move and see if it is moving or not.
Yes,
Yeah.
ma'am.
Okay. Perfect. Please start. Please start.
I am Dr. Pragyal Chaturvedi, presenting a case of 52-year-old male, farmer by occupation and resident of Barasia, Bhopal, coming to our OPD with the chief complaints of diminution of vision in right eye since 1 month. As per my patient, he was apparently all right 1 month back. Then he developed diminution of vision in right eye that was sudden in onset, progressive in nature, not associated with pain, redness, photophobia, floaters, colored halos, flashes of light, or curtain falling down in front of eye. Past medical history, there was no history of spectacle use, no history of trauma, hypertension, diabetes mellitus, anemia, or blood transfusion, no history of bleeding or clotting disorder or any anticoagulation use. There was no history of any cerebrovascular accident. There was no significant surgical history. Patient was vegetarian by diet, having average build, having sleep appetite, bladder bowel habits are normal, with no history of addiction. Patient doesn't have any significant family history. On general physical examinations, vitals were normal, along with normal systemic examination. On ocular examination, visual acuity by Snellen's 3/60 in right eye and 6/6 part in left eye, with no improvement with pinhole in right eye. Head posture were normal, eyebrow, eyelid, eyeball, lacrimal apparatus were normal in both eyes. Conjunctiva, cornea, sclera, anterior chamber were within normal limit in both eyes. Iris was normal in brown in color. Pupil were 3 to 4 mm, central circular, having direct and consensual light reflex present in both eyes. Early cataract changes present in both eyes, like nuclear sclerosis grade 1. Intraocular pressure measured with applanation tonometry was 12 millimeter of mercury in both eyes. Gonioscopy shows open angle with no evidence of neovascularization of angle or iris. On fundus examination, distant direct ophthalmoscopy, media was clear. With 90-day slit lamp examination, disc was circular in shape, pink in color with normal neuroretinal rim. Number of small blood vessels were 10, having CD ratio of 0.3:1. Vessels were dilated, tortuous, engorged superiotemporal venous arcade with apparently empty-looking sclerotic vein with transition point at 2 disc diameter superiotemporal from macula. Multiple deep and flame-shaped intraretinal hemorrhages in segmental distribution were there, confined to the superiotemporal vascular arcade with multiple yellow, white, fluffy lesions suggestive of cotton wool spot. Atrio-venous ratio is altered, that is 2:4. In macular region, foveal reflex was absent, multiple flame-shaped and dot plot hemorrhages, along with multiple cotton wool spots present with hard exudates. Peripheral fundus was within normal limit. This is a Emsler-Du Bois chart, handmade, and on the other side, there's a fundus photograph of the patient, right eye. Fundus findings of left eye were within normal limit. To summarize my case, this is a 52-year-old male presented with chief complaint of sudden painless diminution of vision, having no history of trauma or any systemic disorder, with normal anterior segment finding. Posterior segment evaluation reveals multiple flame-shaped and deep intraretinal hemorrhages in a segmental distribution, confined to the superiotemporal vascular arcade with multiple yellowish white cotton wool spots and sclerotic vessels. In macular region, multiple flame-shaped and dot plot hemorrhages masking the macular area along with cotton wool spots are present with absent foveal reflex. Based on clinical picture and examination, my probable diagnosis is right eye branched vein occlusion with macular edema. Investigations were done. All investigations were within normal limit. Lipid profile was checked to assess the hyperlipidemic condition, but it wasn't within normal limit. Systemic investigations were advised: chest X-ray, carotid Doppler, hypercoagulation profile. Ocular investigations were advised: OCT, FFA, and perimetry. Plan of treatment: intravitreal anti-VEGF ranibizumab 0.3 mg monthly for 3 months, along with monthly follow-up and monitoring with OCT, macula, and FFA. My differential diagnoses are right eye branch vein occlusion, right eye hemiretinal vein occlusion, right eye hypertensive retinopathy, right eye diabetic retinopathy, right eye radiation retinopathy, and right eye ocular ischemic syndrome. Thank you.
That was a good presentation. So you have given in your differential branch retinal vein occlusion, a semicentral retinal vein occlusion. So what are the crucial differentiating points between a BRVO and a HCRVO?
I mean, BRVO, there is a segmental distribution of hemorrhages and cotton wool spots, or segmental branch occlusion happens. But in hemiretinal vein occlusion, there is occlusion occurs before the bifurcation of division of central retinal vein. So that is hemiretinal findings were seen in hemiretinal vein occlusion.
So now you also said ocular ischemic syndrome.
Yes, ma'am.
So what are the points not in favor of an ocular ischemic syndrome in your case?
I mean, ocular ischemic syndrome, there is a occlusion and vascular insufficiency at the level of internal carotid artery.
No, from only the fundus findings.
Ma'am, in ocular ischemic syndrome, peripheral area is more involved, but in branch retinal vein occlusion, posterior pole is more involved.
So will an OIS be limited only to one particular quadrant?
No, ma'am. In OIS, all 4 quadrants are involved.
Yes, that should be your first point to say. Actually, when you are giving a differential for a BRVO, you should not give an OIS, because OIS is a differential for a central retinal venous occlusion, not for a BRVO. Yeah, you must give things which are very closely resembling not the other ways. So you could probably give a tuberculous vasculitis because that can be very localized, or a CMV, which can be very localized. So these are these things which can be the close mimickers, may not be a OIS or the other differentials. Now you have shown a fundus photograph. What is the field of view of your fundus photograph?
Ma'am, superior temporal field was involved.
No, I'm asking the degree.
Ma'am, 30-degree.
No, it's not the 30 degrees. So always whenever you're doing an investigation, it is always better to know what are the field that is being covered. It's a 55-degree fundus photograph that you had shown. Okay, good presentation. Next judge, please.
Okay, ma'am.
Again, coming back to ocular ischemic syndrome, how does a patient of ocular ischemic syndrome present to you? Am I audible?
Hello? Hello?
Yeah, can you hear me?
Yes, ma'am.
Can you hear
Yes,
me?
ma'am. There's a network issue.
How does a patient of ocular ischemic present in the OPD, beta?
Ma'am, sudden painless elimination of vision.
And one more question. Yeah, I got. So you know it. Okay. What is the significance of number of disc vessels? You said in the finder's findings. Why did you say that?
Ma'am, number of disc vessels are as if intraocular pressure or any kind of pressure causing compression, optic neuropathy, then number of blood vessel or disc can be seen.
A less number of vessels, you mean?
Yes, ma'am.
What is the cutoff number of vessels and some particular disc sign usually asked in the exams?
Sorry, ma'am?
Any disc signs? Any sign related to that? Any clinical sign related to that?
When splinter hemorrhage.
Okay, yeah, but good.
I
No,
didn't
that's
get the
fine.
question correctly, actually.
Yeah, okay. Good presentation overall. Over to the next judge, please.
Dr. Panjal, how will you follow up this case? Means what is your follow-up guideline and what is the prognosis? The patient wish to know the prognosis and the follow-up.
So first thing, we have to check for the visual acuity. If it is better after the treatment, given treatment of 3 months, and we will do a fundus OCT macula and FFA also. If things are improving, like macular edema is resolving and visual acuity is improving, then we'll wait for observation and look for the new vascularization to develop if there is anything. Otherwise, observation is the only follow-up, monthly follow-up.
Okay. Next presenter, if available. I think Dr. Vaishnavi and Dr. Aditi are absent at present.
They have not joined. I have messaged also. They are not responding. I think we can
okay.
take Dr.
We will mark them absent and
we can take up Dr. Devi's talk and
after.
Dr. Manu,
Okay.
you can introduce Dr. Devi.
Next, we have a very interesting talk on rare eye diseases by Dr. Devi Aishwarya Das ma'am. She's a senior consultant of cornea, cataract and refractive services at Dr. Agarwal's Eye Hospital, Cuttack. She did her MBBS and MS from Odisha and did her fellowship from Shankar Netralaya, Chennai, and short-term cornea fellowship from LBPI, Hyderabad. Recently, she completed her senior management program in healthcare management from IIM. She is recipient of Dr. R.C. Meher Intramural Oration Award, and she heads WOS Odisha. She is a great academician and a clinician at heart, and also a course coordinator for DNB courses in her institute. Welcome, ma'am. It's a privilege to have your session.
Yeah, good afternoon, everyone, and thank you, WOS Madhya Pradesh, for having me here. So this is currently I'll be speaking on the RED project, that is the Rare Eye Disease project. So this has been undertaken by WOS, and I came very late into the project in last October. So I'll try my best to cover whatever I can about the project, and any doubts on that I can take up at the end. So we are going to talk about the rare eye disease group. My slide is not moving here. So the journey of 1,000 miles begins with a single step. So this is how this project began. So what is this project about? So WOS initiated the following agenda. Its agenda was to establish a national registry for rare eye disease, as well as rare aspects of common eye diseases. Here we have to collect data on demographics, clinical picture, course, counseling, treatment, record and data collected and then stored. Thus, this group was established in 2019. Financial disclosure, this is supported and funded by CIPLA. So the first publication on this forum came on IGO. So what were the objectives of this RED group? What are the objectives of this group? To form a common cloud-based template customized to each disease under study, to give a common platform to all ophthalmologists working in any sector to record and report their cases. So we started off with the Women Ophthalmological Society, but then in time we are including other ophthalmologists who show interest in this. Then to find drugs or treatment modalities for these diseases from the existing therapeutics, as well as initiate new drug discoveries. Then to provide genetic counseling, rehabilitation, and support to patients and their families subsequently. So till now, what have we done? We have identified a few diseases. Now there are 8. We had initially gone with 10, but then 2 diseases we decided to drop out. Then an ethics committee was formed for WOS itself, and clearance was taken for this. Then investigators have been enrolled. Team leaders and group coordinators have been earmarked. Proforma for patient data entry have been finalized. And team leaders or coordinators are sensitized via Zoom meets, and this is an ongoing process. Right now, we are doing it almost weekly. And so first we have the data entry, and then for doing this data entry, a personalized link has to be created for each investigator, and it has been done already. Then team leaders of each group are to have access to all the data in that group. Then data will be compiled and analyzed, and a central repository created. Though it is a time-bound project right now, but this will be an ongoing process. So what are the rare eye diseases or rare aspects of common diseases that have been taken up? One is RP, Stargardt's, corneal dystrophies, ocular tumors, pediatric glaucoma, myopia, normal tension glaucoma. And the last, there's anterior and posterior segment manifestations of COVID. For right now, it has been put on hold because of the lack of any fresh cases and poor record of all the possible manifestations that could have happened then for logistics issues. So we have certain timelines, identifying patients and assimilating data that has started. Links for data entry have been provided to all the investigators. Data entry has begun finally, and all data entered by 30th September 2024 are to be included in the current project. Then data compilation analysis to be completed by 30th November 2024, 2 months after all the data entered. So this is the website. And right now your username is your own email that has been registered with this group. And then the common password, which you can change after entering into the database. Then we plan to undertake a course on genetic testing and counseling as an objective of Project RED, which was the 4th limb of the project agenda. We help create a national repository, genetic analysis to look into rare eye diseases that still do not have a genetic basis or a diagnosis, and to find drugs or treatment modalities for rare eye diseases from existing ones, as well as if we could initiate newer interventions. Genetic counseling, rehabilitation, and patient support programs, and we plan to undertake training of ophthalmologists in this. And for this, we have sought the technical support of MedGenome, and that will again be started shortly. So thank you all. That's it. And the woods are lovely, dark and deep, but we have promises to keep and miles to go before we sleep. So this is made immortal by Robert Frost. So with that, I end my presentation. So any questions?
Thank you, Dr. Devi. And I think the mentors in the group can be a part of rare eye disease project that is being run by WOS, and we can submit our data and be a part of
Yes.
a big registry that we are keeping. And
Yes.
in future, we'll be definitely taking up the counseling
It's
part and
ongoing,
all
yeah.
those. It's an ongoing process, and we must compile the record of all these rare eye diseases. Thank you, Dr. Devi, for being a part of it and taking such a big project. And it is a magnanimous project. I think so much of compiling is needed. So much of things are needed. It's only you who could have done it for WOS, I think.
Rita, I can't do this.
Thank you, Dr. Devi. And Dr. Manushree, I think you can call upon Dr. Shabina for her talk.
Good afternoon, everyone. Good afternoon, Dr. Shweta, Dr. Neetu.
Good afternoon, Dr. Bhalla. We are just we were running late
Sir.
because the discussion was going so nice. We could not halt it in between. We are sorry for the delay. And after Dr. Shabina's talk, we can take up the last session.
No, thank you. Thank you. In fact, your delay gave me time to come back from DOS meeting to my house.
Thank you, sir. Thank you, sir.
Yeah, otherwise I was confused. How will I log in while driving? But I've
Thank
reached
you,
home now.
sir.
Yeah, thank you.
So, is Dr. Shabina online? So I think we can start with the next session, and by the time Dr. Shabina logs in, we can take her in between. I think that will be okay with the judges.
Yeah, I think fine. It's okay with me.
Okay, okay. Dr. Neetu, you can start the session 4.
Good afternoon, everyone. Now we are switching the next and the last session. Firstly, I would like to invite and welcome our judges, Dr. Jatinder Singh Bhalla sir and Dr. Sthiti Juneja ma'am. Juneja ma'am, are you here?
Yeah, good afternoon.
Good
Thanks,
afternoon,
Neetu.
ma'am. So, warm welcome, sir and ma'am. And first, I would like to introduce our judges. So, first one is the Dr. Jatinder Singh Bhalla, sir. He is an alumni of Maulana Azad Medical College, New Delhi, and presently he is working as senior consultant and academic in charge, Deen Dayal Upadhyay Hospital, New Delhi, with a teaching experience of 28 years. He has special interest in cataract and glaucoma. He is an ex-secretary, DOS, and member scientific committee, AIOS, and DOS representative to AIOS. And he is also chairman scientific committee, ISMSIC Jilli chapter. He has got many awards, but most recent one is the Outstanding Ophthalmic Teacher Award by FOTI 2024. He also got many awards for the best paper awards in many national conferences. And he is ex-chief editor of DOS Times. And now he is on editorial board of IGO, Indian Journal of Ophthalmology and DOS. Welcome, sir. And now, and the Sthiti Juneja ma'am, she is an alumni of MGM Medical College Indore, MP. She has done her fellowship from Sankar Netralaya, Chennai. She has keen interest in cornea. Now she is working as associate professor, Baroda Government Medical College, Baroda, Gujarat. She is very loving and caring, ma'am. Welcome, ma'am. Can we start?
Thank you, Neetu. Thank you so much.
Dr. Aditi.
Yeah, very good afternoon, sir, and very good afternoon, Suti ma'am. So here we'll be having a quick brush up of the session. We'll be having a 4-minute presentation followed by 4-minute discussion. And for judges, the judgment will be based on way and quality of presentation, clinical acumen, adherence to time, quality and uniqueness, and discussion. So we have 6 PGs in this session. So I would like to call upon Dr. Shiva Srivastav. Please share your screen, Shiva. And she is presenting from Gandhi Medical College, Bhopal. Dr. Shiva Srivastav. Yes, she has started presenting. Shiva, you are not audible. Please switch on your. We have started your time, so you should start presenting also. Dr. Shiva?
Hello, am I audible, ma'am?
Yes, you are.
Good afternoon, everyone. Today, I'm going to present a case of a 28-year-old male who is a resident of Bhopal and welder by occupation. He came to our OPD with the complaints of sudden diminution of vision in both the eyes since 2 days. As per the patient, he was apparently all right 2 days back when he developed diminution of vision in both the eyes, which was sudden in onset, progressive in nature, and associated with mild pain in both the eyes. There was no association with any redness, photophobia, lacrimation, or foreign body sensation. On further history taking, it was revealed that the patient was exposed to welding arc light 2 days back just before he started developing the symptoms. There was no significant past medical history, any significant drug history, family history, or any significant personal history. On examination, general examination and systemic examinations were within normal limits. At presentation, visual acuity was 1/60 in both the eyes with no improvement with pinhole. Automated refraction showed a spherical aberration of -0.25. Rest of the anterior segment findings were within normal limits. Pupillary reaction in both the eyes were normal. Lens was transparent and intraocular pressure was within normal limits. On performing the indirect ophthalmoscopy, media was clear, disc was normal, over the foveal reflex was dull, and an ill-defined yellowish lesion was present over the center of the fovea. Rest of the fundus was within normal limits. After this, we performed OCT. On OCT demonstrated a subfoveal hyperreflective lesion with disruption of the outer photoreceptor layer. On the basis of this, we made the diagnosis of both eye welding arc maculopathy. For that, we started the patient on high-dose IV steroids for 3 days and topically nepafenac 0.1% eye drops were started. At day 3, the patient showed visual improvement up to 660 and the hyperreflective lesions on the OCT started to resolve. After that, the patient was shifted on oral steroids and supportive treatment was also started and topical nepafenac eye drops were continued. Then the patient was discharged and he was put on weekly follow-up. At day 30, the vision in right eye improved up to 6.6. The lesion over the fundus was resolved and OCT lesion also showed resolution. In the left eye, vision improved up to 6.9 with the resolution of lesion in the fundus, but the OCT showed a cystic lesion in the outer photoreceptor layer. Now, reviewing the literature, the photic injury to retina can be easily missed as this condition commonly present with as photokeratitis. Hence, it is important once the symptoms are resolved, we do a thorough fundus examination. Literature also found a correlation between the outer photoreceptor layer disruption and a visual recovery. So it can be used as a tool to prognosticate the case. And it is also found that in some cases, there is a residual color vision deficiency. Hence, once the visual recovery occurs, a color vision test should be performed and the patient should be counseled accordingly. Thank you.
Judges, please note she has completed well on time. Now the case is open for discussion by the judges.
A very good presentation, Dr. Shiva.
Thank you.
Usually, the welding, what does it affect usually? This was an unusual case.
Yes, ma'am. Ma'am, usually it presents as photokeratitis or welding arc induced cataract.
Yes, very good. So fluorescent staining was done, I hope.
Yes, ma'am. Fluorescent staining was performed.
And it was negative.
Yes, ma'am.
Okay. Secondly, what is the wavelength of the ultraviolet light usually?
Ma'am, usually it ranges from 250 to 700. So 250 to 400 nanometers, and the UVB rays which affects the eye is 250 to 315 nanometers.
Correct.
Yeah. Can you explain,
Thank
Dr.
you.
Shiva, what is the reason the patient developed only maculopathy and there was no photophthalmia, no corneal involvement in this case?
Sir, actually the cornea is mainly affected by the UVC rays, which is mainly absorbed by the ozone layers. So, and it mainly occurs in the cases of solar retinopathy. Since it was an indoor case, so UVC rays were mostly excluded. And since it was a young patient, so the rays absorbed by the lens, when in the older patient, they transmit through the lens and they affect the retina.
So what are the protective glasses that are recommended to prevent in welders? And
Sir,
how do they help?
Sir, to protect these welders, we advise them to have an adequate lighting so that they don't perform the welding by going near and near, and UV protective tinted glasses are advised.
Any specific name of those glasses?
So polarized lenses are used.
Have you heard name of Crookes glasses?
No, sir. Sorry, sir.
Yeah. Okay. Yeah. So in your patient, you used methylprednisolone IV for 3 days, followed by oral steroids. How long was it used?
Sir, it was used over the period of for the period of 6 weeks.
Okay, for the period of 6 weeks. And the patient showed remarkable recovery.
Yes,
6/9 in one eye and 6/6 in other eye.
Sir, yes, sir. Right eye 6/6 and 6/9 in the left eye.
Okay, okay. And what about the color vision assessment and visual field examination? Were they performed later on?
Yes, sir. At 1 month, when he came for the follow-up, a color vision test was performed. For that, he read all the plates on the Ishihara chart. And, sir, visual field also showed no deformity in the field.
Okay. And what about visual field?
So, visual field was also within normal limit. There were no scotomas in the field.
When was visual field performed?
Sir, it was performed at 1 month.
At
Because
1
he
month.
didn't come with the complaints of any scotoma. So once the visual recovery was good, we performed the visual field test.
Okay, fine.
Thank you, sir. Thank you, ma'am. I would request the presenters if they can switch on their camera during the discussion. That would be a nice thing for them. So the next presenter is Dr. Divyanjali Tomar. She'll be also presenting from Gandhi Medical College, Bhopal.
Dr. Aditi, can I interrupt for a minute? Ms.
Yes, yes.
Shabina Zaidi has joined us from Dubai. So if the judges allow, can we please take her talk?
Sure.
Okay, ma'am. I would like to introduce Ms. Shabina before we can have her talk. Ms. Shabina is a recognized soft skill trainer and an emotional intelligence coach with a passion for empowering individuals to harness emotional capabilities and interpersonal skills. She is an author of the book Revelations of a Millennial Mom, which has bagged her many awards worldwide. In addition to her literary achievements, she also hosts a podcast called Mom's Bookshelf, a platform to celebrate women and for balancing motherhood and careers. Through her engaging conversations with mom authors and entrepreneurs, the podcast sheds light on the unique challenges and triumphs faced by women in everyday life. Prior to her current roles, she has also worked as an environmental engineer in environmental consultancy in Dubai, where she contributes her expertise to various Dubai municipality projects. She is multifaceted in her career and is a testament to commitment to fostering emotional intelligence and supporting mothers in their personal and professional growth and for entrepreneuring womanhood. Welcome, Ms. Shabina Zedi. Can we please have your talk?
Hi, good evening, everyone. Am I audible?
Yes, Shabina, you are audible, ma'am.
Thank you. So thank you, Dr. Manushree, for inviting me. And thank you, Miss Dr. Shweta, for giving me a platform where I can share about emotional intelligence. And in fact, I feel that this is such a great platform. I'm sharing with doctors who are of such high caliber, and you people are working with our community. You are uplifting our community, helping us every day in our day-to-day lives. And when I was listening to this conversation, I was listening to the presentations, beautiful presentations by all the doctors. I was reminded of you know 2 years back I got my LASIK done. So I've also written this in my book. So since the book is about moms, it is about the life of moms. So how it is such a hassle to wear specs with small kids, because they'll just snatch it away and all. So that's a wonderful work that you people are doing, the research that you people are doing every day, and it's it's beautiful. So let's start with the session. So since I have to look at the timings as well, so I think you people are very time oriented. So I will stick to the timings, and I hope that my slides are visible to you. Is it visible?
Yes, it's visible.
Yeah. So let's make this session somewhat interactive. We can open our cameras and let's be interactive. In fact, earlier I was thinking that I'm not going to prepare any presentation so that you can just look at me and we can interact. But later I thought, okay, let's make it somewhat colorful. So this is me. Dr. Manushree has already introduced myself, and so I am an emotional intelligence coach. I'm a podcaster, and I've been a trainer. So I'm a speaker, and I've written a book that's about emotions of a mother. So why emotional intelligence? What is emotional intelligence actually? Anybody from the audience? What do you mean by emotions? Let's make it interactive. Anything, you people are already dealing with so many patients. Who else can understand about emotions better than the doctors? So we experience lot many emotions, right, in our everyday life. So we experience happiness, sadness, we experience anger, we are sometimes we are confused. But do we think that there is some bad emotion or there is some good emotion? Do you feel that anger is a bad emotion? At least we can I think we can write in the chat box if you agree or you disagree that we have bad emotions or good emotions. So let's write in the chat box and make it interactive. Do you agree that anger is a bad emotion, or do you agree that being disgusted is a bad emotion? Being fearful is a bad emotion. Is it a bad emotion or not? So I'm getting a few answers. So Manushree says yes, it is a bad emotion. Dr. Aditi says no. Manushree says fear is okay. So yeah, we have our opinions. We think that some emotions are bad, some emotions are good. But let me tell you that no emotion is bad. No emotion is bad, because this emotion is, telling you something. Deep inside, it is telling you something. Okay. So why emotional intelligence? Because our productivity depends on how emotionally intelligent we are. How are we aware of ourselves and our surroundings, or about the people around us? Emotional intelligence is working with people means working with emotions, because each person is a storehouse of abundant amount of emotions. If you just take a note of yourself right from the start of your day until the end of the day, you experience a gamut of emotions, a variety of emotions, and you can note them down. Each time your feelings are different. Each time whatever you feel, what your thoughts are, they are very different from morning until evening or towards the night. Agree or disagree? Does it happen with you? Are you controlling your emotions, or emotions are controlling you? It happens, right? When we are too angry, we will just shout at our kids, or somebody whom we think that they don't have power. So it's so easy. It's so easy to shout at them. So are we controlling our emotions, or emotions are regulating us? Emotions are guiding us. This is a quote by this author that's called Thibaut Meoris, and I read his books, and I recommend you to read his books as well if you want to read more about emotional intelligence. So, there's a famous book by Daniel Goleman which says emotional intelligence is the ability to manage your own emotions. But we won't go it, jargon wise, or we're not going to discuss about the technical aspects. We're going to discuss about how you can develop emotional intelligence, right? Without knowing all the technicalities and without knowing all the jargons about it. So it's about knowing about ourselves and knowing about the people around you. So, what are the characteristics of emotional intelligence? To be aware of yourself. What are your emotions at the moment? What emotions you are feeling? And if you don't know about your emotions, it becomes very difficult to set your goals. It becomes very difficult to go on with your work, because you should know what emotion are you feeling and why it is arising. So as you already study about body, if there is a disease, so you go to the root cause of the disease. Why is that disease arising? What is the reason that disease is present in a patient's body? And when we are working with ourselves, what is the primary key that we need to understand? It is about the emotion or the thought that is going through your mind at that particular time. That's called self-awareness. Self-regulation is how do we control our emotions. Like I gave the example of if sometimes you're very angry with your child, or you just blurt out things, and then most of the times, I think most of us over here are moms or women. So most of the times it happens that we feel guilt. Guilt is an emotion that we usually feel after having gone through that scenario. Social skills is how we manage people around you. How do we regulate? We can't regulate the emotions, but we can understand, and where we can understand how we can react to the situation. We can understand that what is that person feeling. At least we can perceive the feelings. Nowadays, in the times of artificial intelligence, I think it is so important to understand about emotional intelligence, because everything is so artificial. uh, we we're sitting with a person and we don't know about his mood, or about what are the feelings that going on, or what are the thoughts that's going on in his mind, because we're also busy with our phone. He's also busy with our phones. We're so much glued to artificial intelligence, and this is the time of cultivating emotional intelligence. So there is an important aspect of empathy. So as doctors, it is so important to cultivate empathy, because that is going to uh, develop the patient and the doctor relationship. That's going to strengthen the relationship between patient and the doctor. And motivation is just about how do we uh, motivate. That is more about intrinsic motivation. How do we set our goals and how motivated we are? So I'm just I hope I had more time for this, but I'll just be on time, and we will I'll just skip a few things just to be on time. So if we speak about emotional intelligence, and we speak about what are the consequences if we don't have a high amount of emotional intelligence, if we are low on emotional intelligence, that goes on. There are so many workplace conflicts, decision making problems, stress and burnout, because we are not emotional intelligence. We are not aware about the emotions. We're not aware about the thoughts or the emotions that our colleagues have. We're not aware about the thoughts or emotions of ourselves, and that makes us prone to stress. If you ever sat down and you tried to find out what is the reason for your stress, and please you can raise your hands, you can raise the icon if you think that this is the reason, because you're doctors, you're already dealing with your patients, you're already dealing with your families, do you think that time management is the culprit? I mean, you're not able to manage time. Sometimes it happens, we're just running after things and you're not able to manage time. So that is the primary cause of stress management. There is no such thing as time management, says Rory Wadden, and it is only about self management. So how can we, I know you're working with patients, you have your own work, you're managing families. So I'm sure that you must be delegating tasks, but the onus of family or kids, everything falls on women these days. Not these days, but these days when we are managing both the things, we are juggling between our work and our kids. So it becomes stressful, right? Sometimes it becomes stressful. Already we already delegating the task, but sometimes it becomes stressful and we have to deal with the stress. So this is the time management matrix, which is called the Eisenhower matrix. I'm not going in the detail with this. If you want the PPT, I'll share with you the PPT. It's just about how to analyze yourself and know that what are the tasks you can do or schedule, and what are the tasks that you can delegate or just delete. Sometimes we feel that the tasks are important, but they're not so important. How do people manage time? I hope you're not amongst these who manages time like this way. This is just to bring a smile on your face. So what are the strategies which we can follow to manage our emotions? Anybody can become angry, and that's very easy, but to know about anger and to do it at the perfect time, it's very difficult. What are the strategies that can help you to manage emotions? This is the most important part of our session today. uh, as doctors, you must you obviously you know this, that when we are smiling, we generate happy hormones in our body. When we exercise, our lymph nodes, they release the toxins from our body. So how can we manage emotions is by gratitude, showing gratitude, writing about gratitude, writing, counting your blessings, reading books, setting small and realistic goals. Journaling is very important. And since I'm Dr. Manushri's friend, so I'm also going to give you some takeaways you can take from my presentation. I'll give you 2 worksheets where you can work on those worksheets and analyze about the emotions that you feel and how you can work on the emotions. So journaling is a powerful tool. You can journal about if a certain emotion, if you're working on something and you feel that this is the surge of emotion that you're feeling, so you can write about that. You can write how did you feel that emotion, and what was the last time you felt in the same way. So if I speak about being, if I speak about this emotion being jealous, so do you think that jealousy, as I said, though emotion is bad emotion, but let me tell you that when I was not an author, I wanted to be an author. I wanted to write about the book. I wanted to write about emotions. So I had this streak of jealousy, not with all the authors. I did not have any streak of jealousy with the actresses. I did not have a streak of jealousy with the doctors, but I had a streak of jealousy with the author who were female authors, who were moms, who were taking care of, who were balancing their careers. So, and who were, yeah, and who'd written a book. So I realized that this is a positive emotion. This is telling me something. Why I'm jealous of those authors? Because I wanted to write a book. I wanted to be an author. So henceforth, you can also realize where is your emotion taking you. Breathing is an important aspect of emotional intelligence, that is mindful breathing. So we'll have a little session of mindfulness and breathing. So let's relax and close our eyes. Drop your shoulders, your arms by your side, your hands on your lap. Relax. Bring the attention towards your body. Feel the sensation of the air around you. Feel the sensation of the floor under your feet. Feel the sensation of the clothes that you are wearing. Bring awareness to your body. Relax. Now slowly and gradually bring an awareness to your breath. Notice your breath. Is it rapid or slow? Is your breath deep or shallow? Be aware about your breath. We will follow 4-4-4 rule for this breathing technique. On the count of 4, you can inhale 1, 2, 3, 4. Hold your breath on the count of 4. 1, 2, 3, 4. Expel on the count of 4. 1, 2, 3, 4. You can repeat this exercise once more. Pay attention to your breath. As you are inhaling, your abdomen must relax and expand, just like a balloon. And as you exhale, your abdomen must constrict to let the air out. Be mindful of everything around you. If any thought is crossing your mind, let it be there, and gently focus your thoughts to your breath. Inhale and exhale. Gently bring your attention towards your body again. Feel the sensation of the air around you. Feel the ground touching your feet. Feel the emotions. No emotion is bad. When you are ready, gently open your eyes and relax. Thank you. And may you have a wonderful day ahead.
We are actually having one, Miss Shabina. It was actually wonderful, especially the breathing exercise which you took in the last. And all your points also, I am sure all of us would be benefit with all those points. And we will all get back to you whenever required.
So, and please connect with me on LinkedIn. You can also follow my channel that's called Mom's Bookshelf, which is available on Spotify and YouTube as well. Usually my presentations are for 2 hours. The session that I take is for, it usually lasts from 1.5 to 2 hours. But since I have to respect timings as well, and I know this session is dedicated to all the doctors and their presentations. So I was glad to be a part of this session as well. Thank you so much for inviting me.
Thank you, Dr. Shubhina. Thank you. Thank you. Just on one call, you joined this session. It was very nice, kind of you, and we are in fact very, very thankful to you. Thank you so much, Dr. Shabina.
Thank you so much. Glad to be a part of this session.
Thank you. Thank you.
So I think after this session, the next presenters also, they are in a little bit relaxed mode. So they must have done these breathing exercises also. So we have Dr. Divyanjali from Gandhi Medical College, Bhopal. Dr. Divyanjali, please share your screen.
Am I audible, ma'am?
Yes, you are audible. Please share your screen. We are going to start your timer. You can start the presentation, Dr. Divyanjali.
Good afternoon, everyone. I am Divyanjali Tomar. Under the guidance of Dr. Aditi Dubey, I am going to present a case of 21-year-old male resident of Odisha, uh, a worker in coal industry, Hindu by religion and belongs to lower middle class, presented with chief complaint of diminution of vision in right eye since 10 days, appearance of black spot in front of right eye since 15 days. As narrated by the patient, he was apparently all right 15 days back when he incidentally noticed perception of 3 to 4 black spot appearing in front of his right eye throughout the day, which are fixed and not changing its position. This was followed by the observation of diminution of both distant and near vision in right eye 10 days back, which was gradual in onset, progressive in nature. History of sore throat, fever, fatigue, muscle ache, that is flu-like prodrome, 2 weeks back before the onset of visual symptom, which had regressed spontaneously. He had history of similar event in his right eye 1 year back, for which he took treatment and recovered well. History of weight loss and intermittent episode of dry cough over the past 1 year. Patient was alcoholic and smoker. Rest all personal and family history are of no significance. Patient was of thin build. Rest general examination are within normal limit. Visual acuity of right eye was 360 pinhole, not improved, and visual acuity of left eye was 6.6. Anterior segment finding of both eye are within normal limit. Intraocular pressure was normal, and vitreous was clear. On fundus examination of right eye by doing indirect ophthalmoscopy, media was clear. There is blurring of optic disc margin with macular reflex was dull. On general examination, there are multiple round, circumscribed, flat, yellow-white plicoid subretinal lesion of variable size from 1 to 2 disc diameters scattered throughout the posterior pole and extended to equator. A peripheral solitary hyperpigmented lesion presented 2 disc diameter away from the center of macula temporally with surrounding hypopigmentation suggestive of atrophic chorioretinal scar with active edges. Left eye fundus examination are within normal limit. At presentation, there is appearance of two to three yellow-white plicoid-like lesion on OCT. OCT demonstrate macular edema with serious retinal detachment and show hyperreflectivity at the level of outer retinal layer, that is retinal pigment epithelium. After 1 week, the presentation was, there is appearance of new yellow-white plicoid-like lesion. OCT demonstrate resolution of macular edema, but focal atrophy of outer retinal layer, which was correspond to previous hyperreflectivity. OCT of left eye are within normal limit. Chest X-ray revealed bilateral hilar lymphadenopathy. HRCT reveal opacification in parenchyma. Bronchoalveolar lavage reveal inflammatory mucosa and macrophage. Based on the history, examination, and investigation, my provisional diagnosis is presumed ocular sarcoidosis, manifesting with unilateral acute posterior plicoid multifocal plicoid pigment epitheliopathy. Treatment given was IV methylprednisolone 1 gram IV 24 hourly for 3 days. After ruling out contraindication of steroid, oral prednisolone was given 50 milligram for 7 days. Patient called for follow-up after 7 days, and tablet prednisolone was tapered on 40 mg. Local prednisolone eye drop was given 4 times per day. At presentation, there is resolution of both anatomical and visual symptom. Best corrected visual acuity was 6.9 after 3 weeks of presentation. And the patient slit lamp examination was unremarkable. OCT reveal outer retinal and RP disruption corresponding to previous lesion. Based on reviewing the literature, there are studies which showing that AP-MPP can present as early manifestation or can present with sarcoidosis. There are also studies which show that how we can differentiate AP-MPP from other white dot syndromes, or there are studies which shows that role of OCT, FFA, and ICG on ruling out AP-MPP from other white dot syndrome. Thank you.
Judges, please note she has completed well within time.
Yeah, a nice presentation, Dr. Divyanjali.
Thank you.
I would like to ask, what do you mean by plicoid? What is the literal meaning of plicoid?
Ma'am, plicoid are well circumscribed, but not circular or not any, any defined margin lesion. These lesions are either at the level of outer retinal or inner choroidal layer.
Okay.
These are typically appear in peripapillary region or at macular region, spread centrifugally in a serpiginous fashion.
Okay, so then why not serpiginous variety
Ma'am,
of yeah?
serpiginous variety of white dot syndrome is an aggressive presentation, and based on my history, the patient is first of all, serpiginous choroiditis is present in more in females, and serpiginous choroiditis is an aggressive disease. It can progressively lead to CNVM.
Right.
And
Like quite
it is
literally.
also associated with non-granulomatous anterior uveitis. And the lesion are, ma'am, gray-white irregular lesion present at deeper layer. Therefore, it can progressively leads to CNVM.
Right. Like quite literally means plate-like lesions. And any HLA association, or did you go for it? Any typing?
No, ma'am, there were no HLA association in this patient. And there is also no history in family members.
Okay. Which HLA is more associated with this type of lesion? Are you aware?
Ma'am, HLA 27.
Yes. Any other?
Ma'am, HLA B7 and HLA DR2.
Yes, yes. And did you go for any fundus fluorescence besides OCT?
Ma'am, we were planning for fundus fluorescence angiography to differentiate from other white dot syndrome, but the patient was not willing for it. So we have to make diagnosis based on investigation, based on fundus examination.
Okay, what would you have got on FFA?
Ma'am, if it were AP, as we have described, it is a case of AP-MPP. There will be early hypofluorescence followed by late staining. If there is other white dot syndrome, for example, if it is mutes or if it is serpiginous, if it is PIC, punctate inner chorioretinopathy, then there will be early hyperfluorescence followed by late staining. Therefore, we can differentiate in on FFA.
Okay, okay. And what does the black spot in scientific terminology we call it? The patient presented with black spots in front of the eye. So what is that known as?
Ma'am, it can be floaters. Patient can tell if floater involving the macular region, then it
But
can
they
be
were
black.
fixed. They were
Yes,
fixed.
ma'am,
They were
they were fixed. That
really.
means they were not in associated with vitritis. They were fixed. And ma'am, based on my fundus examination, there is a chorioretinal scar. Maybe this is because of that floater.
Okay, what do you mean by a positive scotoma?
Ma'am, positive scotoma is ma'am, positive scotoma is any abnormality in visual field associated with positive scotoma.
No, what madam is asking, what is positive scotoma? And now my next question will be, what is negative scotoma?
Negative scotoma.
Yeah.
Dr. Divyanjali, sorry to please switch on your video. I'll request all the presenters also. So it will be a direct face-to-face communication, although we are online, but still at least we can have this eye contact and during discussion. Please switch on your video.
Yes, ma'am.
So Divyanjali, what is positive scotoma and what is negative scotoma?
Am I visible, ma'am?
Yeah, you are visible.
Yes. Positive scotoma is, can be associated with floaters or cannot be associated with floaters. It is spots of some specific color. I think that is positive scotoma.
How do you record the scotoma? Where do you see the scotoma?
Ma'am, any change in visual field, we can do a Humphrey field analysis to rule out.
Yes. Okay, good.
And Amsler grid test can also be used.
Divyanjali, according to Sun, this thing classification, what is the definition of APMPPE?
Sir, according to Sun classification, APMPP is
Hello, I think your signal is poor.
Yeah, I think.
on clinical
Yeah.
findings fundus examination. This
Hello, can you
Yes.
repeat? Yeah.
Sir,
You could hear.
APMPP can be differentiated from other white dot syndrome based on the clinical picture and based on the depth of the lesion in OCT. If the lesion is more than 500 micron, then it can be differentiated from other white dot syndrome. And in OCT, if the outer retinal layer, for example, RPE and outer choroidal layer are involved, then we can differentiate from Muse and PIC or other white dot syndrome. And these are more common in males 20 to 30 years, and there is no ERG or EOG changes in APMP.
Was there any in the history? Did you ask for any headache, hearing loss, or seizures, and why?
Yes, most commonly APMPP is associated with headache, but in my patient there is no history of headache.
Any hearing loss, any
No, sir,
seizures?
there were no hearing loss or seizures histories.
Okay, okay. Why do they have this headache and the seizures? What is the reason of these symptoms in a patient of APMPPE?
If it can be associated with headache or seizure, and my patient is a presumed case of sarcoidosis, then there can be neurological manifestation of sarcoidosis in my patient, for which seizures and raised intraocular pressure can present, and further disc edema as in my patient can present.
Was a neurological evaluation done of this patient?
Sir, there were no history of any seizures or headaches, so
So it was not done.
yes.
Okay. Okay, thank you.
Thank you, sir.
So the next presenter we have Dr. Asmit Kaur from NSCB Jabalpur. Dr. Asmit, are you there? Dr. Asmit Kaur. Actually, she was there. Dr. Prakha. Dr. Asmit.
Yes,
or...
ma'am.
Okay. Dr. Asmit is there with you, beta?
Ma'am, I'll check. I'll check.
Meanwhile, Dr. Asmit, if he or she is getting ready, can we ask Dr. Prakha to present first? Dr. Asmit?
She's online. She's in the participants.
Online? I don't know. She's not responding. So, Dr. Prakha first.
I'll just call her. Prakha is also there. So
Prakha
she can
is there.
present. She can present.
Okay, Dr. Ashmit is there. Dr. Ashmit, please unmute yourself. As we are already running quite late, so I will request the residents to be ready with their presentation minimized in their desktop. Dr. Asmit, are you ready? Dr. Asmit, we cannot hear you. Dr. Prakha?
Yes, ma'am. Am I audible?
You are audible. So meanwhile, Dr. Asmit is taking care of her microphone and the settings. So we can have Dr. Prakha for next presentation. Judges, please note, Dr. Prakha, please share your screen. Dr. Asmit, you can buy some time to take care of the technical things. Yes, judges, please note, we have the fourth presenter, Dr. Prakha. She's from NSCB Jabalpur. You can start the presentation. Your time has started.
Good afternoon to respected faculty. I am Dr. Prakha, junior resident in NSCB Medical College, Jabalpur, going to present a case under the mentorship of Dr. Padmini Varkhede ma'am. My patient details are name, Saif Ali, son of Mohammad Rafiq, 8-year-old male resident of Gohalpur, Jabalpur, came to NSCB Medical College, Jabalpur with chief complaints of drooping of left upper eyelid since birth. As per my patient's mother, patient has drooping of left eye upper lid since birth, which is non-progressive. There is no diurnal variation, no associated complaints of double vision or any limitation in ocular motility, any pain or swelling. There was no history of any ocular surgery or trauma There was no history of same illness in any of the family member. Birth history was uncomplicated pregnancy and delivery full term. Personal history was normal. Systemic examination was also normal. On ocular examination, visual acuity of both the eyes were 6/6. Position of head was normal. Left eyebrow was slightly elevated. Facial symmetry was normal. On eyelid examination, in left eye, there was ptosis of upper eyelid. On eyeball examination, both eyeballs position, extraocular movement were full and free in all gazes, and Hirschberg test was central corneal reflex. Lacrimal apparatus, conjunctiva, cornea, sclera, anterior chamber, iris, pupil, lens, and tension of both the eyes were normal. Then I did a ptosis examination in which uh, eyelid crease of left eye was absent. Vertical interpalpebral aperture was 4 mm for left eye. Horizontal was 28 mm. Interpalpebral aperture in down gaze of left eye was 6 mm. MRD1 was minus 1 mm. MRD2 5 mm. MRD3 minus 1 mm. Margins crease distance as the lid crease was absent in left eye, so it was not accessible. Then we did levator palpebral superioris function by Burpee's method, which came out to be 7 mm for left eye, and margin limbal distance of left eye was 2 mm. Lid lag was present in left eye. Ocular movement of both the eyes were full in all gazes, and pupil reaction was normal. Bell's phenomena was good. Lag of thalamus was absent. Jaw winking phenomena, shimmer test, Fogan twitch sign, fatigability test, and eye speck test all came out to be negative. These are the photographs of my patient of old, and this was the recent photograph showing that the left side eyebrow is slightly elevated and eyelid crease of left eye is absent. On fundus examination, both eyes fundus examination came out to be normal. My diagnosis is left eye simple severe congenital ptosis with fair levator palpebral superioris function with good Bell's response. My differential diagnosis were blepharophimosis syndrome, which I ruled out as there was no family history, there was no telecanthus. I ruled out Marcus-Gunn jaw winking syndrome as there was no alteration in amount of ptosis with jaw movement. Neurogenic ptosis was ruled out as there was no pupil involvement, and extraocular movement were free and full in all gazes, and mechanical ptosis for my was also ruled out as there was no sign of any lid tumor or lid edema. Treatment advised is left levator resection by Everbook's approach. Thank you.
Very nice presentation, Dr. Prakash. Judges, please note she has completed well on time, and the case is open for discussion.
Yeah, very nice discussion. So I would like to ask, what do you mean by ptosis first and foremost?
Ptosis is the drooping of the eyelid. That is known as ptosis.
Very good. So this is the severe ptosis according to you. So how much, how do you grade the ptosis?
Ptosis can be graded with the help of MRD1. I measured it. It came out to be -1. So I graded
How did
it
you
as
measure it? How did you measure it?
MRD1 is the distance between the upper lid margin in the center to the central corneal reflex. In my case, I was not able to see central corneal reflex as the eyelid was covering the pupil. So I put the scale in upper lid margin and then lifted the eyelid to see the central corneal reflexes. So it came out to be 1 mm because I lifted the upper eyelid. So I noted it as -1 mm.
Okay. Other method of measuring in severe ptosis, how can you measure? Which reflex would be more appropriate? Yeah.
Ma'am, we measured the palpebral fissure height. So it came out to be 4. So it comes under the grading of severe ptosis.
Okay. What is marginal limbal distance?
Ma'am, on extreme up gaze, We measure the distance between the upper lid margin and 6 o'clock limbus. It is used to see the levator palpebral superioris function. It is also known as Pewterman's method.
Okay. The corneal sensations, did you do it?
Yes, I did it, and it was intact in all 5 quadrants of cornea.
Why do we want to do the corneal sensations in case of ptosis?
As after the surgery, there can be a complication of exposure keratopathy. So we should do it prior to the surgery to rule out if there is any signs of exposure keratopathy beforehand.
Okay. This was a case of severe ptosis. So did you get any associated findings along with it?
No, ma'am, there was no any associated findings along with it.
What should be there? What are we expecting to find?
There can be it can be associated with difficulty in deglutination, as we can see in chronic progressive external ophthalmoplegia cases.
No, I want to ask, was there any change in the posture, the something else? How was the chin?
Chin was lifted. He was was lifting his chin to look
Yes, so
properly.
that has also to be mentioned,
Yes,
because in
ma'am.
a severe ptosis and the vision you are saying, how is he
Yes,
able
ma'am.
to see?
Yes,
Yeah.
ma'am. Yes, ma'am.
On the whole, good presentation. Yes, sir.
Thank you,
Sir.
ma'am.
Yeah. So what was the LPS function? How much was the LPS function in this?
Ma'am, sir, LPS function of left eye came out to be 7 mm by Burke's method.
Okay. Okay. And like ma'am said, corneal sensation you have examined. Did you check for how good was the Bell's phenomena?
Yes, sir, Bell's phenomena was good.
Why
We asked the
do you
patient
need
to
to assess? Why do you need to assess Bell's phenomenon?
Sir, after ptosis surgery, there can be a complication which is known as lag of ophthalmos. So, for that, we check Bell's phenomena prior to the surgery.
Okay, okay. And what was the pupillary size, and why is pupillary size assessment important?
So, pupillary size was in dim light, it came out to be 3 to 4 mm. It is important to rule out Horner syndrome or third nerve palsy. In Horner syndrome, we can see meiosis, and in third nerve palsy, dilated pupils will be.
What are the indications to perform neuroimaging studies in case of ptosis?
Sir, in case we are suspecting, suppose we are suspecting neurofibromatosis, so in that cases we can do neuroimaging.
Any other indication?
I'm not aware of that.
And how do you differentiate congenital ptosis from acquired ptosis?
Sir, in congenital ptosis, at first, by history, we can see that it will be present since birth and it will be non-progressive. There will be absent lid crease. There will be lid lag. In acquired ptosis, there will be lid crease present and lid lag will be absent, and palpebral fissure height on down gaze. In acquired ptosis, it will be less, and in congenital ptosis, it will be more.
Why?
Sir, on LP, it comes. The reason is in the pathology. In congenital ptosis, there is LPS dystrophy. So LPS is not able to contract as well as relax. Therefore, when we ask the patient to look down, eyeball goes down, but eyelid is not able to follow the eyeball. So there will be more palpebral fissure height on down gaze. And in acquired cases, pathology is in the LPS aponeurosis. There is dehiscence or disinsertion of LPS aponeurosis. So when we ask the patient to look down, it also goes down, and there is less palpebral fissure height on down gaze.
Okay, okay. Thank you.
Thank you, sir.
Nice presentation, Dr. Prakha. So next we
Thank you,
have
ma'am.
Ashmit. Are you ready?
Yes, ma'am. Are you here?
Yes, we can hear you. Sir, she is Dr. Asmit Kaur, the third presenter. She is presenting from Jabalpur, NSCB Jabalpur.
My screen is visible, ma'am.
Yes, your screen is visible, but your presentation is yes. Your presentation.
Is my screen visible?
Yes, it is visible.
Is my screen visible?
Yes, your screen is visible. You can start your presentation. We are starting the timer.
Yes, ma'am. Good afternoon to all the respected judges and the audience. I, Dr. Schmidt, third year junior resident from NSCB Medical College, Jabalpur, presenting my case under the guidance of Professor and Head Dr. UP Dipankar sir. My patient name is Gyanchand Airwar, 21-year male. He is from Damo, Jabalpur. He is graduated in pharma by occupation. Came to the OPT with the chief complaint of diminution of vision in both eyes in 6 years. As per my patient, he was operated all right 6 years ago when he noticed gradual diminution of vision in both eyes, which is gradual in onset and progressively in nature. It is not associated with the headache, pain, redness, and any other ocular symptoms. There is no diurnal variation. He did not get any consultation for this condition over the past 6 years. Recently, he has felt more difficulties while doing daily chores, which prompted him to come to NSCB Medical College. Past history, trauma, allergic, drug history, and the prior plus surgery are not significant. In addiction history of tobacco chewing and smoking since 3 years. No history of diabetic hypertension and never suffered any other chronic disorder. In family history, patient grandmother and his father had a history of similar complaint. Systemic examination were done. Patient were conscious, cooperative, oriented to time, place, person, and the vitals are within normal limit. Ocular examination were done in both eye. Unaided vision are 636, which is not improved with the pinhole, neither with the refraction. Near vision is N12, not improved with refraction. Color vision are defective in both eye. Contrast sensitivity decreases. Amsler grid test metamorphosis are present in both eye. Anterior segment examination was done within normal limit. In fundus examination, both eye medias are clear. Optic discs are normal in size, shape, color, margins, and vessels. CD ratio are 0.3. Retinal vessels are normal. Retinal background in both eye, a hypopigmented lesion present over the macula of size 2 disc diameter, shape round, color was dirty yellow, and margin are shape and sharp and defined with pigmentary changes in periphery of the lesion. Rest of the peripheral retina was normal. Fovea reflex are absent. This is the fundus picture of both eye. As we see, there is on fovea, there is a hypopigmented patches. All rest of the retina was normal. This is the OCT picture of both eye. As we are seeing, there is a thinning of retinal layer and the fovea, and there is a focal choroidal excavation. This is the perimetry of both eye. There is no significant finding present. Blood investigation was done within normal limit. My probable diagnosis was bilateral best vitelliform macular dystrophy in atrophic stages. Treatment given was conservative management, cessation of smoking, sunglasses for phototoxicity, and avoid retinotoxic gel. Medical management given was lutein and zeaxanthin substitutes to protect the macula. Differential diagnosis was Stargardt disease, which is ruled out because in Stargardt disease there is a typical bronze bitten appearance in age with the irregular margins. Age-related macular degeneration is ruled out because it is a late age phenomena and in which the lumpy bumpy appearance was seen. In the central serous retinopathy is ruled out because there is a no family history in CSR and there is a ring-like reflex present and a serious fluid deposition in the subretinal space. Chloroquine retinal toxicity was ruled out because in which the bull's maculopathy was present and there is a no history of chloroquine drug intake. Macular hole was ruled out because there is a no retinal layer dehiscence in the OCT. Other investigation were electrooculogram, leptoretinogram, fundus fluorescence angiogram, fundus autofluorescence, genetic testing, screening for parents and the siblings. On patient, teachers for the Amsler grid home monitoring and asked to return immediately if changes noted in the vision or Amsler grid. On follow-up, if CNV is found, treat promptly. Thank you.
Good, nice presentation, and she has presented well within time. Now the case is open for discussion. Please stop sharing the screen.
Nice presentation, Dr. Asmit.
Thank you.
What do you mean by metamorphopsia? You said it is metamorphopsia was there in the patient. What do you mean by that?
It is an abnormal perception of abnormal perception in which the target object is distorted in shape and size.
Right. So on Amsler's grid, what do you advise the patient? How should he go about it, and what he should find when he should report?
We teach the patient to look by the Amsler chart put at the 33 centimeter distance on the on the best near reading distance, and close the one eye by one hand and one eye examination at one time, and focus on the central black point, and look about the lines horizontal and the vertical lines which is distorted or not. If any area found scotoma or any distorted line is found on regular follow-up, then comes immediately.
What are the different stages you know of this disease?
Ma'am, there is a 6 stages. There is a pre-vitelliform stage in which there is a no fundus finding and visuals are almost normal, but in EOG is abnormal. And second is a vitelliform stage in which the typical yolk appearance is found on the macula, and vision is almost normal. In third is a pseudo hypopian stage in which the your yolk is settling down and there is a upper clear area and there is a down uh, yolk settling down. It's called the pseudo hypopian stage in which also the vision is not more deteriorated. Fourth is the vitellar eruptive stage in which the lipogen deposition is melting out and there is a vision decreases and it looks like a scrambled egg appearance. And fifth is atrophic stage in which all the materials are absorbed and there is a vision deteriorated. And sixth is a CNV develops and chorioneovascularization membrane developed in the 6 days in which the vision deteriorated less than 660 or worse.
So how will you manage the 6th stage where choroidal neovascularization develops?
In choroidal neovascularization, we provide the patient the anti-VEGF injection, vascular endothelial growth factor anti-VEGF injection, and we can go for the photodynamic therapy and the focal length.
Okay. And what do you find in the EOG? EOG is the differentiating between Stargardt's and this. So what are the findings?
In EOG, we found the Ordine ratio. It is the ratio of light peak and the dark.
How much is
less than 1
should be?
Less than 1 point.
Okay. That's it, I think. Sir?
Very nice presentation, Dr. Asmit. You have nicely explained. So how do you treat these patients in the initial stages? Like ma'am asked, when you have CNV, it's rightly said anti-VEGF. But before that, what are the different modalities which can be tried to manage these kind of
In
patients?
initial stage, if there is no much more vision deterioration, we ask the patient to comes for the follow-up regularly for the vision and the Amsler grid checkup and the other fundus examination and all. And if there is patient feeling any problem in seeing objects, then we can provide the low vision aids in which we can provide the convex lens magnifiers to read or to do any or spectacles modulated convex lens modifier to ease the work.
Do you know of any recent advances in the treatment of Best disease?
No, sir, I don't have any
You
idea.
heard
But
about
the photodynamic therapy is,
photodynamic
photodynamic
therapy is
therapy
one.
and the anti-VEGF used in the CNV cases.
This is one of the diseases where a lot of research is being carried out.
Yes, sir.
Gene therapy in Leber's hereditary optic neuropathy and Best disease. Then there are also, you must read about this thing, proteasome inhibitors, which are being tried, and there are publications to that effect, right? Must read it.
Yes.
Okay,
Yes.
thank you.
Thank you, sir.
Dr. Radhika, please share your screen.
Am I audible, ma'am?
Yes, you are audible. Please share your screen.
Yes.
So this is the second last presentation. Judges, please note we have one more presentation. That will be the last presentation, and the results compiled by the judges to be sent to Dr. Neetu. Dr. Radhika, please share your screen. In case you have any difficulty, but you have not mailed the presentation to me. Otherwise, I would have run from my end.
Ma'am, I'm just sharing you the screen.
Okay.
Ma'am, do I need to switch off my video to share the screen?
No. You just, there is a green icon at the bottom of screen. It shows share screen. You just have to do that and open your presentation.
Yes, ma'am.
Have you found it? I'll request the next presenter also to be ready with the presentation.
See, open your presentation, then click on the share screen, then click on your presentation. Okay.
Yes, sir.
And can we have Nikita Ahuja if she is ready before Radhika?
Dr. Nikita, are you ready? And meanwhile, Dr. Radhika, please email your presentation to me so that I can run from my end. Actually, I've already asked these presenters, so everyone else have mailed.
Yes,
Nikita. Dr. Nikita, first you have to mute all other devices that you are using. Please open the window in only one device.
Ma'am, am I audible now?
Yes, Nikita, you are audible. Please share your screen.
Yes, ma'am.
And meanwhile, Radhika, in case you have any difficulty, please send your presentation to me. I'll run from my end. Not an issue.
This one. Can you see my presentation now?
No, we cannot. Judges, can you see?
No.
No.
We cannot see better.
Now it's started.
Yeah.
Yeah, we can see it now.
Good evening, ma'am. I'm Dr. Nikita Ahuja from All India Institute of Medical Sciences, junior resident of ophthalmology, and I'll be and my mentor is Dr. Vidya Verma, ma'am. And today I'll be presenting my case with alkali burn in a pediatric case, taming the old foe. A 3-year-old child presented to us with history of Lyme entry into a right eye one day back, with chief complaints of diminution of vision, severe pain, excessive tearing, and swelling of both upper and lower lid since one day. Initial treatment was provided at a local hospital, but before her presentation to AIMS, Bhopal. The non-ocular examination of the right eye, visual acuity was perception of light with uncooperative for projection of light. Eye movements were full range in all the quadrants. Upper and lower edema was noted with Lyme particles embedded in the upper and lower cornices. On anterior segment examination, there was total corneal opacity with more than 50% limbal ischemia, Roperol grade 4, and full limbal and conjunctival involvement indicating DUA grade 6, along with scleral ischemia, as we can see in the image provided here. On further examination, the posterior segment was within normal limits. Left eye examination was unremarkable and systemic investigation found no pathology. So our approach towards the management was, first and foremost, pH is very important in such cases. So we did Popis irrigation with 500 ml normal saline with sweeping of the faunaces twice daily. On targeted topicals, we gave lubricants like ointment, lacrygel, carboxymethyl cellulose, broad spectrum antibiotics, moxifloxacin, autologous serum, vitamin C, and nitrobetnisol was given with tapering doses. On systemic drugs, we gave broad spectrum antibiotics, cefazolin twice daily with anticollagenase, multivitamin syrup, and tablet Limcy. As debridement is imperative in such cases, so to allow proper revitalization and to remove the nidus for continued inflammation, always double eversion of lid is to be done to check for reservoirs. And we should know when to stop it when visible bleeding spot and excoriation is present. And on the day of presentation, even after irrigation, few lime particles were still remained lodged. So when the patient was taken under GA for AMT, few lime particles, faunaces were cleaned off before placing the graft. As we can see the clean faunaces in the later picture. Surgical management is mandatory in alliance with anesthesia and pediatrics. We did right amniotic membrane transplantation under general anesthesia on day 2 of admission with follow-up expiration under sedation after 2 days of AMT. As we can see here, there is AMT, there is amniotic membrane and bandage contact lens in place along with symblepharon, early symblepharon formation, congested conjunctival chemosis, along with improved visibility of lens and iris diaphragm, indicating Roper Hall grade 3 and Dua grade 5. We did AMT in acute phase so as to restore the ocular surface for rapid healing and limbal cell function restoration so as to prevent scarring in the later sequelae. On further, after 1 week, we did lateral tarsorrhaphy for salvation of visual acuity and for restoration of the corneal integrity. Patient was discharged with aforementioned treatment 1 week after the surgery, and advice to follow up was given, which he did with improved vision to hand movement close to face. She was planned for allo sled, but patient was lost to follow up. So the carry-on message we get is chemical injuries required immediate and aggressive management with early surgery, necessary to promote revascularization and limbal stem cell population, and late sequelae might include bands, symblepharon, scarring, and excessive cicatrization. Prognosis depend upon early intervention and extent of injury. Thank you.
Please stop sharing your screen. Judges, please note she has completed well time.
Yeah, nice presentation, Dr. Nikita again. How did you come to know that this was a Lyme injury first and foremost?
Ma'am, we found lime particles as patient gave us the history that tuna packet got exploded and got entered into her eye. Also, we could see lime particles embedded in the faunaces.
Okay, so that has to be mentioned that the parents gave the history. The patient will not, I think, give you the history. He's a 3-year-old kid. So the parents gave the history that should be incorporated of Lyme injury. You directly don't come to know that this is a Lyme injury. Right? And the cornea, how was the cornea of the eye? What all findings did you get besides opacification?
So ma'am, there was total opacification with stromal involvement and stromal edema.
Yes, so that also has to be mentioned, and you should draw how much you are thinking the edema is, so that when you follow up, you come to know the edema is subsiding. The AMT, you took the AMT from where?
Ma'am, we in our institute we ordered AMT on request, so it was delivered to us 1 day after. So after the second day, we posted the patient under GA for this, and we.
Where is it preserved, AMT? How is it preserved, in which media? Are you aware?
Ma'am, it is preserved in glycerol and DMSA. The
special name for that media? Like we have for the corneas, any media?
King George, it's something like King George. I don't exactly remember the name.
No, it's Delbocque's media. Okay. Then like vitamin C, what dose did you give vitamin C? You said you were giving vitamin C.
Ma'am, there is in such cases of chemical burn, there is ciliary body damage. So when there is ciliary body damage, the ascorbic acid secretion is decreased and it cannot reach to the anterior chamber. So in those cases, collagen formation, keratocytes cannot form enough collagen.
Dosage. What dosage did you give?
Topically, for topical vitamin C, we give 10% with 4 to 6 times daily, and systemically we give vitamin C. In as she was a child, she was 3-year-old. Usually, we can give 500 to 1,000 milligram with 4 to 6 times daily the tablets. But she was a kid, so we had to give 500 mg.
Topically, we give vitamin C.
Yes, ma'am. In this case, we gave topical vitamin C. We reconstituted it.
Okay. Then Simlifron was there. So during the surgery, anything was done for that, or just the graft was placed and BCL was applied?
Ma'am, when we took the patient under GA, the Simlifron was there. So we took glass rod and with the help of the glass rod, we tried to break it.
So you were able to do that,
Yes.
as it was a second day only, so it broke.
Yes, ma'am.
Okay. Oh, thank you, sir.
Yeah. So after the initial management, what are the long-term effects of alkali burns?
Sir, to start with, it could lead to dry eye disease, limbal stem cell deficiency. It can lead to glaucoma, as there is trabecular meshwork and ciliary body injury in this. So when the trabecular meshwork is injured, there is release of prostaglandin. So it could make the IOP rise and make it could lead to glaucoma. Then it can lead to cicatrization, scarring, and infection can also take place if preservative free eye drops are not, as preservative free eye drops are mostly suggested in such patients, because if preservative is used, it could lead to keratitis and epithelial toxicity. So it may lead to infection if not properly maintained on preservative free drops. Then yes.
And if amniotic membrane is not available, then how can you manage this patient surgically?
So if amniotic membrane is not available, then first to start with, we can apply bandage contact lens to avoid the windshield effect of the lid. So it adheres it adheres the epithelium and stroma. It provides adhesion of epithelial and stroma, and it it prevents rubbing off from the lid. So BCL could have been done if not AMD, and there are various surgical options like in acute phase, tenoplasty can also be done. Like we debride the necrotic tissue and we remove all the nidus present, and this also from the limbal part and the scleral part. Then we take tenons and we stick it to the limbal side. But it may in future it is not phenotypic epithelium which we are providing.
What about limbal stem cell transplantation?
Yes, limbal stem cell transplant can also be done. It can be in acute phases. Usually allogenic alloslet is performed to reduce the chances. And autolimbal cell transplantation can also be done, but in chemical injury cases, there is deep neovascularization, deep stromal neovascularization. So chances of rejection are also high.
What are the collagenase inhibitors you know of?
So for collagenase inhibitor, we can give doxycycline. Doxycycline, apart from its anti-bacterial action, it masks the zinc site which is required for the enzyme to act. So it masks the zinc site and it inhibits the action of collagenase. So doxy we can give.
Anything else? Okay, thank you.
Thank you, sir.
Thank you, Dr. Nikita. Very nice presentation and discussion. Dr. Radhika, are you ready with your case?
Yes, ma'am.
Okay, please share your screen. Very good.
Ma'am, is it visible?
Yes, it is audible at present.
Good afternoon, respected seniors. I'll be presenting my case series on unveiling the mask, neuroophthalmic conditions that mimic glaucoma. Neuroophthalmic conditions can present with disc changes which are suggestive of glaucoma, and their prognosis can be improved by preventing delay due to unnecessary treatment with anti-glaucoma drugs. Hereby, we'll be going through a series of 4 patients who were misdiagnosed as glaucoma elsewhere, but our careful evaluation led to the salvation of their visual acuity. Case 1 was a 53-year-old male with a positive family history of glaucoma, came with complaints of occasional floaters. He was a known hypertensive with a positive history of stroke. On examination, vision was 6/6 in both the eyes. IOP was within the normal range. The fundus revealed a CDR 0.8:1 with NRR thinning. So based on these findings, he was diagnosed outside as a case of normotensive glaucoma and started on eye drop timolol. We did an OCT RNFL which showed a large cup, so it can be due to physiological cupping also. Hence, we advised for a visual field analysis which showed a typical contralateral inferior quadrantanopia. So this was suggested for non-glaucomatous visual field defect. Hence, after neurological consultation, we advised for an MRI which revealed a left parietal region calcified granuloma correlating with medications and is following up in neurology. Case 2 was a 39-year-old male with no family history of glaucoma, came with decrease in vision right eye more than left eye. On examination, vision was counting finger in right eye and left eye 6/24. IOP was 24, but the patient also had a thicker CCT, so the corrected IOP was within normal limit. Right eye RAPD was present and along with disc pillar, in left eye CDR 0.4 with temporal pillar. So the findings were not correlating with each other. Hence, we advised for a visual field analysis, which showed a complete right eye. It was not possible due to low vision. In left eye, there was a complete scotoma denser on the temporal aspect. Again, this was suspected of some other disease. So after getting an MRI done, there was a mass effect on the proximal ends of both the optic nerves, right more than left. It can be due to a post-fixed chiasma, suggestive of a pituitary macroadenoma with a suprasellar extension. Hence, the patient was referred to endocrinology. Case 3 was a 42-year-old female with a family history of glaucoma. She came with complaints of ocular pain and headache from 6 months. On examination, vision was 6/6 in both the eyes. IOP again was on the higher side, but the corrected IOP was within normal limit. On fundus, she had bilateral light disc pillar present. Based on these findings, she was diagnosed outside as glaucoma and started on eye drop brimonidine plus timolol. The disc findings were not typical of as we see in glaucoma. Hence, after getting a visual field done, we saw there was an incongruous contralateral homonymous hemianopia in both the eyes. So it was respecting the vertical meridian. Hence, it was a neurological visual field defect. We advised for an MRI. There was a right temporal lobe lesion, likely glioma. This was again correlating with our visual field findings. Our last case was a case for 55-year-old male with no family history of glaucoma, came with decrease in vision bilateral eye from 3 months. On right eye 4, left eye 6/9. IOP was within normal limit, but there was an increased cupping with NRR thinning. Based on these findings, with IOP within the normal range, was diagnosed outside as a normotensive glaucoma and started already on eye drop travoprost HS. The OCT RNFL revealed RNFL defects, but on visual field analysis, it was a completely different picture. Right eye, there was a complete scotoma, and in left eye, there was a temporal hemianopia respecting the vertical meridian. So this indicated us to get an MRI done for the patient. And on MRI, there was a lesion, non-functioning pituitary adenoma involving both the optic nerves, right more than left. And the patient was discontinued anti-glaucoma medications and referred to endocrinology.
Time is up. Please summarize. Your time is up. Please summarize.
Last slide. Our take-home message is not all cases are glaucoma. So any patient with decreased central vision, color vision defect, RAPD or disc absent, disc hemorrhages, disc pillar more than cupping, vertical VFD is respecting the midline, vertical midline, and poor disc to field correlation, we have to suspect any underlying neuroophthalmological disorder and get a complete evaluation done before starting anti-glaucoma medications. Thank you.
Nice presentation, Dr. Radhika. What was the pupillary response in all these cases, 4 cases? Did you record them? They were normal in all of them?
No, ma'am. In one patient, their RPD was present in one eye, and in other eye, it was sluggishly reacting to light. In another case, there was a sluggish reaction in both the eyes, and in rest 2 cases, it was normal.
And the color vision?
Color vision, ma'am, it was slightly abnormal in all the patients.
So you have to mention that, because all these will point out not only the cupping you should see, you should correlate clinically what are your findings. And in favor of that, you can go for the visual field analysis and the neurological opinion thereupon. Because all these findings will club together, and then we can have a DD. This can be this or not.
Yes, ma'am.
Okay. Thank you.
Thank you.
Yeah, you mentioned that the absence of disc hemorrhages, right?
Sir.
So, when do you find disc hemorrhages in case of glaucoma? It is
Sir,
mild glaucoma, moderate glaucoma, severe glaucoma, advanced glaucoma. When do you find disc hemorrhages?
Progressive cases of glaucoma, like especially when there is progression, then we find disc hemorrhages. In normotensive glaucoma, it is very typical to see disc hemorrhages. And also in POAG, primary open angle glaucoma cases also, we can find disc hemorrhages very common.
Good. But what type of? It is in mild glaucoma or advanced glaucoma?
So
You very
advanced.
nicely mentioned it is in advanced glaucoma, but
Advanced.
and progressive. In mild or advanced?
Advanced, sir.
No, better. It never happens in advanced glaucoma. It is a sign of progression. It occurs in mild to moderate glaucoma. Okay. And what you mentioned was, now let me ask you something about the field only. What does in the visual field, what does 20 dash, this thing, 30-2 and 24-2, what does it mean? What does 24 means? What does 2 means?
So that it means that how much area we are visualizing from the center 24-degree of the vision on all the sides. Or is it from central fixation? It is 30-degree, and the gap between 2 points is 2-degree. 2-degree, the difference is there between 2 points.
So what is the visual? Yeah.
That is
So yeah, please carry on.
To diagnose if we are suspecting some neurological disorder and any underlying neuro-ophthalmological condition, we generally advise for a 30-2, and so that we can get a wider field and to see the progression if there are some defects, and to see if the central area is involved, then we go for 4-2.
And what will be the color of neuroretinal rim in neurological causes, where cup is quite deep and enlarged, versus glaucoma patient? Will you find any difference in the color of neuroretinal rim?
Yes. The pillar is more than cupping in neurological disorders. So in that way, we can get a hint whether it is glaucomatous or whether it is any underlying neurological disorder. Also in toxic neuropathies and in other neurological like optic neuritis, we find pillar is there more than cupping.
So in glaucoma, even in advanced glaucoma, the color of the neuroretinal rim, howsoever thin it may be, it remains pink compared to neurological causes. Which is more important, cup disc ratio or rim disc ratio, and why?
So there are different methods to assess the CDR. So we usually do a cup disc ratio, but the rim disc ratio is even more accurate. We go for DDLS, and in that we there are 10 stages, and we measure the thickness of the rim compared to the size of the disc. So that is more accurate.
Okay, thank you.
Thank you, sir.
I think we have completed.
Yes, sir.
Any
Yes, sir,
more?
we
Any
have
more?
Fourth and
completed.
last now.
Any
Sir,
more
हो गया है?
participants? Yeah.
No, sir. 6 participants only for this session. So I would request the judges, Dr. Bhalla sir and Dr. Stuti madam, to send the judgment sheet to Neetu so that we can compile the results and announce it. Meanwhile, we are preparing the results. We are grateful to CIPLA for giving opportunity to WOS to conduct such programs online. And we have a CIPLA sponsored talk. Dr. Manushri, are you there? So Dr. Manushri will be speaking on the dual polymers.
Am I audible, ma'am?
Yes, you are audible. Go on the play screen. On the above, you will see a play button. Go above.
Is my screen visible?
Yes. Yes.
So we'll be talking about the dual polymer advantage in the management of dry eyes. As we all know that dry eye is a very common condition. It is that 1 in every 4 patients who present to us in our ophthalmic clinics have dry eye. And these are the basic steps in which we manage a patient of dry eye. First, we educate the patient. We try to give a holistic approach, dietary improvement, identify the potential modifications which can be done in lifestyle, and then we give prescribe ocular lubricants to the patient. Another very important aspect is lid hygiene and warm compression,
Hello,
which we
yeah, Dr.
generally
Neetu, I've sent you the result.
then we have
Okay,
non-preserved
can I
ocular
log out now?
lubricants.
Hello?
Sir, I think
Okay,
need to, ma'am.
sure. Okay,
Yes,
thank you.
sir. Sir, I have. Sir, she has
No,
sent the
thank you.
result.
It
Thank
was
you so
really
much, sir.
nice
Thank you so much.
participating. Please share if you have any pics also taken.
Yes, sir. Yes, sir. I'll share.
Right. Thank you so much, Dr. Neetu.
Ji, sir. Thank you so much, sir.
Thank you. Thank you. Bye.
So, after dealing with the general condition and the lid hygiene, we can use non-preserved ocular lubricants or moist chambers, which were the earlier treatments which were frequently used. And if there is any associated lid infections that have to be treated, then we can move on to advanced drugs if topical lubricants alone are not acting, like topical corticosteroids or topical secretagogues, and immunomodulators, and topical cyclosporins, anti-inflammatories, and recently topical LFA1 antagonists are also being used. Along with the systemic tetracycline has proved to be important in the management of meibomian gland diseases. Then, after this treatment has been done, next step for increasing the treatment for severe dry eye patients could be oral secretagogues, then autologous serum, which can be converted into eye drops, therapeutic contact lenses, soft bandage lenses, and rigid scleral lenses. And finally, the most advanced cases or non-responding cases can be treated with topical corticosteroids for longer duration, amniotic membrane grafts, especially if there are associated Sjogren syndrome or other diseases like that. Then surgical punctal occlusion can be used, and other surgical approaches like tarsorrhaphy and salivary gland transplantation. Then artificial tear remains the mainstay of therapy for the management of dry eye disease. The evolution of tear substitutes have been first generation a saline-based substitute, which usually had preservatives like DAK. Then natural and synthetic polymers came, which include methyl cellulose derivatives. Then third generation included hyaluronic acid, and the fourth generation finally includes the lipid components as well. So most commonly used viscosity enhancing agents are HB guar, polyethyl glycol, sodium hyaluronate, polyvinyl alcohol, HPMC, and CMC. Now, how do these newer adjuvants, which we can call act? That is the PEG and HB guar. HB guar is pH sensitive, and at a higher pH of 7.8, which is present in dry eye patients, it forms a reversible crosslink with borate, resulting in a gel matrix with mucin. The gel layer spreads over the cornea and the conjunctiva. A portion of HB-guar polymer molecules binds preferentially to the hydrophobic sites of the damaged surface epithelium cells. So the damaged cells are targeted more. It provides lubrication, retards tear film desiccation, and enhances tear film stability, serves as a natural bandage to allow repair of the surface epithelium. It improves retention time of the formulation and also provides increased relief from the symptoms of dry eye. The mucomimetic action of this drug helps in securing the mucin layer, thus maintaining tear film and protects the corneal epithelial cells. So there is a triple action of this molecule. Sodium hyaluronate, it is a naturally occurring substance in nearly all connective tissues. In eye, it is found in the vitreous but in lower concentrations. Hyaluronic acid is a natural component of tears with a proportion of that on the ocular surface being synthesized by the corneal epithelial cells. Sodium hyaluronate, how it helps in dry eye. It effectively binds water and resists dehydration, promotes epithelial wound healing, and its viscoelastic property enhances residence time. How can hyaluronic acid effectively bind to water? It has a greater capacity to hold water than any other natural synthetic polymer. 1 gram of hyaluronic acid can hold up to 6 liters of water, as seen in vitro. Hence, evaporation of water from hyaluronic acid eye drops is slow and the beneficial effects are prolonged. How does hyaluronic acid promote corneal wound healing? The fibronectin, as we know, an extracellular matrix protein, stimulates epithelial growth, cell migration, and accelerates corneal wound healing. HA binds to fibronectin. The HA fibronectin complex enhances wound closure and helps wound healing. Now, what is viscoelasticity, which we talk about frequently? The viscous properties of a liquid plus elastic properties of a solid together form the viscoelastic properties. Viscoelastic property of hyaluronic acid. During blinks, the shear stress causes the molecules of HA in a solution to align with one another. As a result, the solution becomes elastic and relatively non-viscous and spreads easily over the surface of the cornea. The combination of all these three, that is polyethyl glycol, HB-guar, and sodium hyaluronate together, will have synergistic benefits on the ocular surface. pH gelling with HB-guar provides prolonged lubrication, acts as a mucomimetic, accelerates corneal wound healing, and improves water retention due to hygroscopic properties. The dual polymers formulation benefits can increase tissue hydration and lubricity. It may also protect the ocular surface from damage associated with dry eye. Hyaluronic acid and HB-guar may protect the ocular surface from damage associated with dry eye. It improves tear film stability better than individual polymers. Now, coming on to some clinical studies which have seen the benefits of this combination. A recent study done on 50 patients in which the TBUT was noted, and it showed significant improvement of TBUT within 60 minutes of installation of this combination drop. Immediate effects of this combination on tear film stability was also studied, and it was noted that there was a significant improvement in tear meniscus height within 60 minutes of installation of this combination drop. 1/3 of the patients undergoing cataract surgery experience dry eye symptoms, which we can hear most often in our post-op patients. Symptoms may be combined with a reduced tear film stability and an increase in ocular surface staining, which can persist up to 3 months, even after 3 months of surgery. Improvement in ocular discomfort with HPG and HA eye drops post-cataract surgery was also studied. and it was noted that this combination significantly reduced post-cataract surgery ocular discomfort. Improvement in tear film stability with HPG and HA eye drops post-cataract surgery was noted, and this combination reduced post-cataract surgery tear film instability. The effects of hyaluronic acid, HPGO, or artificial tear solution was also noted to have protection on corneal epithelial cells. The effects of this drug was noted on the recovery of corneal epithelium, and it was seen that cells associated with this formulation exhibited greater cell membrane barrier function, greatest tear, and then those associated with single polymer formulations. The impact of hyaluronic acid containing artificial tear products on reepithelialization was noted in vivo on corneal wound model, and it was noted that this group compared with other HA containing artificial products showed greater debridement uh, of inactive or dead tissues. The impact of hyaluronic acid containing artificial tear products on reepithelialization was also studied on in vivo corneal wound model. The percentage area of reepithelialization was highest with HPG HA treated corneas versus those treated with other hyaluronic acid or mono drugs. So the take home message is the dual polymer tear substitutes provide increased tissue hydration and lubricity and protects the ocular surface from damage associated with dry eye. It helps in maintaining the tear film stability post cataract surgery, provides significantly greater cell viability than the other individual single polymer formulations on the desiccated corneal epithelial cells. It also helps in reepithelialization of corneal wounds by accelerating wound healing process. So this was in a nutshell why we should be using this dual combination.
Thank you, Dr. Manushree. With this, we come to the end of our exhaustive session of WOS resident program, MP chapter. All the residents were fantastic, and it was good to see such a variety of cases. And if other residents had attended, this was a, I think, coverage of the whole course, and it was a good revision for their practical exam. So for the results, I would now like to call upon Dr. Vinita Ramnani Madam, who is Scientific Committee Chairman of MP State and is a very active WOS member. And now the stage is yours, Dr. Vinita. You can announce the results.
Thank you so much, Dr. Shweta. Ideally, you should do this because you have done a lot of efforts for arranging such a wonderful program, scientifically crafted. And I should congratulate all the PGs. I think all are winners because they all have presented so well. Even I should congratulate the judges that they are there from 10 a.m. today on a Sunday, and they have judged each and every one. And but anyhow, we have to come to a conclusion of getting one out of all. So thank you for giving this honor to me. I thank WOS for this. Any guesses? Like, because we have many PGs from Bhopal, Indore, Rewa, Jabalpur, Gwalior. So any guesses like who is the winner? Probably my heart is for the Bhopal. So the winner of today's PG session is Purva Lal from People's Medical College. So congratulations, Dr. Purva, and also to your mentors. Thank you. Thank you so much.
Dr. Harpal Singh is her mentor. And in fact, all the residents, it was just a margin of 0.5, 0.5, 0.5, 0.5. And everyone was good. Everyone was good. And I would like also to thank the moderators who had executed the session so nicely, communicated with the judges, and the judges also spared so much of time, asked so many questions to the residents. They were so polite and humble, guided them wherever they were wrong, and in fact all the residents will take up the points that were suggested by the judges.
So Purva has joined. So Purva, thank you for showing your face and congratulations to you and Dr. Harpal.
Thank you so much, ma'am.
So with this, we come to the end of the session. Thanks to everyone. Thanks to Sipla. Thanks to the IT team, Bhageshwarji, Sharik, for giving us this platform. And thank you, everyone. And see you soon in the next chapter. Thank you. Thank you so much.
Shweta, for being instrumental for organizing such a wonderful MP State PG chapter. Thank you so much.
Thank you, Prantal Namita.